for your emotion and spirit. Yeah, ladies and gentlemen, dear colleagues, welcome to this international conference on climate change and pandemics. It is a really great honor to welcome so many renowned international experts in this field. And on our campus, the Neuenheimer Feld, and it's also my great pleasure to congratulate to this multi-birthday, because it's the 60th birthday of the Institute of Global Health, but also this year, the 70th birthday of the leading scientist here of the Congress, Professor Sauerborn, and also, I guess, the 90th this year of the founding director, Professor Diesfeld of the Institute. So congrats from the side of the hospital, and also special thanks to the organizers, to the colleagues Berlinghausen and Röckloff. It's great that again we have these meetings in person, not only via the WebEx conferences. And I think it's time, it's not only timely and interesting, but it's of outstanding importance to have this topic as an international conference in these days. Because climate change and pandemic are the topics that fundamentally influence our lives and also our health. And as a professor of medical microbiology by training, I know that climate change may boost so many microbial threats because it's a very important component of transmission routes. And a couple of years, the idea came up of the One Health approach, which initially in my field was considered as a matter of human medicine and veterinary medicine, but now a very important and essential third component, climate change, is a very strong part of this topic. And I think this is the way really to challenge and to tackle such a global threat to humans, to health. So, but before I come back to this topic, let me say a few words about the University Hospital. And we have heard that the University of Heidelberg is the oldest one in Germany and one of the internationally very old ones. And also, this is also true for the University Hospital. But this certainly is not an achievement of our generation. The achievement of our generation is that the university, and especially and also the University Hospital, are among the top leading institutions internationally. So today, in on this campus, in the University Hospital, we are more than 30,500 co-workers, means 2,000 medical doctors, 3,000 scientists, 3,000 nurses, 80 clinical departments, and remarkably, we care about 100,000 inpatients per year and 1.2 million outpatients per year here on the campus. And this is, I think, an outstanding achievement of the personnel that are very much dedicated and specialized in excellent medicine. We have the simple mission to provide the best care to our patients and certainly to develop an even better care in the future. And to accomplish this, we have established here on the campus excellent infrastructures. Many of them are in fact common infrastructures with the university or with the German Cancer Research Institute and other institutions. Coming back to the topic of your Congress, I believe that climate protection is in fact health protection. And when and most university hospitals are very much focused on care in the OR, in intensive care units. But today we consider our tasks starting from prevention to rehabilitation. This is a new way how we tackle medicine also in the buildings of a university hospitals today. And therefore, we want to make, as an institution, a real contribution to strengthen climate-friendly technologies and also behavior, because as an organization with so many people and so many budget, which is 1.5 billion a year, we can really make a contribution. And to this end, we have taken a couple of measures, and I'll just give you a few examples. We want really to push or to achieve a new level of awareness in our institution on these topics. And that means that we have multidisciplinary teams, and in all disciplines, not only in medicine but also in administration, starting also in the canteen and in our management, to address the topic climate change and prevention and healthcare. And to this end, this group of the Institute has founded a group. It's called the NENA, the Network of Sustainability in our hospital, and bringing together more than 50 colleagues of totally different fields and disciplines: science, hospital, administration, management, to really tackle this issue. And also, stimulated by your activities, the hospital aims to get certified by the European Eco-Management and Audit Scheme in the next time. And also, we have started many research projects, very translationally oriented, tackling like climate protection in our hospital by optimization of supply chains, because this is also something that we can really influence, and we can make a contribution and impact. That's what we are doing every day. And we are also in, let's say, one example in patient care. The gas emission in anesthetic units is considerable. And we have really changed our policy, despite the high prices, to select those gases in anesthetic units that really protect our climate. But, and this is an important point, we need to address this topic also with our stakeholders, because if we don't get a reimbursement or at least an incentive, also economically, the measures on climate protection are extremely difficult. So, and therefore, it's very important to get also such a socio-economic relationship on such conferences, not only on the focus of scientific data. And also, we have considered this topic in teaching in the medical faculty. We have implemented a longitudinal curriculum, PlanMed, which is also supported by the Land Baden-Württemberg, a curriculum for planetary health and sustainability in medicine, also to really bring this topic to the awareness of the future generation of doctors. So all in all, we have really a lot of activities and projects ongoing in our hospital to reduce the carbon footprint and greenhouse gas emissions in our hospital, and to make a contribution to health by prevention of health and climate. So at the end, I really thank you for joining this conference from all over the world. It will stimulate us and push us further to consider this issue, and I wish you very stimulating discussions. Thank you for sharing your thoughts, your ideas, your data on this topic, and I wish you a wonderful time in Heidelberg. Thanks.
Thank you to Audenried, the medical director, and again to the rector. We feel very supported by you, although we are sometimes not easy. Querdenker is the German word. I don't know whether this can be translated. Doesn't fit in the usual schemes, the topic climate change and health, but we found a lot of support and convinced a lot of people that this is an important topic. And now we will have a word from our mayor. He couldn't come, but he will appear on screen. A little word from our mayor, because as Rector Eitel said, don't forget Heidelberg. You're in a very nice town here.
Sehr geehrte Damen und Herren, zunächst herzlichen Glückwunsch zu 60 Jahre Tropenhygieninstitut oder Global Health Institute, wie Sie sich heute nennen. It's a great pleasure for me to welcome you all as the mayor of the city of Heidelberg to talk about climate change and the pandemic, the risk, which is coming up more and more, and what we can do on the local level. So it's one of the leading questions at the moment on the global scale. And I'm very happy that we have this institute here in Heidelberg, which is so impressive and is so well related to all the international network partners, which we need. We are fighting against those questions like climate change and pandemic. From the local point, I must say it's very important to recognize that we are in a very special situation. The time clock is running out of the possibilities we have as humans to change really rapidly our behavior into a more climate-friendly behavior. So less fossil fuel, less nuclear power, more renewables, more energy efficiency, and a greater and bigger understanding for global change in the dimension of refugees, if you're talking about this question. So it is one of the most relevant points on the global scale. We as mayors, we're working also on the national and international level very close together. I'm president of the European Association of Cities. I'm talking just 3 weeks ago with Timmermans from the EU Commission what we can do about the climate change policy, also in the dimension now with the Ukrainian war and the gas and energy crisis, which is coming up. But in general, we have to work closer together on the international level with all the cities, with all the institutions, to fight against climate change in the field of awareness campaigns, changing the behavior, and a better global policy which is based on knowledge, which we have, so new technologies, and using the resources more efficiently, which we have. So I wish you a successful conference here in Heidelberg, all the best for the whole team, and I'm very proud with all the Heidelberg facilities that we have such a wonderful institute here in Heidelberg. Welcome again.
Well, Joachim, can you come down, please? And till now we are doing this together. Yeah, this is a very green city. He's not member of a party, but he's the greenest person that I have met who is in charge of a town. So if you are interested, look at their webpage. They really are part of model cities and so forth. So for those who, of course, everybody knows Till, my successor. Unfortunately, my predecessor, Jochen Diesfeld, 90 years, 70 years, 50 years, 40 years. So we are improving on our age average. Couldn't come because he broke his hip 3 weeks before the meeting. But tomorrow he will present from his bed by Zoom at 90 years. So I think we should, because he watches us by stream. So let's give him a hand. Jochen, if you hear us, this is for you. Okay, so we briefly introduce you into the topic, and then I will do this, and then Till will say some words on the Institute and use some words on the science of how it all connects together. So, why pandemics and climate change? There are so many important topics, but these topics are, first of all, current. If you look at the newspaper, and it's all over the place, it is on the mind of citizens, of scientists, and they are interconnected through many aspects, and I will only name a few. So both are current major health risks. Climate change is a new one. Pandemics have been with us for thousands of years. Both will stay with us. They are permanent health risks with different time patterns and spatial patterns. Most of these health impacts will be in the global south, particularly for climate change, which brings up the question of equity. Both show extreme events. Many of you know that climate change is not a gradual march towards a hotter world, but it comes with shocks, with extreme events like pandemics. So in their rhythm, they are similar. Both need prediction power. Both need early warning systems. Both need modeling. You can't look into the future. Only scientists can look into the future. And you need models that can predict and prepare us to protect populations. Both are largely man-made. No further elaborations needed on this one. And both are global threats. They are caused by everybody, and they are impacted on everybody, and they can only be managed globally. No country, no person alone can do it. And for both, I must now praise science. Science has done a good job. We predicted climate change, I mean scientists in the world, everywhere from south, north, west, east, predicted climate change well before it came on the radar screen of journalists and politicians. We developed vaccines, science developed vaccines, tests for COVID and for other, and we have all the tools, provided all the tools and the diagnostics and the predictions, but still they are not followed. And this is one key issue of our conference. We have two examples where science did a good job, and citizens, I don't want to point only to industry or to politicians, we all have too large a footprint, or most of all, particularly those from the north, and we must find ways how to better involve, integrate with those who are in power and with our own colleagues and citizens. So this is a major problem that science has failed to unleash its potential. The symposium is focused on solutions, not on how bad is it and so forth, but how can we adapt healthcare? How can we develop climate-resilient health systems? I outlined exactly what you said. Vaccine and health response to pandemics, health system response, early warning systems. Joachim is talking about this. And session 6 with a Heidelberg, not born, but Heidelberg-trained rector of the 10-year rector of the Charité, Detlef Ganten. He will lead the panel on what went wrong, science to public and policy in climate change and pandemics. And we have psychologists, we have mathematicians, we have all sorts of disciplines to tackle that question. And in session 7, we will bring together, this is tomorrow afternoon, in the evening, we will bring all the ideas about what can we do better, what research topics have come up in the panels, and try to come up with a kind of Heidelberg statement, which we then want to publish. Good. On Saturday, we have 2 important sessions. One is on how to teach the young generation. It's not only in the university. I know we have wonderful things here, but also in schools, in industries, everywhere. How can we disseminate the news in a way that is understandable? Just delivering a paper, even if it's in Nature, is obviously not having a big impact. We will also hear about different incentives, different measures from impact factor that include social impact of sciences. Okay, and that the last thing is it's a jubilee. Jubilee comes from a Hebrew word, which is the ram's horn that was trumpeted when particularly at the 50-year turn of a Jewish festival. It came into the Latin language and then filtered finally into the English language in 1640. I looked it up today. 1640, and it means to jump and to trumpet for joy. So we will have music, and global music, as you will quickly find out, and we want to celebrate with you, not only discuss with you. So this is the introduction to the symposium. Now I hand over to my friend and successor, Till.
Yeah, thank you, Rainer. Wonderful introduction to our symposium. Wonderful to have all of you here, and thank you for the inspiring kick-off speeches, Bernhard Eitel and Ingo Autenried. We really appreciate your support and long-standing support for the Institute. When we discussed what topics we should choose for this Jubilee, there was no doubt it had to be on climate change and pandemics, and there are 3 major reasons at HI why that needed to be the natural choice. The first reason is domain expertise and competence, and I really have to congratulate you, Rainer, for having the foresight 20 years ago that climate change and health was a major topic. Rainer was one of the pioneers, and even on the international stage in pushing this topic, and HI when I took over at the helm 5 years ago, had 15 or so scientists. I think we now have 25 scientists working nearly exclusively on climate change and health, and it's a domain expertise that can support and spread worldwide. We've been successful in climate change and health, recruiting Joachim Rockleff as Humboldt professor for EI in climate change and health. We have a junior professor of sustainability sciences, Ina Dankwa, a DFG research unit on climate change and health, and we were able to win major European Union program grants, ID Alert, predicting pandemics in Europe, how they will be influenced by climate change and health over the next decade. FEAST, Aditi Bunker and Anand Yani are leading that project on sustainable nutrition, how we in our everyday lives can make a difference in the intersection between what is good for us and what is good for the planet and for just societies more broadly by supporting people in their everyday consumption choices. And that's the second reason why I think it was a very natural choice, these two topics. We are, as you know, deeply focused at HEI on intervention research, on policy research. We do the science of making an impact in this world. Our knowledge is always intended to have an impact and have an impact now, not 50 years, 100 years into the future. It's applied science and real science, rigorous, but with the potential for immediate impact. And we have that expertise and the urgency of climate change and, of course, the urgencies of emerging and re-emerging and continuing pandemics made it really important for us to continue to invest in climate change and health research, our faculty, our talents. And the last reason is you, our global connections, our global partners and collaborators. I think right now we have projects in 50 countries at an institute with about 100 faculty. We have projects in 50 countries, and you are those network partners and global partners really in part because Rainer and Professor Diesfeld and the scientists at HEI have wonderfully trained global talent for the last 60 years. Our graduates now are leading SICO in Malaysia, the Health and Demographic Surveillance System at Monash University in Malaysia, Malabika Saka, the Center for Implementation, Excellence in Implementation Science at the JP Grant School of Public Health in Bangladesh. We have Catherine Kyubungungi, who is leading the Africa Population and Health Research Center. There is this long-standing connectivity to you, our talented global leaders who at some point in their careers passed through Heidelberg and were in part with us, and it's Ali Bokar, of course, of course. Welcome Ali and Bokar. So a whole generation of talent that was with us and is still with us, and that's the third reason, I think, why we can make a unique contribution as HEI on these important topics. Over to you.
Thank you. First, I'd like to say that I think this is a fantastic research environment that you've built and established, and climate change bringing along and on board is obviously fantastic, and especially since that's my field of research. And I'd like to do 3 connections between climate change and pandemics. The first one is quite obvious. It's deforestation. And we all know that rainforests are super important for the earth and acting as carbon sinks. There's a lot of deforestation going on still, and that obviously limits the CO2 uptake of these important vital organs of the earth. At the same time, when we change the environment, when we interfere with natural wildlife, we also change and we force them to adapt. And those adaptations have been documented to lead to more viral sharing among animals and to the emergence of infectious disease. That's well documented. So that's a very important link between climate change and pandemics. And it's also an upstream link, which is even more important because knowing how we interfere with nature and that our interference with nature is actually also leading to more spillovers and more potential for pandemics. It's just knowing that we could actually do something about it. So that's a way of preventing pandemics. That's number one. There's a recent study actually also looking at these patterns, looking at climate change and the distribution of species. A very comprehensive study looking at about 3,000 mammal species and how they potentially redistribute with climate change. It finds that with climate change at 2070, as 50 years from now or so, according to this model projection, there could be as much as 4,000 times more viral spillovers across mammals in areas that are highly densely populated. That's really serious and important. It doesn't say that there will be this number more of pandemics, but it says that the potential for pandemics is definitely increasing. Another point connecting epidemics and pandemics is dengue. I've been working a lot on dengue. Currently, there is a dengue outbreak in Singapore. Singapore is rich. They have vast resources to control disease outbreaks. They've been investing lots of money into this for the last, 40 years at least, but they can't really control dengue. Dengue, at the moment, there is a big outbreak which started earlier, probably due to higher abundance of vectors and the climate conditions being very conducive. At the same time, these epidemics and pandemics are fueled by mobility, partly because we spread a virus and partly because we spread new strains and new variants. So it's a combination of human influence in two different ways, which is really affecting epidemics and pandemics. And in terms of climate change, there's another connection to pandemics. We've all heard a lot about transmissibility. There is a new strain or a new variant which is more transmissible. Climate change is doing the same thing to viruses and diseases. It actually changes its transmissibility. We have an indicator for the Lancet report, the Lancet Countdown report, which measures up till today how much climate change has contributed to increased transmissibility of dengue. It's not as large as for COVID, but it's still almost 10%, and it's only the beginning. So there's definitely going to be strong influences on the transmissibility and the spread of epidemics and pandemics with climate change as well. Last point, I think with the pandemic, there's been a rapid development of tools, methods, data generation for society. And it's very obvious that society needs data, it needs models, it needs synthesis, it needs a lot of support in making decisions and decisions based on data. And with that, there has also been quite a lot of development and pioneering work on models that combine, 100-year-old structures developed for malaria, but with machine learning, which holds a lot of promise to do more data-informed models, better tools for decision-making, with streaming data flows, and with also much more better developed tools and software, which actually is easier for people to understand and to use. So that's also a very promising development, although the whole area is obviously maybe not only promising, it's also a daunting task to address. And we are addressing these interlinkages in my new research group at the Global Health Institute and at IWR at the university here. So this symposium is really at the core of our activities. So very many thanks for setting this up.
Thank you very much. Joachim, of course, is from Sweden, and you have to leave, okay. Let's give them a round of applause. Joachim is from Sweden, and there's also Göran Thomsson from Sweden, and today is midsummer, and I know what this means. Tomorrow? Okay. But tomorrow is midsummer, and this is like Christmas for the Swedes, so it's the most important feast, and you have renounced to come here. Thank you very much. And I also want to thank those who come from very far. We have 2 people from New Zealand. This is really the worst distance, or the largest distance. Alistair and Aditi. Is Aditi here? Well, and then we have people who have struggled. I can't greet you all, but who have struggled with visa. And I would name Srinath Reddy from Delhi, School of Public Health, if you like, Public Health Foundation of India, who couldn't get a German visa, and he went to the Danish embassy to get a Schengen visa to come here, and arrived at 3 o'clock in the morning. So, a big round of applause. It shows really remarkably how this family almost has grown together, and how we like to be together in person. We've fed up with Zooms and everything. So thank you very much. Now we have one other musical item, which shows that we have global music here. It is from a Bulgarian composer of the 20th century, and it's performed by a 15-year-old Wunderkind from Turkey, Yaz Türkmen, and you can ask for encores. She has 1 encore if you like it. It's only 2 minutes, but let's listen to her and see also the age balance of us. Naz, buyurun, hoş geldin. The piece is called, now I have to read my Sevdana, which is a hybrid from a Slavic language, and sevgi is a Turkish word for love. So it's about love, everybody understands that. And the composer is Georgi Slatev Cherkin. welcome now the Dean of the School of Public Health. We have 6 Deans of School of Public Health here, from New Zealand, from India, from the States, from UK, and from Indonesia. So, but we are very proud to have Dean Williams here.
Many thanks for...
Thank you, Andy. Dean Williams is known to many of you, particularly to Till, who worked at the School of Public Health. I had my earlier public health training there, but this was before your time. And we both enjoyed the environment and the excellence of this university. And we are very proud to have you here and give us your impression of the topic and how your famous institution relates to it.
To recognize the importance of climate change in the context of global health. I also want to say just how wonderful it was to hear from the rector and the director. The rector's remarks about the primacy, the centrality, the significance of global public health in the whole societal and scientific framework is really music to my ears. Because not only because I've spent 36 years of my career in public health, but because it is true. Public health is really that space where all disciplines come together to encourage, support, and enable discovery science, but to also make sure that those discoveries have immediate and lasting impact across populations. And I really appreciated the comments about being solutions-oriented, Till, because I think that's what draws many of us to public health. So again, thank you for the introduction and for the invitation to be here. It's an honor to be with you all, especially at such an extraordinary time in public health. 60 years ago, the Heidelberg Institute of Global Health was founded with a simple but ambitious mission, and that was to improve the health and well-being of the sickest and the poorest among us. Few could have imagined what the work would look like in 2022, and just how much we'd advance the mission around the world. Think about how much has changed since the Institute first opened its doors. We've pretty much won the fight against smallpox. We've seen polio nearly vanquished. HIV and AIDS are no longer a death sentence, and in many cases, neither is cancer. Extreme poverty and malnourishment have declined across the globe, and child deaths have plummeted as well. Indeed, today, millions of people are surviving and thriving who would not have 6 decades ago, and it's one of mankind's greatest successes. Some public health development have been seismic, and others rather subtle and even iterative. But the cumulative impact has been really remarkable. And yet every one of you here know that we still have our work cut out for us. The COVID-19 pandemic has laid bare so many of our persisting vulnerabilities. These vulnerabilities include inadequacies in our healthcare systems, gaps in global coordination, underinvestment in the social determinants of health and behavioral change management, rampant disinformation, and long-standing inequities hiding in plain sight. The world hasn't seen such immense, singular disruption since World War II. And the consequences of this COVID pandemic will be felt in nearly every country for decades to come. But as we grapple with COVID for a 3rd year, we know that another crisis, just as deadly and as far-reaching, is also upon us. And our actions today will shape human health for generations to come. Of course, I'm talking about climate change. You see, in many ways, the human prosperity that we've achieved these past 6 decades has become a threat unto itself. Aging societies are straining our healthcare systems and economies. The expansion of the global middle class has led to unhealthy lifestyle shifts and the rise of non-communicable diseases, antimicrobial resistance. And these are undermining some of the gains that we've made in infectious diseases. And while digital technology has revolutionized our ability to connect with one another, even during times of pandemics, and we're all tired of Zoom, but thank goodness that Zoom was here for us to leverage, it really has also hastened the spread of disinformation. Add to that the fact that our longer lifespan means that we're putting more people and more pressure on our planet itself. Patterns of human growth and extreme resource consumptions are degrading the environment in profound ways. So profound, in fact, that they've been designated by a new geological period known as the Anthropocene, or the human epoch. Human activity has already heated the planet by about 1 degree Celsius. And this has been since the pre-industrial era. That may feel abstract and may even sound de minimis to you, but the consequences are anything but. You don't have to look far for examples of what that 1 degree Celsius change represents. Heidelberg was among the hardest hit last summer when record floods swallowed entire towns. This happened in Germany, in Belgium, in Luxembourg, and in the Netherlands. You saw homes collapse and historic floods and bridges destroyed, historic roads and bridges destroyed by sudden, relentless floodwaters. Just 3 hours north of here, North Rhine-Westphalia had its highest precipitation levels in more than 7 decades. That was about 150 millimeters in under 24 hours, more than double the previous rainfall record set in 1947. Thousands were left without light or electricity across Germany, and all told, more than 100 lives were lost, and hundreds more were left unaccounted for. And just as all of this was unfolding, wildfires ripped through large parts of southern Europe, along with California, Siberia, and South Africa, decimating the lands and livelihoods in their path. And the most severe heat waves in the history of the Pacific Northwest, where I lived for 20 years, killed hundreds of Americans and Canadians. That was last summer, but I will share with you that this summer could be just as deadly. In the past couple of months alone, we've seen heat waves have scorched large swaths of Pakistan and India, killing dozens. Extreme droughts have forced northern Italy to turn off tap water at night in Italy, as some places didn't see a single drop of rain between December and April. And historic floodings has continued to displace and even kill thousands and thousands of people across nearly every continent. These extremes are no longer extremes at all. They've become the new normal, and they're merely a preview of what's to come. Last year, the UN released a major climate change report, and their findings were stark. The report indicated that warming is almost certain to reach 1.5 degrees Celsius over the next 2 decades, well within most of our lifetimes, and that there's a good chance that will happen sooner than that. Now, I don't want to be a doomsayer, but I am a scientist, like many of you here, and the science is clear. No matter what we do at this point, the coming years on this planet will be warmer, wetter, and more volatile than ever. and that it isn't just an environmental crisis or even an economic crisis. It's also a dire public health crisis. And we know that there will be catastrophic consequences for the well-being of people around the world through both direct as well as indirect pathways like heat-related deaths, asthma, pregnancy complications, and cardiovascular diseases. But there are countless of indirect consequences as well, and I will list a few. Extreme droughts will leave hundreds of millions without enough water. Coral reefs, which feed and provide income for large portions of the globe, will die off on massive scale. 100 million people are expected to be pushed into extreme poverty, and while some animal and plant species will go extinct, others, namely disease-carrying insects, will expand their reach as temperatures rise, as you just heard. It's why climate change is what we call a threat multiplier. That is, it exacerbates all the stressors that already threaten to harm human health. One such threat multiplier or stressor is food insecurity. Rising temperatures are already reducing crop yields and creating food shortages. In fact, the UN International Panel on Climate Change recently reported that yields of the big three staple crops, corn, wheat, and rice, that the yields of these staple crops will fall an additional 10 to 25% for every 1 degree Celsius of future warming. And climate change isn't just diminishing crop yields. We've also discovered that the changes in climate are promoting changes in the nutritional value of the foods themselves. For example, for more than a decade, faculty at my school, at the Harvard Chan School of Public Health, researchers have been growing plants in an environment that simulates the air quality that we expect to see at the end of the 21st century. And they're concluding that higher carbon dioxide levels are actually changing the internal chemistry of staple crops like wheat, rice, maize, and soybeans. Essentially, high levels of CO2 is resulting in stripping these staple crops of micronutrients like zinc and iron. These micronutrients essential for human immune system and cognitive development. Today, around 2 billion people around the globe already suffer from zinc and iron deficiencies, and they depend on these crops for nutrition, especially in countries where meat is rarely consumed. Let me give you another example from our research. In 2020, Harvard scientists looked at COVID-19 data in areas across the United States. And they looked at areas with high pollution levels, like the pollution from car exhaust, refineries, and power plants. And they found that people who lived for decades in a county with high levels of fine particulate air pollution, they found that these individuals were 8% more likely to die of COVID than someone who lives in a place with 1 unit less of pollution. This is just one example of how environmental degradation can compound other health threats. And I think this example is apropos to the main theme of this conference today, pandemics and climate change. Another such threat is also global displacement, and you heard mentioned the importance of migration and movement. Around the world, conflict has driven a devastating rise in the number of people forcefully displaced from their home, from Ukraine to Ethiopia to Afghanistan, millions have been uprooted by violence and persecution. At the same time, millions more are being displaced by climate change. In 2020, more than 30 million people were forced from where they live by disasters, the vast majority of which were weather and climate-related floods, storms, wildfires, extreme temperatures, and drought. 3 years ago, I had the privilege of visiting Bangladesh, and I had the opportunity to visit Cox's Bazar. It's a sprawling city in the southern eastern coast of Bangladesh. It's also the world's largest refugee settlement, with nearly 1 million Rohingya currently live in makeshift shelters. These families have fled unspeakable atrocities in Myanmar. Many are survivors of rape and violence. Others have seen family members murdered and their villages burned to the ground. Those who have managed to escape live with severe physical and psychological trauma, and the toll is compounded by their life in limbo. NGOs and humanitarian aid groups are working to help overcome the critical challenges posed by overcrowding, poor sanitation, and limited drinking water in these camps. They're providing health and hygiene consultations, distributing food and millions of gallons of fresh water, administering cholera vaccinations, and dispatching emergency teams to stem the outbreaks of disease. But despite all of these efforts, the situation is precarious, so much so that the International Rescue Committee has called health in the region a ticking time bomb. Poor living conditions have put refugees at high risk of diarrheal diseases, upper and lower respiratory tract infections, skin diseases, and E. coli infections. And all of these challenges are made that much more difficult to solve, that much more complex by climate change. The concentration of refugee camps in Cox's Bazar has had a devastating impact on the local environment as well. Thousands of acres of forest have been cleared to make way for the camps, and the hills where they are perched are now essentially bare, meaning there is nothing to keep the topsoil and everything on it from sliding downhill in heavy rain. Warming temperatures in the coming years will result in more intense downpours, mudslides, and floodings. I visited the area not long after a brutal monsoon season, and the weather had destroyed vital infrastructure across the camps, including health centers and children's learning facilities. Heavy rains had caused hundreds of latrines to overflow, increasing the risk of cholera and other waterborne diseases. All of this has fueled an unfolding humanitarian crisis. I share this with you because what's unfolding in Cox's Bazar is a microcosm for the profound public health issues we faced worldwide. Harmful physical and social environments, poverty and humanitarian crises, vulnerable health systems, new and re-emerging pandemics, all of which will be worsened by climate change. And it's the world's vulnerable and neglected who will suffer these compounding threats most. And ironically, the people who will suffer the most have contributed the least to climate change. So today we have arrived at another crossroads for this institution and its mission. Will we build on the incredible gains in human health we've achieved over the last 60 years? Or will our progress begin to unravel? The answer, I would submit, depends on us. What we do today will set the course for human health for the next century and beyond. Yes, rising temperatures are now inevitable, but how much they rise is still in our control. Even staving off an additional ½ degree of warming could make an enormous difference for life of the planet and us. Let me put this in perspective. At 2 degrees of warming, more than 1/3 of the world's population will experience extreme heat waves at least once every 5 years. If we halt the warming to 1.5 degrees, we can reduce that number by more than a half. We could also save 61 million people from drought, stop whole island nations from being submerged, and keep the coral reefs that we rely on from going virtually extinct. To put a finer point on this, limiting global warming is the single most important thing that we can do to advance human health today. And it would rival any public health success of the previous century. Curbing warming means ending our reliance on fossil fuel energy and investing in renewable energy sources. It means supporting zero-emission infrastructure like green transport systems and green healthcare systems. It means protecting biodiverse ecosystems through sustainable farming and ocean management. And it all means scaling up financing for more vulnerable countries to address their climate and health crises. Now, these are not the types of interventions we typically talk about in public health. Certainly not the kinds of interventions we talked about when I was a first-year public health student in 1986. But they should be, and they are, because planetary health is human health, and we must keep that human face on this crisis. After all, there's a reason it could be difficult for people to fathom climate change, even when we know the consequences are so catastrophic. We know that humans are hardwired to put our short-term needs and desires ahead of future ones. We call this present bias. It's why so many of us have trouble saving for retirement or even getting our work done in advance, even when we know we'll be far better off by investing early. On a subconscious level, we think that it's for our future selves to worry about. So when we talk about climate change in terms of 100 or even 50-year impacts, or degrees of heat and units of emission, people automatically disengage. The good news, however, is that we can change our mindset by changing the way we talk about and communicate the crisis. We must emphasize what is happening to individual people, to you, to me, to our families. And we must talk about them with a sense of urgency and that these changes are happening now. The narrative has never been as potent as it is now. It's more important now than ever before that we in public health communicate as broadly, widely, and effectively to all. I've always said that public health is everywhere and nowhere all at once. What I mean by that is when public health is working, when the work that we do is so critical, yet it remains largely invisible until there's a moment of crisis. Because when public health is successful, nothing bad happens, right? But today I want to say that public health is everywhere. The health of humankind is now top of mind for people all over the globe. This is our opportunity to take the moment and turn it into a movement. Because while COVID-19 has been devastating, and it has been a devastating setback for global well-being, it also offers us a new beginning. It offers us an opportunity for countries to rebuild stronger, to be more equitable, and to be more sustainable than ever before. This is an opportunity that we must not squander. If we are to have a shot at limiting the warming to 2 degrees Celsius, every country would have to live up to its climate change pledges, including getting to net zero carbon emissions by the middle of this century. We don't have any time to lose. To put it in terms the students in this room will understand, we are basically starting on the term paper the night before it's due. Some of us are too old for all-nighters. So let's get started. At the same time, I want to say we must do everything in our power to protect people against the climate shocks that are already happening. That means we must shore up our healthcare systems around the world. It also means we have to dismantle the systemic inequities, both between countries and within countries, that leave people vulnerable. We know that doing so will take profound political will, financial investment, and unprecedented, coordinated global leadership. And it's up to us as public health professionals to be the agents of change for progress, just as we've always been in public health. That is our history, that is our legacy, to be the agents for change and progress. To think globally about emerging health priorities, and we must also act locally to design and fight for health interventions that meets the needs of different populations, so no one is left behind or underserved. That is how we'll help people not only survive, but to continue to flourish for generations. So I am immensely proud to be invited to this symposium, to be collaborating with you all in this work. And I'm hopeful that what we will accomplish together in the next 60 years and beyond will allow us to propel our population forward and protect the climate, the earth, simultaneously. Thank you for your attention.
Okay, I wish that this change between government and universities were more frequent in Germany as well. We seem to be afraid of, from our history, very well understood, afraid of getting our fingers into the power, those of power. Okay, now we have, does he see me? Ah, yeah. Do you see me, Andy?
I do, but I don't seem to share the screen. Can you hear me?
We hear you very well, and now the screen share we don't see yet.
Okay, let me try now.
That looks like your screen, yes.
That's it.
There we go. Just keep going. And I've asked the audience to formulate 3 questions for you, as you insisted to be iterative.
Well, let's hope we have some time for that. Thank you so much. I'm really sorry I can't be with you, and it's a great pleasure and privilege to follow on from the previous wonderful talk. So what I want to do is to build on some of the points that were made. Just to say, to start with, that we are indeed really in danger of reaching the 1.5 degree centigrade limit in coming years. This is the limit, of course, in the Paris Agreement. This is the preferred aim of keeping to 1.5 global average temperature increase. And as you can see from this slide, the 2 temperature records are diverging rapidly. So the orange line on the left is what the climate would look like if we weren't emitting lots of greenhouse gases, particularly carbon dioxide and methane. And the red line shows you what's actually happening. So we're now at about 1.2 degrees, something of that order. And with the El Nino coming next year, it's likely to be a record-breaking year. So we have to act very urgently, and as we've already heard very compellingly, I think the health community has an important role to play in advocating rapid action. Also, science is moving on very quickly, so increasingly we're able to attribute specific events, climate events, and trends to climate change. They're not due to natural variability. A recent study showed that 70% of over 400 extreme weather events and trends were found to be made more likely or more severe by human-caused climate change. Now, one example is shown on the right side of this slide. This is the Siberian heat and fires in 2020. This was an extraordinary event. As you can see, the temperature records were broken, much of Siberia, and this wouldn't have happened, virtually impossible, in a pre-1900 climate. So we can be confident in saying this kind of event is due to climate change. Now, we've already heard about the ways in which climate change can impact on human health, so I won't say very much, but just to remind you, this is from a paper we wrote a few years ago in the New England Journal, that climate change can affect health through a range of different pathways, and it's mediated through a range of demographic, socioeconomic, and other environmental factors which determine the magnitude of the pattern of risk. And without going into detail, you can see that these health exposure pathways and the health outcomes range from the very direct, like extreme heat, for example, air quality, wildfires, water quality and quantity, across to the effects on infectious diseases and social factors such as population displacement, increasing poverty, and probably conflict as well. So this recent study exemplifies the advances in science. It's a study led by some of my colleagues, Ana Becerra Cabrera, published in Nature Climate Change last year. And what it showed really for the first time, really compellingly I think, was that climate change is with us now, that we can attribute about 1/3 of the heat-related deaths over recent decades to human-induced climate change. And that was using data from over 40 countries. You can also see that there are big gaps in the data, the grey areas on the map, Africa and Asia. We sort of don't know what's happening. And it's likely that these estimates are underestimates because these vulnerable areas are not covered by adequate data and surveillance. We know that climate change will have massive and worrying effects on food production, as shown in this map. And of course, the link with COVID-19 is that many people were suffering, increasing numbers of people suffering from food insecurity as a result of the disruption in supply chains from COVID-19. And of course, the Ukraine crisis is adding to these problems. And climate change will be superimposed, and is being superimposed, on top of these other stressors. You can see there may be increases in food production in some parts of the world, in the temperate regions, but we don't know how long that will go on, nor do we know whether populations can afford to buy food on an increasingly competitive global market. COVID-19, of course, also impressed upon us how pandemics and pandemic responses can have massive effects on mental health. And really, climate change, again, is increasingly recognized as having effects not just on physical health, but also on mental health. So when people are exposed to floods, droughts, wildfires, then they experience increases in depression and anxiety, often for many months, perhaps years sometimes, after the event. And we have the emergence of these concepts like solastalgia, which is the distress caused by environmental change, which has been experienced by communities in the Arctic, in Australia, where farmers have lost their livelihoods. And of course, climate anxiety, which many young people, many others feel, because of the hazardous and uncertain future. So climate change doesn't just impact on physical health, it impacts on mental health, as we've seen, of course, with COVID-19. And of course, there is growing evidence that the same drivers that are driving climate change, namely burning of fossil fuels being one of them, also may have contributed to some of the mortality of COVID-19. This is a paper a couple of years ago led by Andrea Pozza at the Max Planck in Mainz. Human-induced sources, and from those related to fossil fuels. And you can see that about over 20% in some cases of COVID-19 mortality could be attributed to air pollution. So it increases the risks, because it increases the risk of these non-communicable diseases, which in turn increase the risk of COVID mortality. So that's an added argument, you could say, for decarbonising the world economy, as if we really needed an added argument. So clearly we have a real need for urgent action. If you look at the figure on the left there, you can see that in order to have a reasonable probability of keeping within 2 degrees, we have less than 30 years left, and we have less than 10 years at current rates of emissions for 1.5 degrees. And the health professionals, of course, have increasingly become mobilized around climate change. In 2020, the leaders of organizations representing over 40 million health professionals urged G20 leaders to put public health at the core of the COVID-19 recovery. We can debate how successful that was, but it was an important statement by the leaders. Really starting to take a more leadership position. So where are we now with relation to Paris Climate Agreement and COP26 moving on to COP27? Well, very, very briefly, just to remind you, the Paris Climate Agreement aims to limit the average global temperature to well under 2 degrees. It aims to enhance resilience and adaptation to climate change, to those impacts we can't prevent, and it aims to align the financial flows in the world with these objectives. For the first time at COP26, WHO had a pavilion. There was a very active number of events there. Health had a significant presence with many other events as well. And there was a WHO Global Conference on Health and Climate Change and a COP26 special report on the health argument for climate action. You can see that there are 10 proposals in the WHO report, and I won't read them all out. But you can see that they include committing to a healthy recovery from COVID-19, harnessing the health benefits of climate action and building resilience to climate risk, protecting and restoring nature as a foundation for our health, reimagining cities, promoting healthy food systems, and of course financing a greener and healthier and safer future for all of us. So we can debate just how successful those calls were, and let me touch on a few developments of COP26, some of them positive and some negative. First, on the positive side, well, we saw at COP26 over 50 countries committed to building health systems which are able to withstand the impacts of climate change and which are low carbon and sustainable. And 14 countries set a deadline of 2050 or earlier by which their health systems will reach net zero. Since then, there have been other signatories as well. The image on the left here just reminds us that when we think about health systems, it's not just the fossil fuels burnt in health facilities or the electricity that health facilities buy, it is also the scope 3 or indirect emissions. And these are the emissions in the supply chains: pharmaceuticals, medical equipment, food and catering, freight transport more generally. So if we want to decarbonise the healthcare system, we also have to work with the supply chains for the healthcare system. And an increasing number of countries are doing that in order to accelerate the transition to net zero healthcare systems. We know that healthcare systems contribute about 5% of global greenhouse gas emissions. If they were a single country, they'd be about the 5th biggest emitter in the world. So action is imperative. Another positive development was the global methane pledge. We often forget about methane. This is a tremendously important greenhouse gas. Short-lived, it lives in the atmosphere for about 12 years. And this pledge undertook to cut methane by 30% by 2030 compared to 2020 levels. And if that's successful, that would decrease heating by about 0.2 degrees. That's quite significant. I mean, 0.2 degrees doesn't sound very much, but it's absolutely vital. As we've already heard, every 0.1 of a degree, every fragment of a degree is worth fighting for, because we don't know where the tipping points will be in the climate that will take us towards an increasingly disastrous future. So we have to fight for every reduction in greenhouse gas emissions we can get, and methane is an important one. But there are many disappointments. Yet again, parties failed to reach the $100 billion goal for climate funding, which is, as you can see, they pledged to do for many, many years, and they won't reach it now until, well, probably not next year, particularly with the Ukraine crisis and so on. Also, many nations refuse to accept liability or provide compensation for loss and damage. We are seeing some changes there. New Zealand, for example, I read in the news just recently, have undertaken some kind of fund for loss and damage in the Pacific region. But there will be a great deal of discussion about the the responsibility of the high-emitting nations at COP27 will be a key issue. Coal was also a disappointment. There was great hope that there would be an agreement to phase out coal, but in the final analysis, the coal-burning nations, I won't mention names, but a couple of coal-burning nations particularly fought against that phraseology, and they used the term phase down rather than phase out unabated coal. And they used also the term phasing out of only inefficient fossil fuel substances. Well, in my view, all fossil fuel substances are inefficient, so they're driving us towards disaster. So that was a big setback, and as we know, coal is a big contributor both to air pollution and to greenhouse gas emissions. So, very, very briefly, what do we need to do? We need integrated climate action, mitigation to cut greenhouse gas emissions, adaptation to manage the risks of climate impacts that we can't prevent, more resilient healthcare systems, better disaster management, and so on. We know quite a lot about what we should do, from modelling studies and so on. There's still a dearth of empirical evidence about the health benefits of adaptation and mitigation strategies, as summarised in this paper from my colleague Pauline Shielbeek recently. So there's still a lot of work we need to do to evaluate some of the impacts of these adaptation and mitigation strategies. But we know the benefits, potentially, mitigation and adaptation, are very large indeed. And this useful paper by Ian Hamilton and colleagues last year estimated the public health benefits of the Paris Agreement. Now, these are the benefits not just of preventing dangerous climate change, but these are the co-benefits, the near-term benefits of moving towards a more sustainable low-carbon economy. And you can see that across the 9 countries studied in this paper, ambitious nationally determined contributions, these are the statements that countries have to make in the Paris Agreement, could result in the prevention of many millions of deaths annually over coming decades, from air pollution, from diet-related risk factors moving towards more sustainable diets, less consumption of ruminant meat, more plant-based food consumption, and increasing physical activity through more sustainable transport systems. So big benefits and near-term benefits over and above those from reducing the risk of climate change. So how well is health reflected in these nationally determined contributions? Well, an analysis by the Climate and Health Alliance in the run-up to COP26 showed that actually many countries were failing to mention the potential health benefits in their nationally determined contributions, particularly high-income countries, many of them in Europe, did not capitalise on the healthcare benefits of climate change mitigation, nor did they emphasise the importance of adapting to climate change to protect health. So, big missed opportunities, and I think really a lot more work needs to be done to ensure that health is really embodied in these nationally determined contributions. We don't have much time. We do have small windows of opportunity here. There will be an opportunity in 2025 to communicate new or updated nationally determined contributions. There will be the stocktake in 2023, which will, I'm sure, show these NDCs are not sufficient. So we have a few windows of opportunity, but it's going to be imperative that we get a much higher profile of health in these nationally determined contributions, and probably even more importantly, that the countries, actually implement their NDCs, that these are not just pieces of paper that sit on a desk, but they're actually implemented. So where are we going now with COP27? Well, COP27, as you know, will be in Egypt, and from my perspective, the big points that will come up will, of course, be the ambition of greenhouse gas reductions as we emerge from COVID, and many of us have hoped that there would be a much bigger investment in green technology, but unfortunately there hasn't been. Many of the investments, the post-COVID stimulus packages have not emphasised green investments and healthy investments as they should have done, and that will come up. Climate finance will clearly come up. This $100 billion target is quite scandalous that it hasn't been reached over so many years. Who's going to blame? Who's going to pay for this is going to be a very contentious issue. Who's going to take responsibility? That will come up undoubtedly. The whole question of food and the debt crisis will be amplified by, of course, the Ukraine tragedy. So we need urgently to think about how we construct more resilient and affordable food systems around the world, which also have a lower environmental footprint. And because it's based in Africa, of course, adaptation will be absolutely crucial. because there's so much happening already that we can't prevent. So we do need to adapt rapidly to climate change. So these are very great challenges, I think, to the global infrastructure, to the COP process, and I think to health professionals as a whole. And it's really important that our leaders, our organisations, our professional associations play a major role as we come up to COP26 and ensure that health is very much at the centre of discussions in COP27. Thank you very much indeed.
Bravo. Thank you, Andy. If it took another proof that you're the leading expert in the field, here it is, here it was. So I hope the audience has prepared 3 questions each. No, 3 questions. Yes, please. Just, I throw you the microphone. It's not heavy.
So I talk here?
Just talk in it, yeah.
So hi. Yeah, I just wanted to ask you, with all the wars happening around, and there is a lot of scarcity in natural resources, or like, for example, natural gases and something like that. And a lot of countries will shift back to mining, for example, and using coal and all that kind of stuff. So how do you see that, or how can we go about this?
Yeah, you're absolutely right. I mean, this really worries me. You know, even in my own country, we're talking about opening a new coal mine, which is where we need to be. We have to keep coal in the ground. 80% of coal has to stay in the ground if we're going to have any chance of reaching the Paris Agreement targets. So, yes, there is a real danger that in a short-term rush to address this gap in energy, countries will go back to using coal. I really worry about that. What can we do about it? Well, of course, we have to keep making the argument that in doing so, all we're doing is accelerating the crisis, the climate crisis, which is coming so rapidly. It's already with us, but it's coming more rapidly over the horizon. So all we're doing is replacing one crisis with another crisis. What we need to do, of course, is to use energy much more efficiently. A lot of the energy that we use is just wasted. I mean, I know in my own country, for example, many of our houses are inefficient. A lot of the heat leaks out. We should be retrofitting our housing stock rather than digging new coal mines. We should be using our cars less. People are driving around in 2 to 3 tons of steel in cities. Why?
Particularly Germany.
Republic and London too. So yeah, we think we are wasting a lot of our resources, and what we need to move towards is a much more frugal economy, but an economy which puts health and well-being at the centre. I think this is a political argument we have to keep having and try to prevent some of the retreat back into coal, which will be so disastrous to the climate and around health.
Thanks, Andy. As you say, it's fun to live in a climate-friendly and healthy world, and we should not say, oh, it's so costly, we all need to sacrifice. There's Till who wants to talk to you. Till, are you good at that?
Andy, can you? Thank you for your excellent presentation, Andy. My question to you is, where do you see the major levers that we specifically have in public health and global health? How can our research most contribute to your intervention and policy research agenda? We see these levers on the one hand on the health system side. Can we support health systems in becoming less emitting? Our CEO spoke earlier and talked about our efforts here locally to reduce our greenhouse gas emissions and carbon emissions. As a university hospital, the biggest, I think, in Germany, can we make a difference? And then on the household and home-based, family-based, individual-based intervention agendas, can we change our behaviors as people? I think about 1/6 of our contributions are our behavior, our consumption behaviors, heating, eating. That's where we see a lever for us also in health, in the sustainable diet interventions and the intersections, right, where we can make a co-benefits argument about health and planetary health, personal and planetary health, leading to co-beneficial boosts. Do you see another arena outside these individual home-based interventions and the health systems that is for us in global health, in public health?
Thanks. Well, great question. I think you sort of partly answered it yourself, really. You gave some great examples. But so I think obviously the health system is important. accelerate energy decarbonisation of the healthcare sector. The important thing there is working with the suppliers. Of course, we can have a much bigger impact on the economy than the health system itself. Even if the health system is only 5% emissions, of course, all the supply chains are working with the pharmaceutical industry, the medical equipment industry. They have their own suppliers, and so that can have a knock-on effect, an accelerating effect on the whole economy, I believe, and that's going to be really important. But we also have to think about reconceptualizing health. So health isn't just about healthcare, of course, it's also about creating an environment which is conducive to health and also a much lower environmental footprint. So one area that I think we can emphasize much more is this health co-benefits of the net zero economy. What are the benefits of the food system, as you mentioned? I think this is crucial. The food system is about 25% of greenhouse gas emissions, and it's a major driver, of course, of biodiversity loss. So we have these dysfunctional food systems, which we know hundreds of millions of people are undernourished, and at the same time, 2 billion plus are overweight and obese. So we have this totally dysfunctional food system, and that's something we need to fix, both in terms of changing dietary choices, but also, as some researchers have pointed out, the possibility of novel foods as well, novel and future foods, many different types of which I don't have time to go into detail, but a lot of exciting innovation in the food system at the moment. So I do see that as a really crucial way of focus for our research. It's a very exciting time, it's a very worrying time, but it's also a very exciting time, I think, for health researchers and the healthcare community more generally, because we do have this potential to play a leadership role in this very vital debate and to accelerate the progress that we so badly need.
Thanks, Andy. We have two more questions. We are good in time. One is, I understand, about migration.
No.
No? But I thought it's a good topic, and you had...
Do you want to ask?
No, I don't have a question yet. I'm confused.
Sorry, I don't have a question.
They are fighting to ask you a question, you see. But then, but very short
Hi, Andy.
question, no statement, short question.
Yes. Hi, Andy. It's Aditi Bunker. Thanks for your thanks for your wonderful talk. My question is about the fact that I'm always torn between balancing the resources that we have between adaptation and mitigation work. And I wanted to know your views on that and how you think we as scientists should focus.
Yeah, this is a fantastic question, and we've been thinking about this quite a lot. So, I mean, there are these two communities. So there's one adaptation which comes often from the kind of disaster relief community and others, and then the other community on mitigation, which is more around food systems, energy, and so on. And I think we need to remove some of the artificial barriers between mitigation and adaptation. We need both. We need them simultaneously. And what we need to ensure is that there are synergies between mitigation and adaptation. So some adaptation strategies, for example, putting in air conditioning everywhere, will actually make it more difficult to mitigate. It might make it more difficult to cut greenhouse gas emissions because they're so energy dependent. So when we're thinking about adaptation solutions, we need to think about adaptation solutions that don't increase the risk of climate change. So passive ventilation, passive cooling in buildings, green roofs, shuttering, these kind of windows, rather than just sticking lots of air conditioning. So increasingly we need to integrate the two. Now if you're in a very low income country where the greenhouse gas emissions are very low, the focus is going to be on adaptation, naturally. But if you're in a high income country with lots of greenhouse gas emissions, then you need to emphasize mitigation, cutting emissions. So there's varying emphases, but the broad direction of travel is we need to integrate actions on adaptation and mitigation. Thanks very much.
Thank you. Trish.
Thanks, Andy. Trish here from Heidelberg University as well. It seems sometimes like the health community are saying the same things over and over again, and I'm just wondering how we're going to bring the conversation forward at COP27. Is it a matter of simple messages repeated often by trusted voices, or do we need to be saying different things? And I'm particularly talking about the tertiary impacts of climate change. We seem to concentrate a lot on extreme weather events and ecologically mediated infectious disease, etc., and not really as much migration and conflict. So kind of two questions there. First, how do we move the conversation forward at COP27? And what do you see kind of the next steps with the health community engaging with the tertiary impacts of climate change? Thanks.
Okay, thanks. Yeah, again, two fantastic questions. So I mean, the first one of these, I mean, we've done quite a good job in talking to ourselves. We've convinced ourselves that we need to do act. We haven't been very good about actually communicating that to other people, at least they haven't been listening. And I think many of us have hoped with COVID-19 that there would be an increasing voice from public health and that public health would be listened to by policymakers. And that's partly true. But of course, once we emerge from COVID-19, I'm afraid many policymakers go back to their old habits of ignoring the importance of public health and well-being. So we need to do a much better job of reaching out to policymakers, not just at the national level, but at the local level as well, working with regional governments, city governments, and so on, who are often much more receptive to these kind of arguments than national governments, because national governments, of course, have very powerful lobbies. The fossil fuel lobby, the food lobby, they're very powerful on the national stage, but the local and regional stage is sometimes easier to make advances. I think the other thing we need to do is become much better at communicating.
But one question in short.
The public still think of climate change, I think, as an environmental issue, but of course at heart it's a public health issue. So this is something that all health professionals can do, and I think it's going to become increasingly crucial in years to come. So we have a lot of work to do, and I think we've had some successes, but we really haven't had the impact that we should do. Now the next question is about COP27. So COP27 is an important opportunity, but let's be realistic. COP will always go at the speed of the slowest, because it's a consensus process. So you won't get the speed of action that many of us want to see just from COP. That doesn't mean to say we abandon COP. Of course we have to keep pushing for better agreements and for implementation of those agreements. But what's really important now is national and local collaborative action around the world to really ensure that we do decarbonise as quickly as possible. And that cannot, as I say, we just can't wait for the slowest countries at COP. We will need to engage in a whole range of actions using perhaps the healthcare system as a kind of spearhead of action, but not limiting it to the healthcare system. Trying to have an impact on other sectors as well. And then the second point about should we emphasise more of these tertiary impacts? Well, yes, sure. I mean, of course we need to keep emphasising the negative impact, but we also know that just telling people it's all going to be catastrophic doesn't necessarily motivate change. In fact, sometimes it increases populism, it makes people feel inadequate, helpless. We need to, on the one hand, emphasise the risks and dangers, including of migration, but on the other hand, we need to emphasise the solutions and say the solutions are at hand. The point is that the political will is not there to implement them. And we need to change behaviours. We should change our own behaviours, and we need to change behaviours of the population more broadly. Now, behaviour change is beginning to occur. We are seeing, certainly in the UK, we're seeing a lot of young people are eating less meat, for example, eating more plant-based foods, driving less, and so on. But there's still a long way to go. So there's a great deal of work to be done. So no easy answers, but we've got to emphasise both the threats and the crises ahead and currently with us, but also the opportunities and the steps, the positive steps that we need to take.
Thanks, Andy. And one last very short question and also a short answer. I came up here because my throwing skills are limited and I almost knocked out Birgit Teichmann. You haven't seen this, so there's drama on our side here.
Hello, my name is Kathy, also from the Institute of Global Health here in Heidelberg. I have a question concerning health policy. So how would you relate the role of policy documents on adaptation, including the NDCs you just mentioned, but also national adaptation plans or strategies of countries, including health national adaptation plans, in terms of the legal status, leading to implementation?
Yes, well, many national adaptation plans, of course, don't give enough prominence to health. It does vary a lot by country to country. Some of them have very nice statements in the plans, but of course the point is always, are these plans implemented? Are they really put into practice? And what lessons do we learn when we put them into practice? One of the concerns I have is that there's very little evidence base around adaptation. We propose all sorts of adaptations like heatwave early warning systems and various other early warning systems, which probably do have a beneficial effect. But it depends very much on how the health system responds to those early warnings, whether they're effective or not. So I would argue, first of all, for greater prominence of health in national adaptation plans. Secondly, ensuring that we actually implement what we propose in these plans. And thirdly, that we evaluate it. And that's an important role of public health research, is how do we evaluate the impact of these national adaptation plans. So quite a big agenda there, but you mentioned regulation of the law, and just in closing, I would say, increasingly we're being approached by colleagues in the legal professions. And increasingly, I think we're going to be giving evidence in a number of litigation cases, either for young people who see their future blighted by climate change, or by those populations who are experiencing the impacts of climate change right now. So I do see an important intersection between public health and law and legislation. And yeah, I think we're going to see increasingly prominent legal cases.
Thank you so much, Andy, for taking the time not only to give the talk, but also to answer some great questions from the audience. Thank you so much. So I think we owe him a clap of hands. Hope to see you soon in flesh and blood in London, maybe. And with this, thank you and bye-bye.
All right, everybody. Welcome to the first session of our dedicated speakers of today. Hans Christian, kindly take a seat. My name is Ina Dankwa. I'm a professor on sustainable nutrition here at the Heidelberg Institute of Global Health, and I'm leading the working group on climate change, nutrition and health, and feel very pleased to be able to chair this first session today with you. And we are having 4 dedicated speakers of that session, which is on adapting to the climate change impacts on health. And I would like to introduce our first speaker to you. It's Professor Sylvie Jousson from the National Research Center in Paris. Sylvia is a climate modeler, and we are very much looking forward to hear her words and her impressions on climate change impacts, as well as how they could lead to adaptation strategies for the future. I think most of you know Sylvie for her work on the IPCC reports. And please give her a warm applause and welcome her to that session. Sylvie, the floor is yours.
Thank you very much, and thank you very much for the invitation to give this talk on climate projections in the aftermath of COP26 commitments. Not that easy to talk after the great talks of Michel and Andy, but okay, let's try. So climate projections, that's the fields of climate modeling. That's indeed the field in which I work. And those models are quite key to better understand and predict climate variability and change. They represent the atmosphere, the oceans, the land, and they can be used to study how the climate system answers to natural and anthropogenic forcing. The international community is very structured within the World Climate Research Programme, and we conduct international coordinated experiments, which are called CMIP, typically for the global models, or CORDEX for the regional, which are coupled model intercomparison projects, which you probably have heard about because of their projections, but it's not just projection. Those are consistent set of simulations to understand, evaluate, and provide projections. All the data are open. There is an open database, international, which is called the Earth System Grid Federation, which in Europe we support through the EasyNest infrastructure project that I coordinate, and which also provide some of the data to the Copernicus climate change system. We are talking about a system of data database of 30 petabytes and more than 15,000 users. So climate models are behind 2 of the key results related to climate change. On the left side, that was shown already by Andy, you have the observations in black and 2 sets of ensembles of simulations with natural forcing in blue and natural and anthropogenic forcing in beige, showing that it is absolutely impossible to reproduce the observations without taking into account the anthropogenic forcing, that is to say, the greenhouse gases and the aerosols. That led to conclude that it is unequivocal that human influence has warmed the atmosphere, the ocean, and land. On the right side, you have the global projections, which is one of the most popular type of curve, which shows that highly depending on the scenarios, you can go from 1.4 to up to 4 degrees in 2100 projections, depending, of course, on the scenarios. So the warming anyway we are committed to continue to grow for the coming years. This is accompanied by a number of impacts, and Michelle already gave quite a lot of very good examples, and Andy also gave results on that. So we not only have the warming, but we have the heat waves. On the top left, the results from the working group 1 shows that you have the amplitude, which increases with the scenario, and that the amplitude can even be more bigger for the extremes, with, for example, 5 degrees hotter for 4 degree global warming. And also the frequency, which can reach up to nine times what was in pre-industrial time. It's not only tackling the temperature, but also all the hydrological cycle. With increase of temperature, you have an increase in total precipitation, but this goes with heavy precipitation, so you have more floods, but also risk of droughts in some regions. On the right, you have heavy precipitation over land, showing that there is also an increase in the frequency and in the intensity, depending on the scenario once again. And it's not the only effects that you have associated with climate change. You also have the risk of fires, the risk of sea level rise and storm surges, which is also quite an important risk. And the changes in temperature and hydrological cycle have an impact on ecosystem, agriculture, and food. Corals were also mentioned, but for agriculture, there is quite some risk, especially in the tropical regions. So all that have an impact on health, either a direct or indirect health, as was already mentioned by Andy just before. I would like to focus on the rate of change. So it's not much the total amplitude of change, but it's how fast we go to this amplitude of change, which is a big risk. So I think we should quite focus on the rate of change. We did a study with two PhD students of mine, Chabayas and Brouillet, and we looked at look on the left, 20-year windows. In blue, you have a 20-year window distribution of temperature, and in yellow, the 20-year window, the next 20 years. And we wanted to look at how much, when you have, how much it is, the change will be perceived. Of course, we are not going to look at the change looking at what happened at the pre-industrial time. That's not how people are going to leave the change. They are going to leave the change, leaving with the experience they just had in past decades. So if you look at the blue curve, some events that are happening only once every 50 years, so really the tail of the curve, you see that if the change of temperature between those two 20 years reaches 2 sigma, the variability of the system, that means that something that happened the past 20 years only once every 50 years, the next 20 years are going to happen 1 year over 2. So that's a big change, and people, that's how they will leave the change. So we looked at how much this is going to impact the population, what is going to be the exposure in percentage of population. The green one is with a mean temperature, and you see that if indeed we are in a high scenario, that's the RCP 8.5, we can reach 50% of the total population that will have this feeling of the past, what they had in their childhood was exceptional. The next 20 years will be really completely common. But we also looked at extremes. You have the yellow curve for extreme temperature. And for extreme temperature, the curve is lower just because the variability is much higher. But what was even more interesting is we looked at extreme heat stress with the well-bulb globe temperature in pink. And you see that for extremes in the heat stress will be stronger than for the extreme temperature. So it's not much the speed of the heat extreme that will stress that will be faster, but it's more that it will be really felt as varying much more. But heat stress, of course, is something which is more felt by the human body. What about policy related to this and the COP? Let's come to the COP26. So concerning mitigation, the 2015 Paris Agreement goal has looking at all the impacts and their link with the amplitude of change to limit to 2 degrees and ideally 1.5 by the end of the century. And the countries have provided NDCs, so the nationally determined contributions. And for COP26, there has been an update of those. And on the right, you have the update in the emissions corresponding to what has been done between 2016 and 2021. And there is about 11% decrease in the level of emission committed by the NDCs in 2030. So it's not negligible, but not very strong. And this has been taken into account by the IPCC Working Group 3. And I particularly like this figure from the Working Group 3 because it clearly shows you where we are in the terms of emissions, where we are in terms of implemented policies. So if we do not do more than what is already implemented, we will be in the red curves. And what would be needed to limit to 1.5, the blue ones, what would be needed to limit to 2 degrees, the green ones, and where we are with the NDCs. So you see that the NDCs, indeed, you have a small inflection, so there is a small decrease by 2030. But if we want to limit to 2 degrees, there would be really a need to strongly decrease and reduce the emissions. So the NDCs are a first step, but clearly not enough. And the Working Group 3 even concluded that warming likely to exceed 1.5 degree if we stay with this level of NDCs. On adaptation, the COP26 document also includes elements on what are the priority areas dealt in the different adaptation plans. And you can see that the topics that are there in percentage of the different countries providing adaptation plans, you have food production and nutrition security, freshwater resources, terrestrial and wetland ecosystems, human health is there. So there are some steps in taking that into account, not necessarily that much yet, but probably still more to do. On so the Working Group 2 emphasizing that indeed the system is not just climate change and human society. What we really need to take into account is climate change, human society, and ecosystem. And all this system is linked, and in the middle you have health. That means that if we want to really have a more resilient society, we need to tackle climate change, human system, and transition. For that, different approaches of modeling and interdisciplinary approaches can help. I led an interdisciplinary consortium some years ago, and we had a program on climate change, ecology, and health. And one project was on pollen allergy and climate, linking coupling models for phenology, for pollen transport, and allergy risk. And they were then involved in a European project where you see ragweed maps for 2050, showing that with climate change, we have a 4 times increase in the amount of pollen in the air associated with climate. With the models, you can disentangle what is the role of seed dispersal, so invasion part, and climate, and they obtain that climate explained 2/3 and seed dispersal 1/3. So we can learn a bit more about what are the different factors by combining. So to conclude, COP26, there are some improvement. We are still, but there is still much more needed to really limit climate change. Interestingly, COVID-19, there were some CO2 emission, and this has been evaluated in the IPCC reports, Working Group 3, Working Group 1. The decrease is about by 5.8% in 2020 versus 2019. But Working Group 1 clearly says that it is undetectable above climate variability. That it has a positive effect on pollution, but on climate it's difficult to really see it now. On research gaps, I could mention gaps in climate modeling, but I'm not sure that it is really the topic of this conference. Of course, we need to really improve precipitation at regional scale. We have to better quantify and reduce uncertainties. We have to better tackle the complexity of the system, especially the carbon cycle. We have the risk of tipping points. We have a number of things to address. But for this conference, I would like to push that for adaptation and increasing resilience, there is a need to foster more interdisciplinary approaches on climate, ecology, and health, and I would add also society. So really better tackling this overall nexus. Maybe we could push for a nexus on climate, ecology, health, and society, like there is a water, food, energy. And, but it's not just, I mean, pushing interdisciplinary from the experience I had in the past decade requires to nurture interdisciplinary, really to push that. Otherwise, you have a trend to stay in your disciplines. It needs to take time, more time than just working on its own discipline, to understand the concepts of each other. So it needs to be nurtured. So yes, that's what I would like to push for this conference. Thank you.
Thank you very much, Sylvie, for this excellent overview. And I think you've also showed us very nice examples how we can make it tangible for people to understand what's going to happen. I really like the approach of looking at extremes during your childhood and how often they will occur later when you are an adult. We do have time for 1 or 2 clarification questions, but please be aware we have half an hour approximately at the end of this session for a panel discussion with all our 4 speakers. So I hope that our microphone box is ready. If not, you can also raise your hand and maybe shout. We are not too many. Are there any questions to Sylvie at the moment? Not yet. Well, it seems that was an excellent and well understandable overview.
Maybe a bit too fast, but but anyway, we can discuss later, and do not hesitate to come back to me at the breaks also.
Thank you so much, Sylvie. Please give her another round of applause. This gives me the pleasure to introduce our second speaker for this session on adaptation possibilities. And just as Sylvie, he is also a very well-known scientist. We would like to welcome Alistair Woodward, who made the long way from the University of Auckland to meet us. I learned he's also going to join the marriage of his son, another very important event to join and good reason to come to Germany. And Alistair is a famous epidemiologist and public health researcher. And most of you will know him also for his climate change and health research with a particular angle on the social determinants of climate change and health. So please give him a warm welcome. And Alistair, we are looking forward to your talk.
Well, thank you for the invitation. Thank you very much, Rainer, for inviting me to come. There were 2 speeches that I was thinking about on the plane over. One of them I thought would be relatively straightforward, and one of them I'm really quite stressed about. I thought talking to you would be talking amongst colleagues, be a welcoming audience. I've been to Heidelberg before. I very much like it here, and so I wasn't too bothered about this. I thought it would be a very interesting, enjoyable, stimulating sort of an environment. The speech that I'm really worried about is the one that I have to give next weekend at my son's wedding. I've got no idea how German weddings operate. Maybe you can give me some advice on what I should say and what I shouldn't say. You know, I'm conscious that there are cultural differences between New Zealand and Germany, you know, to do with things like recycling and taking notice of traffic lights, you know, which are quite different sort of cultural practices. And I, above all, don't want to cause offence by whatever it is I say at the wedding or don't say. No nasty childhood pictures. Okay. All right. Could I just begin by referring to a couple of things that speakers said in the first session? Rainer pointed out that climate change and... Ooh, just a mishap at the back. Yeah. Is all good at the back? Yeah. Okay. So Rainer said when he opened the session that climate change and pandemics had some things in common. One is that there has been spectacular science in both areas in recent decades. And the other is that the application of that knowledge has been uneven. And it's that which is a question in its own right, I believe. Why is it? How could we do better? As Dean Williams said, that question about how we could do better resonates particularly for those of us working in public health, because frequently that's what drew us to the discipline in the first place, trying to make a difference. And so my talk is not looking so much at the things that public health has done well in the past, and there are many, which we should continue with, but looking at some of the things where I believe we have an opportunity and indeed a responsibility to try and do better. Now this slide here is a graph. It comes from New Zealand. It shows our national greenhouse gas emissions from 1990 to 2020, so that's roughly half the lifetime of the Heidelberg Institute of Global Health. And the three lines show at the top gross emissions, then the middle line is net carbon emissions, gross carbon emissions, and the bottom line is net carbon dioxide emissions. Now, New Zealand's peculiar. I won't go into it in terms of its greenhouse gas profile. Roughly half our greenhouse gases come from short-lived forcing agents such as methane. And we also have a rather peculiar national policy of ignoring the short-lived agents and only concentrating on CO2 and other long-lived gases in terms of setting our goals. But the important point that I'm wanting to make here is that this period is essentially the lifetime so far of the IPCC. The first assessment report was in 1990. The sixth report, of course, came out this year and last year. Over this period, when there have been, I've estimated, roughly 12,000 densely printed pages of very good science produced by the IPCC, New Zealand greenhouse gas emissions have not reduced one iota. And there's some irony in the fact that at the time of the first assessment report, New Zealand was actually quite close to being net carbon zero, and that is now a distant and very challenging goal for us for 2050. So a period in which there's been spectacular science indeed, and yet very little progress in terms of greenhouse gas mitigation. This led me and two colleagues to ask the question, how can public health add value to climate policy? Kirsty Wild and John Samet worked with me on this, and there's a paper that we hope will be published later this year, which is based on 20 years of literature on climate change policy and public health, in which we picked out 4 themes. I'm not going to talk about the first 3. They're really examples of public health doing well. And the 4th one, I think, is one of these growing areas. This is a symposium about growing areas, about thinking about research needs in the future. And so I'd like to spend a few minutes talking about the 4th of these topics, which is engaging with advocacy and activism. The point being that we've heard lots of examples already of very good science about the relationship between climate action and health. Many, many examples of co-benefits that can be achieved, including in the transport area, which is the point of my picture here. And yet, this information has frequently done little, unfortunately, to spur climate action. I work largely in the area of transport and public health, and we have plenty of examples in New Zealand, such as this one here, which is a bicycle lane in a suburb called Island Bay in Wellington in New Zealand. A very small and, by European standards, exceedingly modest intervention, backed up by very good science about mode shift, emissions, public health, and yet fiercely resisted. This is a paper that appeared last year in Lancet Planetary Health, which has sort of expanded that thinking to look at what the consequences have been of framing public health, of framing climate change as a public health issue in terms of the effects on policy. And there's an argument here, which I think is a very cogent one, and I'd recommend the paper to you, saying that this is not surprising, because unfortunately in public health, we tend to work with a very limited and simplified notion of the relationship between science and action. You know, we're all linear thinkers. We think that making a change over here will lead to a change there, will lead to an outcome. And in this instance, we talk constantly about knowledge-based policy, about science-based policy. The idea, it's embedded in the IPCC, that if we produce good information, it will be picked up and used. And in fact, policy making, of course, is so much messier and more difficult than that in practice. This has led us to think about, are there opportunities to learn from past public health successes? And for those of us, of my and Rainer's generation, of course, we came up in public health in the era of tobacco control. And I'm not saying that tobacco is solved, by no means, but there have been very big advances, particularly in high-income countries. This is a very interesting monograph written by Simon Chapman, who was at the forefront of tobacco control in Australia and New Zealand, about what it was that made the difference, made the biggest differences in tobacco control. I'm going to pick up what I've written on the bottom right-hand side. It's only one of the things that Simon talks about, but it's provocative, it's important, and it's clearly relevant to climate change, in my view. Simon talked about vector control. Any idea about which vectors he had in mind? This is tobacco. Sorry? Human? Well, they are human, although sometimes they don't behave that way. Industry, yeah. So this was talking about how important it was with tobacco control to pay attention to industry action. This is coming up in our discussions in New Zealand about why it is that we're not moving forward. Guy Salmond is a so-called blue-green environmentalist. He's an environmentalist, but with strong connections with business. So I was really interested when he was pressed about this point, and his comment was, we don't take responsibility for the future, and secondly, we are unduly deferential to vested interest. I think there's a lot of truth in both those observations, certainly in New Zealand. And the general point is, I believe it's not the science that's difficult to accept, it's the consequences of the science. Brought home to me earlier this year, New Zealand of all places, you know, we have a very strong science community. We like to think of ourselves as being environmentally focused, socially focused, very low levels of corruption, very high levels of trust. And yet, the New Zealand delegation to the plenary meeting where the report from Working Group 2 was signed off was instrumental in getting plant-based diets, all reference to plant-based diets, taken out of the summary for policymakers. Any thoughts about why this might have happened? New Zealand beef was the suggestion. It's not so much the beef, but it's certainly, New Zealand makes an awful amount of money. It's sort of what cars are to Germany, perhaps. Milk powder and lamb are to New Zealand. You know, we export food, and in particular food produced from dairy farming and from sheep farming. Here's another example. The reference was made, I think it was Andy Haynes who made the point about coal. You know, coal is at the heart of the climate change challenge. And it has to stay in the ground or we're cooked, you know. The Biden climate change bill was scuppered for a number of reasons, but instrumental was this man in terms of the way he voted down the legislation. The New York Times daily podcast has done a really interesting broadcast on Joe Manchin's background and the conflicts of interest that he experiences and why that may, at least in part, explain the way he voted. Sometimes these conflicts of interest are more subtle. This is a sustainability newsletter produced in New Zealand by a relatively progressive, new, young media organisation. I was keen to sign up to it. I began to fill in the form until I got to the point where I was asked if I would like Hyundai to help me with my electromobility choices. Hyundai is the major sponsor of this sustainability newsletter. Now, how does that make sense? What sorts of conflicts of interest might arise? Well, here's one. In New Zealand, our fleet is upsizing. We're going in exactly the wrong direction. And it's largely as a consequence of extremely heavy marketing and promotion of vehicles of this kind, the light truck. Now, what will happen to that media organisation when they contemplate removing advertising for fossil fuel products and in particular petrol and diesel vehicles? What can we learn from past public health successes? What would it be like if we took seriously the welfare of future generations? And confronting the commercial determinants of climate change. Where might that lead us? And I offer you this book. Has anybody read this book? The Ministry for the Future by Kim Stanley Davidson. It's a science fiction book, but it is very relevant to all these questions and very relevant, I think, to the issue of climate change, which we're talking about this week. Thank you.
Thank you very much, Professor Woodward, for this fascinating overview and also for reminding us on our responsibility in the society as scientists. So good science is just the starting point. We have time for one or two questions for Professor Woodward. Are you throwing it?
Yes.
Who first? Oh, she was first.
kind of slipped out of my hand. Okay.
Okay, next time, by the time we've thrown it up, maybe you guys come down.
Yeah. Well, that was fun. Thank you so much for the great presentation and the reminder that we need to think about industry interference in these policymaking and also taking into consideration commercial determinants of health for climate change. So one of the questions that my colleagues and I have been grappling with is this question of how then should us as scientists engage with industry? Because you've referred to tobacco, and in tobacco control, there's the FCTC, where scientists essentially don't engage with industry. So just wondering what your thoughts are about that. Thanks. Should I throw it back?
I think that's a really good question. Maybe it's not something I can respond to quickly. We learnt an enormous amount, I believe, from the tobacco era in terms of the perils of getting too close to industry. But at the same time, I think we need to recognize that tobacco maybe has some differences to climate change, and many of the industries, like Heidelberg, that have a part to play in climate change. It's not the same as tobacco. We're not talking about a ban on cars. It's perhaps climate change is a bit more like alcohol. There is a place for the product. It's a question of how it's used responsibly. So it's more subtle, it's more nuanced, but I think it would be foolish to ignore the role that the commercial determinants have in explaining why it is that we're not making progress.
Thanks, Connie. Joachim?
Yeah, I actually had a similar question, but I have another one too. First of all, the talk was great. I think it's really important to think about translation and actually research going into policy and making a difference. And there's often this discussion whether, in research versus activism, and I think there's two different groups there. There's the activist like Richard Horton, who thinks we should be more activists as researchers as well. And then there's the sort of science community and some representatives who's more sort of, we should be scientists, and it's part of, credibility. Being a scientist, we can't engage too much. So how do we draw the line? Like, what's actually a good model in terms of doing research and also trying to make a change without, is there a risk that we be engaged too much or be seen too much as activists? How do you look at this?
Thanks, Joachim. No, a good question, and it's on everybody's mind, I think. What can we do in our particular role? We're not political scientists, we're not full-time agitators, we're scientists, we're social scientists, we're physical scientists. Again, I think the first thing, two things. We need to talk about it and to try and explore this topic and understand where we feel comfortable. And secondly, I do think we can pick up some things from history. I remember at public health meetings, people saying our role as public health professionals is to do the studies. So let's do the 351st study that shows that lung cancer is bad, that smoking is bad for people's health. That's our job. And people moved from that position to say, particularly as public health professionals, we should be engaged in the translation of that knowledge into action. What's holding it up? Where are the blockages? Where are the opportunities for action? And so the whole sort of field of implementation science rose and prospered, because that was obviously the need of the time. Even Sir Richard Dole, who began by saying, I'm an epidemiologist, that's what I do, ended up appearing in court, defending cases against the tobacco industry, because he saw the need and the opportunity, to contribute his skills to actually putting knowledge into action. How do we move from anxiety to action? That's the big question of the time.
Thank you so much, Joachim and Alistair, for starting this philosophical discussion. Let's see how we can move on with that at the end of that session. Until then, I would like to welcome our third speaker of that session, which is my dear colleague, Dr. Alissier. He's from the Health Research Center at Nuna, Burkina Faso, and he's probably one of our closest and long-standing collaborators when it comes to help us in this large research unit that Till and Rainer have already mentioned in the beginning on climate change and health in sub-Saharan Africa, and is one of the experts when it comes to health and demographic surveillance systems on the subcontinent. So I'm very much looking forward to your talk today, Ali. Welcome, and the floor is yours.
Thank you, Ina. I would first like to thank the organizers for giving me this opportunity to stand here in front of this assembly. It's a very great symposium to talk about the data, because since we're here this morning, it's not easy to stand after all these good speeches, but it's still okay to talk about the data, because what we have seen since the morning is all about climate change, going to adaptation strategies, to mitigation, and to projection for the future, because this is long-term issues, not only solution right now will make it. So we have to think along ahead of us. So my predecessor said, better information may spur climate action, but often it doesn't. I would like to add, it should, but unfortunately we don't have the good data anytime we need it for decision making. So my talk is about linking the climate and health core data in Africa for research, early warning, and policy. So this is all about collecting data, generating data via research, and for adaptation going via the early warning and response system, and make it policy relevant as well. So we know in Africa it's a little bit different from the developed countries, where we have a well-established demographic information, civil vital event registration is well done, and the health system data is also good managed. So in many low and middle income countries, like in sub-Saharan Africa, there is a lack of effective and comprehensive demographic data. And this is also true for the health system, where the health systems that are not well capacitated to generate good data, and also accurate data. I mean quality data and comprehensive data. That is well explained, because you know, to get a comprehensive data, you should get a good health attendance rate, which is not the case. Not all the patients are attending the hospital, so you will not get the clear figure when you limit yourself to the health data. This is how the demographic surveillance system came into the system to complement this data gap, getting comprehensive demographic data, and also expand later to get some health data. And this health and demographic system, the surveillance systems, they have some strengths. The first strength is that they are monitoring the birth, death, the cause of death to ascertain, by verbal autopsy to ascertain the cause of death, migration, and other health and socioeconomic indicators are also collected by this health and demographic surveillance system. The second strength for this system is they have a temporal coverage. They are collecting data over time, and they also have a strong link with the country other system. So here to show you, for those who are not familiar with the HDSS concept, this is how it starts. It's a defined geographical area and a defined population, starting by a census, where we get to have the cohort that is established, and you keep on following this cohort, collecting data on birth, death, migration, in and out migration. So this cohort will grow up with the birth data and in migration data, and it will decrease with death and out migration. So adapting to climate change and its health impact is all about to improve early warning and a response system to climate change phenomena. And also, it's about research. It needs a strong research capacity in country. And the HDSS are currently in a good position really to contribute to the early warning and response system and research in sub-Saharan Africa. But to be able to do this, there are some weaknesses that need to be filled. And first is to expand from the demographic data to health data, not to collect only data on birth, death, and migration, but also add some health data. This is one thing. And the second thing is also not to only concentrate on health and demographic, but also add climatic data and environment data as well. This is by this way that health and demographic surveillance system could really contribute and be policy relevant for early warning and response system, despite the limited geographic area, because this is most of the time the criticism that is coming from people. So this is the concept, the conceptual framework of early warning and response system. Sorry, this concept is not from me. I borrowed it from WHO. This is not mentioned here. Forgive me about this one. So a good early warning and response system is all about quality, standardized and formalized data collection and analysis. So this is the basis to have a good early warning and response system. And after that, it's about epidemic intelligence. This epidemic intelligence is a systematic collection, analysis, and communication of the information to assess, investigate event and health risk. And it integrates two types of information collection. The first one is the indicator-based indicator surveillance, which is a structured data collection. This structured data collection is mainly health data, but not limited to health, because we have also metadata, environment data that could be had. But as a process, this needs to be systematic, it's routine, and mainly a passive data collection. So some examples are epidemiological surveillance. We also have mortality data, lab data, and research data is also part of this one. The second group of data is event-based surveillance data, which is formalized, it's flexible, it's active data, but it's unstructured. So these are mostly data coming from the media, the community. So as soon as there is an event that is going in the field, this data collection could be organized to serve the purpose. So how do HDSS best contribute? So to better contribute to this early warning and response system, we should continue the demographic dynamic assessment first, and to add climate and weather data by daily met data, or to have the data from the nearest national weather station. So online data can also be downloaded and analyzed with this data set. And we need to also capture morbidity data. So for this, we have our example of the DFG research unit, where we managed to have the MET data plus the demographic data and health measurement data. The demographic data in this study is collected based on tablet, and all the data are sent on the cloud on a server where you can download and do your analysis. So this is a linking with the climate data. With the morbidity data, we have examples. Our example is a comprehensive disease assessment, which is collected directly within the HDSS. It's a sample of the HDSS, 10% of the households that we are collecting. And this is collected all over the year to avoid the seasonal bias. And it concerns chronic and acute disease as well. The other model is the comprehensive health and epidemiologic surveillance system, which is a linkage from the health facility data to the HDSS data. So we have this demographic data and the facility data. When the patient comes to a health facility, it will be prompted to the server and will get the data at the same server with the demographic data. But to be frank, this tool has strengths and weaknesses. If you go to facility-based data, you will get 30 to 40% of the data given to the health attendance rate. If you go to community data, you will not get the clear picture. So the good thing will be to have the two combined together, to have the community data and the facility data as well. So this is a research framework. It will allow you to have a population data to describe the transition, to explain the transition and the consequence of the transition at population level. And at the individual level, you will be able also to map the health status of the population as well. So this is my last slide to say that linking climate and health data is possible. It has some requirement. HDSS can play a big role, but they have to improve. So, as I said, HDSS, they are locally represented. How a locally defined HDSS could efficiently contribute to national early warning and response system, this is a question that we need to answer. And how to build a reliable epidemic intelligence for an effective early warning and response system. Thank you for listening.
Thank you very much, Ali, for making this strong statement and advocacy for our health and demographic surveillance systems. We have time for one question. I promise you don't have to catch the cube. I also come up with a microphone.
That's an honor. Well, thank you, Ina. Thank you, Ali. Great presentation. Of course, we've working on this together with many others. You mentioned very rightly in your slide, how can we integrate these extremely data-rich islands of excellence with the national, pretty thinly and not so well data-wise equipped system of early warning? That is the conundrum that we all face. Maybe you have an advice, and maybe others have an advice.
So maybe I was too fast, I didn't talk about this one. Let's say that the problem with the HDSS data is also that the access is limited. So the complaint of people is to access the HDSS data because you have to go in contact to these people handling the HDSS to get the data. And the second thing is that it's like two people sitting separately, not talking to each other. And this is really a gap for us to fill. And my belief is that we need really to have a strong collaboration with first the Statistics Office and the HMIS, the Health Management and Information System. These two offices should really work closely together with HDSS, inside HDSS, because if you take the example of Burkina Faso, we have like 4 or 5 HDSS, so which is really enough to really complement the health management and information system.
Thank you very much, Ali. Thanks, Rainer, for the question. I hope we will talk more about who to convince also to increase and enlarge that capacity and make those voices heard. Until then, and you can think about more questions, I would like to welcome, last but not least, our fourth speaker of the session. Professor Manuela de Allegri. She's our health economist and health finance specialist at the Institute, also involved in the climate change and health in Sub-Saharan Africa research unit. And I'm very much looking forward to hear from her about the economic point of view and her work and views on that aspect in climate change and health. Welcome, Manuela.
So, good morning, everybody. First of all, let me say how pleased and honored I am here. I didn't realize among such big names I will be talking, not exactly as a climate expert. So thank you very much, Rainer, for the nice opportunity. The second thank you I want to give, and I really mean it, as I was coming here this morning, I realized this is the 60th anniversary of the Institute, and it's my 20th year here, which means I've been here for a third of this life. And then, as I came here, I realized this is like a gift to me today, because I would say, you always say it takes a village to raise a child, while it takes a village also to raise a good scientist. And my village is here today. Heiko, Jenny, Kamala, Vika, Olaf, Albrecht, all my entire village is here. And I felt immediately even more honored. And so now I'm thinking, oh my goodness, I have to live to this expectation. And I'm actually a health financing expert. I'm not really a climate change expert. But those of you who know me well know two things about me. One is that you can get me excited about any topic. So it took Rainer a bit longer than it took other people to get me excited about climate change, but he has managed. And the second one is that I'm a very loyal person. So I feel very loyal towards this institute, and I feel very loyal to have to continue in its tradition also of research in this field. And that's why I'm standing here. But of course, you have to find a bridge to what I'm an expert on. And I'm an expert on health financing and specifically on insurance. So how did I get to step into climate change? Is actually by looking at insurance. A different kind of insurance, not insurance for health risks, but insurance from agricultural risks that result from climate variability. And that's what I'm going to talk to you about today. And I feel it's so nice because we have taken really from the big picture of Sophie, from the climate model, all the way down to the political aspect by Alistair, the need for data. And now we're looking at the specific adaptation strategy. And I'm going to try and link as much as possible to Ali, what are the needs for data in this case. Now, first of all, what is the problem as we know it? Well, another thing people know about me is that I don't like to stand still, so it's going to be very tough for me to stand here and not move around. Is that there is obviously in Africa very high dependence on subsistence farming. And subsistence farming exposes farmers to risks. Because obviously, if one year the weather is bad, there is a high chance that crop production will be low. And bad can mean anything. We always think of droughts, and we always hear talks about droughts. But actually, the data at our disposal, also from NUNA, suggests that it's really these extreme weather events that nowadays are affecting crop production and therefore the livelihood of households. And here, I try to think very, very simply in graphic form of what do we mean. There is weather variability. Weather variability impacts crop production. Poor crop production impacts food availability. And in addition to that, it's not only the food that gets on your table that is less, it's also the crops you have to sell that become less. And if you have less to sell, you have less money. And if you have less money, what do? You go to spend your resources, your stock up. And your stock up is your goats, your cows, the pigs that you have. So you deplete your assets just to keep your survival going. And if you do that, you initiate a vicious cycle of impoverishment and poor health. And I think poor health, as you can see directly, because in a way, if you have less food, you have more malnutrition. Impoverishment, if you have less crop to sell, you have to deplete your assets, and that leads to impoverishment. And actually, people like me who have spent their entire academic life thinking of how to protect people against the adverse consequences of ill health because of the link to impoverishment, can easily find a connection to say, oh, wait a second, we have to do something to stop this vicious cycle as well. It's just as bad as the one resulting from bad health. And this is just, in a way, like a side note, linking back to what Ali has been talking about, to show you that this brief diagram is not something that I've come up out of my own mind, but that there is really evidence. And that if we link population-based data, this is beyond just the HDSS. This is a database that I happen to have because of a different study, actually. Linked with climate data, you can actually find tangible evidence that weather variability, in this specific case, excessive rain, too much rain, and too much rain not at the times of the year you probably need it, leads to children poor nutritional status. Now, people have come in and said, wait a second, we have to break this vicious cycle. How do we do it? Instead of health insurance, let's offer people crop insurance. Sorry, there is a mistake here. I didn't want to say immediately index-based weather insurance. I wanted to say simply crop insurance. Basically say, I insure you in case your crop is poor this year. So you get money back if your harvest is not as good as it should have been. And this way, you're supposed to break this vicious cycle. The problem with crop insurance is the verification of the loss. Put yourself in rural Burkina Faso. I've spent all of my PhD time there, so I know it's really rural, it's really remote. Going village to village to check, has the crop really not been as good as it should be? That's pretty tough to do. So people have come up with this alternative idea, which is index-based weather insurance. The idea is still that you insure the loss. It's still that you offer farmer protection against the potential of losing out on their crop, but you don't verify the actual loss, but you assume that a certain set of climate variability variables will lead to poor crop production. And the moment these conditions are met, you have the payout to the farmer. Now, this is being currently talked about as a potentially very powerful policy solution to a very well-known problem, which is only likely to become an even acuter problem because of increased climate variability due to climate change. I'm not saying it's perfect. There are lots of problems with also this kind of model, and we can talk about them in the break or during the question session. But what I want to show you is that we have actually tried to sit down and think conceptually of all the mechanisms of change through which index-based weather insurance could actually break this vicious cycle. And I want to share here an experience from health insurance. It has actually been shown that the moment poor households have health insurance, they keep their children in school. Okay? You can say, what does health insurance have to do with keeping your children in school? Well, if you know that your assets are protected, you're more likely to make investments in other areas of your households. So the expectation here is not only that index-based weather insurance could break this vicious cycle directly, but that it could act on multiple levels against breaking this cycle of impoverishment and poor health. Now, the good news is that people have actually sat down, among these people also us, to try and figure out how this could work. The evidence is very, very scanty. You'll be amazed how scanty the evidence is. And the evidence out there doesn't actually link index-based weather insurance to health in any way whatsoever. So people have actually not looked if the moment you offer protection against a potential bad crop, you spend more in health services. You are more likely to actually send your children to school, keep your children in school, and get them away from the fields. All of this we don't know. And we don't know if health status actually improves, if the nutritional status of children actually improves. So we have these studies, but these studies really only look at the most immediate impacts in terms of like very short-term asset protection. So, as I said, we don't know anything about the impact of index-based weather insurance on broader dimensions of welfare. We have not looked at what it does in terms of dietary diversity, nutritional status, and health status. Does it mean that because I'm protected from loss, I start feeding my family differently? I actually make a different use of resources. I make different decisions about intra-household allocation of resources. We don't know all of it. We don't know if it actually improves health status, and we don't know what is its value for money. Because obviously, a caveat of this is that this is not necessarily a cheap solution. We need weather stations close to the villages to actually capture dimensions of climate variability which are really relevant for one specific village or one specific set of villages. We need to calculate premiums. We need to be able to collect this money. So this is a solution that bears some costs, and we have absolutely no evidence about it. So looking forward, what would I like to propose? I am probably not one of these scientists who always sticks to her scientific neutrality. Although I try to as much as possible, I'd like to say we need more investments in index-based weather insurance. We need to try out this as a potential adaptation solution. And we need more investments in the research that accompanies it. I just came yesterday from a meeting again looking at how development cooperation needs to talk more closely to research. And I would like to say we really need to have accompanying research for development cooperation solutions, and we need to expand the scope of this research to also include more explicitly health. And I close with an image which goes back to who I am. As I said at the beginning, I'm actually a health financing expert. And most of you will know the image of the umbrella to signify universal health coverage. The idea that we all have access to care and are protected against financial losses due to ill health. We're all under one umbrella. I would like to imagine a world where we are also all under the umbrella of index-based weather insurance. Thank you.
Thank you so much, Manuela, for this very inspiring conversation and talk. I would like to invite our 4 presenters of this session. Manuela, maybe you can join me here for a few minutes of our panel discussion. So if you have direct questions to Manuela, please, you can post them now. But I would also like to invite you to maybe get back to some of the questions that have already been raised. What about our responsibility as scientists? How do we make sure that the right people who can invest in expanding our data sources are heard by us? And how do we make sure we all get under that umbrella? Just as a few examples of potential questions.
I'm Göran Thomson, Karolinska Institutet and SITE. My question is to Alistair. Rainer said that he wanted a statement. He wanted one of the outcomes, deliverables from this meeting would be a Heidelberg statement. I assume that power and power asymmetries will be part of that. I'm fascinated by the PPP, private sector, politicians, and the public. And we all know that there is an enormous imbalance of economic power between government and industry. I can give figures, I won't. So what's your advice here to rectify that imbalance, to avoid NATO, no action, talk only, in what this is all about? Thank you.
You have 5 seconds to think about it until I'm down here.
Maybe we could talk over lunch. But seriously, Rainer, if you're thinking of trying to craft a statement that might bring together what's been covered, over these 3 days, I think it would be a great pity if we didn't include some reference to the question of what stands in our way in terms of attempting to put good knowledge into strong action. I think that is something that as scientists we should pay attention to. And the question of power, politics, and money, just comes up all the time. It's something that you can't look past. How to deal with it, that's more complicated.
Hello, what such a great panel, Malavika Sharkar Black, James Pickens School of Public Health. My question is to Manuela, most of the countries are suffering from the catastrophic health expenditure. There's no health insurance, majority of the low-income countries. And so how do you vision that there will be index-based weather insurance, where the government is kind of failing to provide the security for the health?
Very provocative.
Provocative from my sister, I wasn't expecting that. I think there are two different streams of funding. So I think one is really health financing and another one is environmental financing. I don't think they are in competition necessarily with one another. I think it's about, I was recently on the Lancet Commission on health finance, and the idea is spend more and spend better. And I would say even in the environment, spend more and spend better. We're doing maybe other things, and this is a way that is at least worth trying on a more extensive base if it could work.
Thanks. I'm Peter Berman from the University of British Columbia. Again, to bring things back to Alistair a bit, I really appreciated your focusing our attention on this question of how knowledge gets translated into action. I hope this will be a theme we'll come back to many times in this meeting. But I would like to kind of ask you, and maybe ask all of us, to think about this as a topic of research that public health does not spend enough time and attention on. And one of the kind of concerning things I found in the discourse starting off is this idea that somehow this is different from science. There is a science behind knowledge translation. It's a science we could all develop further. I've been working with colleagues at UBC, and I appreciated you citing one of their papers on this question of how this actually happens. What are the organizational, political, and other structures that influence change? And how do scientists input to those processes? So I would like you to kind of respond a bit to this idea of how can we strengthen research on this important area of impact for public health?
Thank you. And I do think we've got a lot to learn from, the people in British Columbia and those researchers who have thought so carefully about what are the paths, what are the trajectories, what happens along the way. So I would like to underline your point entirely that this is definitely the domain of science. If we think of science as being thoughtful and critical and reflective analysis, this is what we should be doing, I believe, to understand why it is that the coal industry in the United States is standing in the way of effective climate action worldwide. What are the avenues of influence, and where are the opportunities to intervene? I think that those are deep and difficult and really important questions and require the best minds.
From your experiences, I think most of you have already been strongly engaged with stakeholders, decision makers, politicians, and some of you have already started to accompany that with research. Are there any examples that you would like maybe to highlight that can shed a bit more light on how we could do that?
I would like to pick up on a point that Andy made in his talk, where he referred to the intersection of public health and law as a really important one, and one that I think, is developing further with climate change. So I know that Andy and legal experts from the University of Oxford are working on the extension of attribution science to assist legal scholars thinking about responsibility and liability, because that's at the heart of much of the judicial action that, you know, motivates domestic action and might also stimulate international action, the question of loss and damage and liability. So I think that's a practical example of thinking about levers and opportunities to bring about change. Tools for transition is the sort of term more broadly. What is it that we need in order to make the very radical changes that we have to make? And one of them, I think, is getting public health people to work closely with people in legal studies to understand what instruments there are to motivate government and to bring about effective and ensure the implementation of effective policy. That's my suggestion.
I think there's now also a chair for you there. Sylvie, from your experience with the communication of your findings, would you say that this is also an important aspect, even though it goes into the NATO direction, but maybe the way we do communicate and we do talk about our findings is also relevant? Just pointing to that example from China.
Thank you. Yes, indeed. Informing is, of course, the first level. I think the fact that we have assessments like IPCC is crucial, because then you can really rely on really the best assessment possible and not just one voice, I think. But even that is not honestly enough. But I've seen since the last 30 years a really big change, even if in the action it's still difficult. On the information for climate, we are also quite developing what we call climate services. That means really working explicitly with the different sectors, taking time to understand how much they depend on climate, because people need to understand how much they depend on climate. They do not necessarily, because they are adapted, they don't necessarily realize that they may be impacted. So that's something which is underdeveloped. I like in this conference the fact that I think, yes, we could push more on this link between climate change and health, because I think this is something that people touch probably more easily than some other aspects, and it's probably not that well said and not that well known to a large audience. So those are different levels. But then the problem is that economy, we can see it, even if in Europe people want to reduce emissions, you have Ukraine and you need to limit import of gas. Some countries are restarting coal power electricity. So yeah, so economy is quite tough.
Yeah, sure.
I just want to share one thing, but more at the micro level in a way. And I want to share like more, it's like a very recent experience with. I think one thing is like obviously influencing the higher level policy, and that's fundamental. But I wouldn't underestimate the impact that each one of us can have on a small level. And recently, in writing a proposal, Edmund, Valerie, and I reached out to a number of local organizations in Burkina Faso and Kenya, the two countries where we are expected to work, without knowing them. And everybody responded, and everybody got interested, and everybody shared information, and we came up with a common research agenda and a common plan of how we can, if results are in a certain direction, disseminate these findings. And honestly, I would have not expected it. I would have expected, okay, I'm new to the field, we're just calling up people and asking, but people are responsive. And I think, of course, it's not changing the higher level policy, but it's making one specific set of change or initiating that. And I would really encourage people to just try out and call out people. People are more responsive than we expect them to be.
Yeah, thank you. For my experience in Burkina Faso, let's say they have a national adaptation plan where the objective is very clear. they have 6 main areas where health is one of them. But if you look at, frankly, in details, it's like the area on agriculture is performing well, and housing also is performing well. But in the health sector, where they clearly mentioned that the early warning and response system should be really reinforced, as well as the research. These are clearly mentioned as adaptation to climate change effect on health, but still it's not happening. We as researchers keep the dialogue with the policymakers, but they are receptive, as Manuela said. If you go to them, they are really receptive, but after there is no follow-up on actions that you started. So this is where the problem starts. So we need really to put the finger on how to continue to maintain and continue with dialogue with the policymakers in this field to get them really well involved in what we are planning.
Thank you so much, Ali.
This is really a fascinating session. Thank you all. I am struck by the index-based weather insurance, Manuela, and I'm struck by your comment about verification, and wondered, and this is potentially a very naive question, but I wondered whether or not a different data stream could be very helpful in the case of using remote sensing from satellite data to make it more applicable for evaluating at community level the impact of climate on crop yields. And it links to Ali's brilliant talk about data science for development and health, is how I would characterize it. And I just wondered if there are opportunities here for synergies in solving a problem on scale.
Manu, the ball is in your field.
Yeah. So let me say, I don't know if Jonas is in the audience because I came in late and I didn't get to meet him this morning. So we're actually engaged in Heidelberg, and I shouldn't take credit for it because I'm actually only stepping in as Professor Sauerborn is stepping out, as Rainer is stepping out. There has been collaboration together with Sandra, who I've seen is in the audience as well, within the framework of this research unit, with a company that actually tries to do exactly that. So tries to develop models for crop predictions starting with satellite images. And one of the dreams we have, and for which actually we've not even yet advanced the proposition for research, is try to figure out if we could help such scheme figure out better ways, both of setting their premiums and of managing their payouts. And we are at the very, very beginning of that research, because the question is obviously that prediction has to be quite specific to that field in that village. And right now, with the data currently available and the instruments at our disposal, the level of precision is not there. And then I don't get the payout, and she does, just because she's closer to the weather station where lack of rain was detected. But I also experienced it, but it's not detected for me. So I think it's a field in evolution, and I think it's a little bit of a long-term dream to actually be able to partner. I'm a social scientist, so it's obviously not me, but to partner with people who are engaged in that kind of work and find that bridge. So I think one of your calls was also for interdisciplinarity, and that's obviously much needed.
Just to add on what Manuela said, yes, with Jonas, we are doing similar things with food security, trying to use the remote sensing to model the harvest, and with impact on the nutrition of the under 5. So this is something that is going, that could be also done with the project. But my worry is always about the scaling up of these activities, because we can do it in a lifetime of a project. But to get it in a normal life, it will be really a lot of demanding, and costly. Sometimes this is where the problems come. Otherwise, we could really do it on a research level, show the evidence, but later on to scale up, this is another issue that we have to deal with.
Sorry, I didn't have a comment because I don't know the area, but I had a question. And that was, what's the right level to work at with your insurance scheme? I mean, it could be the householder, it could be the village, it could be the region. You know, what's your experience in terms of thinking about data needs, application, equity issues? There must be all kinds of things you have to bear in mind, but it's not, to me, immediately self-evident that the householder is the right unit.
And I think, maybe I'm loud enough to that, I think that's again an area where health can also contribute to the knowledge, like health insurance, because different models have been tried in the past. Okay, it's not enough to operate the individual, maybe we should operate in cooperatives, right? I think that's what's been tried in Burkina Faso. Everybody's in the cotton cooperative gets it. Because what ultimately matters is the social protection of the community more than the individual, because then there is also reallocation within communities, the reciprocity in these settings. And I think these are open questions. I think that there are very few pragmatic applications of the idea. Always, as Ali said, small scales, very difficult to figure out if and what really works.
I may comment on this because it's really my field also, and I agree with Manuela on most things, but not on that it's too early to do research. I think if not now, when? The insurance takes the weather signal from Ouagadougou airport, one signal for the entire Burkina. Is that very sophisticated? No, it's not the kind of data stream that you allude to. And it gives to everybody who has 70% of the harvest gives a payout, of which the government subsidizes 50%. Amazing. But we can help with village-based, from NASA, NOAA, there are all sorts of, we can map the whole country with the weather pattern, not only cumulative rainfall, but mini droughts, torrential rainfall, everything that's bad for your harvest. And then we can go at the harvest side and not only say, okay, you must be 70% lower because we found out in Ouagadougou airport that this was bad weather. We can, with Jonas, this company, they know for each field of each household how much of crop they have harvested. And they know it 6 weeks before the harvest. That's an amazing scientific advantage. And now, I agree fully, doing a household basis will cause friction, you know, I get it, you don't get it. But on a village, community level, you can get all the fields together, look at their harvest, and the weather signal, you can get it from NASA at a 5 by 5 kilometers. That's one village, basically. And then you can give really, with the nuance and scientific evidence-based, you can predict the losses and get the right payouts, maybe in food and not in money, but that's a debatable thing. Research on acceptability, research on what the validity of the signal is, whether we have some weather stations there. This is now, I think, the agenda, and if we can join hands, Michelle, I would be most happy. And she's in fact a fan of this insurance, and she wants to do it, but she's too careful to go ahead. Okay,
no need to defend Manuela. I think you were referring to the technology, right? All right. Ooh, that's a tough one. Just in the middle, but you were the first, so maybe I can throw. Okay, then until you switch it on, can you show your hands again? Who had a question? some sports this morning. Trish, I'm faster.
Hi, thank you so much. I also have a question regarding the insurance and financing. And connect the talk maybe that most developed countries contribute more in climate change, and the less developed countries carry the risk of the and the impact of climate change. And insurance basis based on the risk, right? And if the weather conditions will worsen and increase the risk of crop loss, it will basically induce more payment from either government or from the farmers, so increasing the social welfare loss for the low-income countries. And my question is whether there is a thought stream of how basically the more developed countries, the contributors to climate change, can participate in financing of this insurance or of this risk. Yeah.
For the person in Burkina Faso. And that level of responsibility, the tools we currently have are bilateral and multilateral aid. And here we enter in the whole discussion, are these sufficient instruments? And I would say in the case of climate change, even more so, when we know we are causing the damage. So I think you really raise questions. To be frank with you, I don't know of any tangible examples in solution. I rather think of further fundamental human rights almost question. But I don't know if my colleagues have seen any implementation of the
I think you have wrapped up all the voices of half of the world at the last COP26. So I think that is a very important question, and many leaders of countries and people who have responsibility there have stood up and said, well, you are causing the damage, we have to face it, so please help us. So there are these discussions out there on political and economic levels. I'm afraid we can't solve them today, maybe over lunch, at least some ideas. And that's actually what the time is now there for. So I would like you to, again, give a warm applause to our panel.
COVID-19 has had a lot of problems, but it has also made health on top of the agenda. There is an opportunity to interact between the climate and health community. Secondly, it's never boring to work with Rainer. And you will soon understand why. But before that, so much in life, at my age, I have a bit of experience. So much in life is about friendship. Thank you for the friendship, Rainer. Also, thank you for introducing me to great people from Burkina Faso. Two of them being here, Bukar and Alissi. I said, it's never boring to work with Rainer. He's quite a courageous person, and you can have other adjectives for that. In a very rural area of Burkina Faso, Rainer, after a full day's work, Rainer said, now, let's hike, let's go into the desert. And we did. Further and further. And some of us, I'm not that courageous. If you want to check, you check with my wife. She will join for the evening session. I said, Rainer, shouldn't we turn around? And Rainer said, no, why? Anyway, we went, until it became dark, and it was obviously not only me that was a little bit concerned, because Bukhar called the police. Do you remember, Rainer? Just shows, no, of course Rainer don't remember, but it just shows also what friends are made for. And I'm here referring to Bukhar. Thirdly, or fourthly, I've almost forgotten. You know, what a thing. 60th anniversary. And by the way, Rainer, you told me how I should distribute the Karolinska Institute ties with greetings from our extremely dynamic Norwegian president, Ole Petter Ottersen. Rainer said, give it both to Till and Joachim. So I did, and I hope you will enjoy it. Now, let's move to the presentation. And I normally always press the wrong button. Let's see if I can make it this time. Okay, so this originates from a webinar hosted by the George Institute, my namesake, if you wish, at Sydney University. A webinar that I chaired. And who do you think gave the keynote? Who else than Andy Hayes? He is around all the time. Another true pioneer. Now we thought that we had invested so much time in this that we should make something more out of it. And then not only dealing with intersectoral action, which is absolutely necessary. In Sweden, the different ministries don't work together, and they are like silos. And you cannot address the grand challenges of our time without intersectoral approaches. So we decided that we should focus on the politics of intersectoral action. And let me quickly walk you through our findings related to what came out of the webinar, and then a pragmatic literature review focusing on the politics of it all. So, in summary, and those of you that don't want to listen more, you can, in a few minutes, one or two, close your ears. Barriers, lack of political support, inadequate leadership, the institutional stickiness. Isn't it surprising that the major global institutions are the same that were created after World War II? Are they relevant for the problems of our time? Facilitator, executive leadership, I'll get back to that in detail. Shared cross-sectoral goals and coordination, civic mobilization and accountability. Not least the latter, so difficult. The way forward, framing, visions, narratives. We addressed part of this in the last session before lunch. More explicit division of labor between the ministries. They should talk to each other, communicate with each other, but they need to know who is going to do what. Localized agendas, and as we also talked about prior to lunch, legislation. Monitoring for accountability. And include this in the more mainstream. We have this fantastic opportunity with you in Agenda 2030. Synergy and convergence to key concepts if we want to avoid NATO, no action, talk only. I'm not talking about the military alliance. Key message number one. The undermining of natural systems represents an existential crisis for health of humanity. Some call the Sustainable Development goals as a survival kit for humankind. Now, many of the actions for addressing environmental change has a lot of co-benefits. You can see them. I'm not going to read it all. But emphasizing these actions could motivate more intersectoral action. 2, Such ISA is beset by major political challenges, as evidence from COP26. Remember, though, what Andy Haynes said. Okay, there are COP26 and what's going on with the negotiations there, important. But it's not enough. We have to act in addition to that. Be aware of barriers and enablers for human and planetary health. 3, the literature review that we did identified a number of barriers and enablers. Outdated institutions. Remember the concept I used, stickiness, institutional stickiness. If you want to read more about that, I refer to the Lancet Commission, Global Governance for Health, 2014, led by the president, now president of Karolinska Institutet, Professor Ottersen. Enablers. In a way, enablers are more interesting than barriers. We should capitalize on the enablers. They include political demands, often demands created by one of the P's that I mentioned before the lunch, namely the public, citizens' voices. Politicians are interested in what citizens value. 4, you need visionary agents. You need individuals outside the academe, including the academe, but also outside the academe. Also before lunch, there was talk about knowledge translation. I was surprised that not anybody, as I heard, mentioned EVIPNet, the Evidence Informed Policy Network, hosted by WHO with regional groupings. It includes 12 to 15 tools for knowledge translation. Also, the academe work in silos. Interact with EVIPNet. If you want to, I can facilitate that interaction. There is an imperative for intersectoral action. Both adaptation, mitigation, Andy talked about that. And it needs to be better integrated, these two concepts and driving forces. Focus on the co-benefits, both for physical exercise, but also food and revised food intake. Health indicators. When Alice presented from NUNA, the DSS created in collaboration between Heidelberg and Burkina colleagues, I was looking for indicators. Maybe that is something we can discuss next. As co-authors, we decided to talk about the 3 I's: ideologies, interests, and institutions. I apologize for you having to see the paper and the authors at the bottom of many of these slides, but I really welcome you to read it and comment on it, because this is a process that is ongoing, and we need to act. Finally, apply a political lens. Barriers, lack of political support. You can read yourself examples of that. Inadequate leadership and links across sectors. How do we assist in operationalizing this? And then organizational and institutional constraints. This I'll read. Narrow specialization may not value collaboration and cooperation, nor foster mindsets and skill sets amenable to working with other sectors. Einstein said something like, we cannot use the same methods trying to solve the problems that we used creating the problems. We have to be innovative. Finally, facilitators. Executive leadership is the type of leadership that transcends ministries, sectors, organizations at different levels. Shared cross-sectoral goals, again underlying, emphasizing civic mobilization. And something that is so difficult, but where I think the Lancet Countdown has been excellent. There are so many Lancet commissions, most of them don't survive. But Lancet Countdown survives because of the annual monitoring for accountability. Thank you very much.
Thank you very much for a very thought-provoking and useful presentation on thinking of next steps and what we need to do to go forward. I'm sure our next speaker, Dr. Furman, will talk a bit about indicators and particularly around co-benefits. And I look forward to hearing what she's going to say.
And I have to say, I'm not a doctor. Very nice of you to give me that title, but I haven't worked for that, so I don't want to pretend I am. I'm going to present today the climate impact of healthcare, which means I'm going to talk a lot about emissions. To explain why I'm here talking to you about that, I have to explain where I'm coming from. So I'm working for Healthcare Without Harm. That's an international NGO working on the environmental impact of healthcare. We're trying to make the healthcare sector environmentally friendly and to fulfill its role of not doing any pleasure while providing healthcare. I'm working here in Europe in the office in Brussels. And we are working in 4 different program areas. We're working on sustainable food, on safer pharma, circular healthcare, and climate smart healthcare, which is the program area I'm working at. You can already see we're already crossing a lot of sectors there, a lot of silos, and trying to combine what is happening in the healthcare sector with what we know from the more sustainability sector and the engineers working with us. And we are working mostly with hospitals and healthcare facilities. For that, we have a network called the Global Green and Healthy Hospitals. And we're working worldwide with over 1,500 members who represent more than 50,000 hospitals and health centers around the world. Here in Europe, we're having in our network around 5,700 hospitals. Not that many in Germany yet, trying to change that. Working for the Climate Smart Healthcare Program, our goal is to transform the European healthcare sector into a net zero carbon and climate resilient sector. So we're working both mitigation and adaptation. And we're trying to protect public health from climate change and accelerate the wider society transition. The idea behind what we're doing is to first do no harm, that's what I've said. So the healthcare sector has a responsibility to not do harm with what it's doing already. That means not doing harm to the environment, which again, as Sir Andy Haynes said this morning already, has so much impact on health and on human health. The problem, well, to find out where you want to go, you first need to find out where you're standing. So what we did in 2019 was to calculate the healthcare emissions worldwide of the entire healthcare sector. We found that the climate footprint of healthcare is equivalent to 4.4% of all global emissions, which is quite a lot and quite ironic considering that's not what we're supposed to do in the healthcare sector. If the healthcare sector was a country, it would be the 5th largest emitter in the world. Here in Europe, we are responsible for about 12% of all emissions of the healthcare sector worldwide, which puts us in the 3rd place after the US and China. And interestingly, many of those emissions are coming from scope 3. So what you're seeing here in dark blue is scope 1, in red is scope 2, and the light blue is scope 3. And scope 3, I think Annie Haynes said that also before, are the emissions from the supply chain, from the indirect, the indirect emissions, from what the hospital buys, from the transport it produces, all the pharmaceuticals, all the single-use items, all the nutrition or the food that is bought. That makes it obviously a little bit complicated to reduce those emissions, because that means we have to work together with different sectors. We have to work with the pharmaceutical industry and all the producers of medical equipment. And that brings me to what we can actually do. After producing the report on the climate footprint of the healthcare sector, we wanted to see where we can go from there, because just telling the healthcare sector that you're bad, you shouldn't be doing that, doesn't help anybody. So last year we produced the global roadmap for healthcare decarbonization. Apologies. It shows a trajectory of healthcare decarbonization. First, it shows where we're going to go if we don't do anything, but it also shows us what we can do and how we can get there. We also looked at 68 different countries and looked at how those countries, the health systems of those countries, where the emissions come from and where the best areas for action are. What you can see here is our trajectory for how healthcare emissions are going to develop in the next years until 2050. The top part is how they would develop if we don't do anything. So if we don't do anything, they're actually going to rise, which is the opposite of what we want. And that is because health sector still needs to grow. We have growing populations, we have growing medical needs, and also climate change contributes to that. Then the second part, so the second line, the blue part, is basically all the emissions we're going to reduce if all the governments hold their promises that they made until 2017. So if all the governments really implement what they promised to do, we're still going to increase in emissions compared to where we have been in 2014. That means there is an imperative for action from the healthcare sector directly. We need to work ourselves on those things and don't just wait for others to do the work for us. This red part is what the healthcare sector can do and where we know there are already solutions that we can implement. Now, we've taken that red part and divided it up in 7 high-impact action areas. Those are the areas where we know we can act. There's already the knowledge out there to do that. For example, using clean and renewable energy, investing in zero emissions buildings, investing in safe and zero emissions transport, healthy and sustainably grown nutrition, low carbon pharmaceuticals as well, and circular healthcare. Also the waste management is important. And last but not least, there's also the need for more effectiveness in the work of health systems, because we're also using a lot of resources that we don't need to use for unnecessary procedures or just out of ineffective use of those resources. We do have some fact sheets. I invite you to have a look at them. They're on our website. Now, because we're in Germany, I decided to look a little bit into how bad it is for Germany and how it is compared to the rest of the world. In Germany, just like for the world, health care emissions are 2/3 from scope 3, so from the supply chain. And all those numbers are really hard to understand. So it's nicer to translate them into things that you can maybe imagine better. So for example, the health sector footprint in Germany is equivalent to 14 coal-fired plants, or to over 700,000 tanker trucks worth of gasoline. I think that's easier to imagine than megatons of emissions. What we also did is looking at the actual sources of emissions. Usually it's like scope 1, scope 2, scope 3, and scope 3 looks very big. But it's important to look at where do those emissions actually come from, and also how does Germany do compared to the rest of the world. What you see here, the little red dots, those are the global mean. And you can see that Germany is over the global average in basically every emission source. We're using a lot per capita. One thing I wanted to mention as well, because we've had the question before from somewhere on the upper right side, we are also giving target trajectories for different countries in the roadmap, because not every country has a health system that is already providing enough healthcare for the whole population. So some countries still need to have the ability to grow their health system. That is why rich nations like Germany have a very steep trajectory, who need to reduce their emissions very, very quickly to make up for the still growing health systems in other parts of the world. I think I'm a bit slow, so I'm going to jump that. What I just wanted to mention as well is that obviously this is all on country level. We are working with ministries of health through our Operation Zero. We're working with the Ministry of Health in Portugal and in the Netherlands and in Italy, in the region of Lazio, to work with them on actually calculating their emissions in more detail and actually creating a methodology, a plan on reducing those emissions for the country health system. Hopefully Germany is going to jump on that too. I wanted to finish with how we are supporting healthcare providers as well, because we're talking a lot about country level, but every healthcare facility also has a responsibility to reduce their emissions, and some things need to be done from the ground up. So what we have is a bunch of projects, a bunch of networks. The biggest of it is the Global Green and Healthy Hospitals that I talked about already, which is basically all the healthcare providers in the world who want to work on sustainability. And part of that is also that we create resources and calculators, emissions calculators for those healthcare facilities. So we have created on Hippocrates, which is our data platform, a calculator for healthcare emissions, specifically with emissions for the healthcare, of the healthcare sector, including anesthetic gases and inhalers and patient transport. And that one is spanning all three scopes, so the direct emissions from the healthcare facility, the electricity and purchased energy, but also scope 3 in a top-down way, scope 3 supply chain emissions. And yeah, we have all that available for hospitals that want to get better. And we're also working with other organizations on a global scale. For example, we're working with the UNFCCC with Race to Zero. We are supporting all healthcare institutions worldwide who want to reach net zero by 2050. And we're working with, for example, the World Resource Institute. They are the ones who created the standards for emissions calculation. So it's great to work with them as well. And we're trying to work bottom up with healthcare professionals through our Nurses Climate Challenge and Doctors for Greener Healthcare because I think it's super, super important that healthcare professionals also stand up and share the knowledge that we have about how climate change impacts health, because they're trusted and people will believe them rather than a politician saying that. If you have any questions on that, please find me outside. I'm always happy to talk to you about it. And, well, thank you very much.
My presentation will be on climate migration as a stressor for health systems, ? I did my PhD on the interconnections between climate change, migration, and displacement. I'm not a health professional. I work on the climate impact side, the human dimensions of climate change. And I wanted to share with you a little bit some of my insights that I gained from my field research that are related to health. So when we talk about climate change and migration, we talk about a nexus that is quite intricate. We see that there are many drivers that can cause migration, for example, demographic drivers, economic drivers, social drivers, and these drivers are impacted by the effects of climate change. But of course, the decision to migrate or not to migrate by a household, by an individual, is always a question also of household resources, a question of how people are tied to their land, and a very individual decision. So when we talk about climate change and migration, we always talk about migration as being multi-causal, having a variety of drivers and pull factors that lead to the decision to migrate. So here's a very complex graphic from the Lancet, which highlights in one aspect the climate, health, and migration nexus. This report was mostly on climate change and health. Probably many of you have read this report, and you can see on the left-hand side are the direct effects in dark red of climate change, meaning like direct physical climate impacts, storms, droughts, leading to a variety of indirect effects that are then instigating different social dynamics. And on the very bottom, you can see mobility and conflict status. So in the climate migration discourse, to lump together migration and conflict is always like slightly problematic because, of course, migration into already populated areas can lead to conflict, but it doesn't have to necessarily, and often it actually helps also the receiving communities to improve, for example, their economic basis. And then these different social dynamics cause various health impacts, and I wanted to look at that a little bit closer. And this is just a little bit of my own thinking on this. How do climate, migration, and health really interact? And I look at it from three angles. The first one being health risks as a push factor of migration. So, for example, people who are inclined to migrate because they fear for their physical safety, or because they fear for the long-term effects of a climatic event. So, for example, for food shortages or freshwater scarcity. Then health opportunities as a pull factor for migration. So people migrate to have better access to healthcare and sanitation, to have better access to income, to be able to pay for these services, or to be able to pay for sufficient amounts of food. And health outcomes as risks of migration. So these are the three dimensions that I came across in my research when I was trying to find out how climate and migration are interacting and how people are doing after they have migrated, how are the receiving communities doing after they have migrated. And so health outcomes as risks of migration, I will go into this a little bit further. Here, looking at the perspective of migrants themselves, I just want to highlight maybe three longer-term impacts. One is the question of mental health, the stress from changing a place. It can be a positive experience, can also lead to loss of culture, loss of being rooted. It can also lead to a loss of traditional health practices. So things that people practiced in their place of origin, they can no longer do because maybe they don't have the natural resources to do so where they arrive after their migration. But it can also lead to positive outcomes. For example, if people move from rural areas to cities, they are able to access better healthcare facilities. The receiving communities, so we look at often when we talk about the migration system, which consists of migrants, receiving and sending communities. And the receiving communities also have a variety of long-term effects. For example, the introduction of communicable diseases, which can occur through migration. Also, a positive effect can be that migrants contribute to GDP and therefore add to the economy. And for the sending community, it can also have like short-term negative effects. For example, if labor is kind of drained out of the sending community, this can mean an increased burden for example, when many men migrate, that a lot of labor burden is on the women. They have to do the childcare and the agricultural labor, meaning that they will have more physical labor to do. Maybe it also helps when people send back remittances for the people who stayed behind to improve their own access to healthcare, to medicines, because they can afford to buy them now, or also improve nutrition because they are able to buy better food or invest in their agricultural practices. I did one case study on Bangladesh a few years ago. This is a report we produced for the Asian Development Bank with a wide variety of authors. And here you can see it's kind of a scientific cartoon. It highlights a variety of climate impacts that are present in the Bay of Bengal and how they can cause migration movements. And what we see in Bangladesh is that people move from, for example, from the south, from the rural areas, into medium-sized cities, and some people move from these medium-sized cities also into the capital or across the border to India. And when migrants engage in this type of migration, they not necessarily avoid climate risks entirely. So they may avoid the climate risk of tropical cyclones in the rural areas, but when they migrate into medium-sized cities, they don't have necessarily the skills to be able to integrate well into the urban labor market. And this means that they have to take on very hard physical labor. They may end up in informal settlements. Some of them you can see here. And these informal settlements are also affected by climate change impacts in turn. So they're affected by flooding, they're affected by heat, especially in the corrugated roofs. Heat is a really problem, and also communicable diseases. So I just wanted to share some interview excerpts with you, with people that I interviewed. For example, in Khulna, one person said in summer season it's difficult to live, referring to the heat stress in the city. Then in Barishal, somebody said, frankly, sometimes during monsoon we are used to starve because they're not able to find enough employment during this time. For example, they work as a cycle rickshaw driver, but at that time, because of the rains, people are less inclined to use a cycle rickshaw, and then they are out of labor and fall into poverty and are not able to finance their day-to-day living. And again, heat due to excessive temperature, I sometimes lose my senses, another person said. And then we also, I mean, this is not a clinical assessment, obviously, this is just what people tell us. And my talk to you, as many medical professionals who are here, I just want to get you interested in this topic of the interconnection of climate change and health. So this is just qualitative insights from which I derived some hypotheses which could be interesting for further study with a quantitative analysis, for example. So one person said here, we were well in the village because the environment was good. We now feel psychological depression because living here meant to leave our own home. The urban areas are more chaotic than in the rural regions. Here, income is less than in my village. So you can see like the different pressures that are on the people and how they also reflect, obviously, on this variety of pressures that affect them. Another case study that I briefly want to mention is in the Marshall Islands in the Central Pacific. It's this group of small islands that are quite remote from each other and that are very much affected by sea level rise, by king tides, storm surges, drought. So really also a variety of climate impacts already occurring and affecting people's day-to-day life. And this poses substantial risks to people. When the sea level rises, sometimes we have dead children who are playing in the ocean where they used to play. They're taken away by the sea. It happened nearby at the ocean side, 2 children, 3 and 1-year-old. This was an interview on the outer islands. So the storm surges on the high tides are coming in deeper and deeper into the islands, and people are not yet used to it. The children are being surprised, the parents are being surprised by these strong climate impacts, by these extreme events, meaning that deaths occur more frequently. And then another person said food crops are decreasing, the water lenses are salinized, so this is an effect of droughts and also of flooding. So if there's a storm flood and the water washes across the island, both the soil and the water lenses are salinized because this is obviously salt water. And this person also said people have to rely on imported food, and this is something you can see basically in many small island states, especially in the Pacific, that this reliance on imported food, which has to be shipped over many weeks or months even, also causes diseases such as diabetes, which were previously not present on the islands and have become rampant in the last decades. Then there also this loss of culture and identity leading to a lot of mental pressures, at least I would say, are really present with many people who had to leave the outer islands. So people move from the outer islands to the capital island of Majuro, and from there some of them tried to move to the United States because the Marshall Islands is also the place where the United States tested its atomic nuclear bombs. Because of this very tragic history, the United States and the Marshall Islands have a very strong military relationship, which enables people from the Marshall Islands to live and work in the United States without a visa. So what people told there was that, yeah, they're losing their culture out there. When they move to the United States, their own culture and the custom of togetherness, this is one person said. And then another person said, I'm not scared to go down the sea, I'm scared to move there and be nobody. So you also have this effect of people being voluntarily immobile despite growing risks because they don't want to leave their place of origin, which is very understandable because the changes they're confronting are very, very thorough. I just wanted to highlight one particular group that is specifically vulnerable to the climate impacts, but also to displacement from climate change, which is people who have a disability. And there is research saying that they're one of the most vulnerable and socially excluded groups in any displaced or conflict-affected community. And you can see out of all persons who were globally displaced in 2020, 15% have a disability. So it's quite a large group, and often they don't receive sufficient support. And one very tragic example I wanted to give of this is the floods we had here in Germany last year in the Ahrtal, where in the whole region we had over 180 deaths. We were not prepared for this enormous floods. And the one thing that occurred was that there were 12 people who had a disability who were living in one home in Sinzig, in a home where they should have been helped, and they were not able to evacuate them on time. So 12 of these people died because they were not able to self-evacuate. So there's one reason that people need special assistance in times of these crises, which is often not planned for in these evacuation plans or things like this. So we need better preparedness in this area. I was asked to say a few words of where to focus research in the future, what would be interesting. And I think one area is the question of the limits of habitability. I think there's some research out there on physiological thresholds regarding heat, so the wet bulb temperature, but I think there's other compounding effects. So how does this interact with pollution? How does this interact with the carrying capacity of healthcare systems? So I think this question of habitability and health is a core one for the future. My last slide is just a slide for this conference as a whole. We are battling on many fronts now. This is a picture of, or animation of the island states of Vanuatu, which was affected by Tropical Cyclone Harold in 2020, while they're at the same time trying to deal with the effects of the COVID-19 pandemic, trying to isolate, etc. And it was very, very difficult to manage these two crises at once. So given the health crisis we have, given the geopolitical crisis that I didn't talk about today that we have, and the climate crisis we have, we really have to be able to multitask nowadays. So this is my final comment, and I thank you very much.
Thank you, Chris Ebi. So I'm very glad and honored I can talk to you today, and I will actually take forward what Anne Fuhrmann presented today from the perspective of healthcare without harm, but now with a rather concrete example of how to reduce the carbon footprint of Heidelberg University Hospital. So, and I didn't want to touch on that very much, but we had the discussion about being a scientist and being an activist. So I am a member of the German Climate Change and Health Alliance. I do not receive any funding from them, but I give some workshops for them from time to time. And so you can maybe tell me after the presentation if you think that this is a conflict of interest, if this is a way for us as researchers to deal with this, to simply make it transparent, that we work with such kind of NGOs, and I don't have any other conflicts of interest to declare. Okay, so I will follow a pretty classical structure, a little bit of background, but we had a lot of that already. Then settings and aims of the CLIO project, some preliminary results and conclusions. And we have heard about the concept of scopes from Anna before. This is actually a publication from Tennyson et al. In the Lancet, and it shows again the carbon footprint of the healthcare sector. And the only thing I want to draw your attention to is that actually more than 2/3 of the emissions are from supply chain. So you see it's pharmaceuticals and medical equipment, but also the green part, the personal travel, that also belongs to the Scope 3 emissions. And this is something we really need to focus on also in hospitals. And we actually have done some analysis in Germany, and that was mainly done by a colleague of mine who cannot be here today, Claudia Quittmann. And she has looked into the CO2 reporting of German hospitals, and we found that actually 12% of German hospitals had a CO2 reporting, but none of them did Scope 3 reporting. And that is obviously related to a lot of methodological issues. So this is something we really need to pay attention to. And one other short background, of course, if we think about hospitals, we heard from you, Mr. Thompson, that health co-benefits are important, and they are also important for climate change mitigation in hospitals, because there we also have employees and patients who need to come to the hospital. So can we have active mobility there? We do have a lot of food catered to patients and employees where we can introduce principles of the planetary health diet, for example. Also telemedicine has been shown to create health co-benefits along with CO2 reductions. And we also had the area of reduced overprescription. We do have a lot of overprescription where actually pharmaceuticals are not needed or even harmful. Think of antibiotic resistances. And there, of course, we can also reduce emissions a lot. So now let's look at our hospital here. We are actually, I don't know if you can see that. We are right here. So that's the head clinic, and we are a clinic ring. You can see that. We have all the clinics around internal medicine, surgery, and they're in a ring. And we also have one in the old, rather in the old town, and one out there, the orthopedic clinic. And that's our hospital. And the project translates to roughly climate change mitigation in hospitals through optimization of supply chains, and the acronym is CLIOL for the German title. And us, this is actually the Heidelberg Institute of Global Health, but also the Institute for Energy and Environmental Research in Heidelberg with my colleague Bernd Franke, who's also here today. And we are funded by the German Ministry for Economic Affairs and Climate Action under the umbrella of the National Climate Change Mitigation Initiative. And actually every project of this initiative needs to have a concrete reduction goal. So we're not only a research project, but we actually needed to show that we will reduce CO2 emissions within our project. So that's the main aim. The 7% reduction of scope 3 emission of our hospitals within the 3 years of the project. And to do so, we want to build a carbon calculator, or we've already done that, and I'll show you some results of that. And we also made a stakeholder analysis wanting to find out about perceptions of climate change mitigation in hospitals. So this is something I can show you some preliminary results about. But then, starting from now on, we will also identify greenhouse gas reduction measures that we want to implement, and we are very happy that we will not need to do that alone, because we have also heard from Anne that this is really something that needs to have the support of the organization. And we heard this morning by Professor Autenried that we have a top-down commitment for climate change mitigation, and we also have this wonderful network, sustainability, Netzwerk Nachhaltigkeit, in the university, where we have also a lot of bottom-up movement towards more sustainability. And so we hope that our role in the project, and the project just started in the end of last year, will be to actually evaluate such reduction measures with regard to greenhouse gas reduction, but also health co-benefits. And so what I can show to you today is actually the first results of our carbon footprint calculation, and that's mainly thanks to Bernd Franke and his team. And you can see here, probably as expected, that most of the emissions, all the blue ones, are the scope 3 emissions. And you can see that only a little bit is scope 1, so basically emissions that are actually emitted so CO2 and other gases actually emitted on site, and that's mainly anesthetic gases, and that make up about 1% of the footprint of Heidelberg Hospital. Then of course you have a lot of electricity, but then if you look at the scope 3 emissions, there's a huge part of medical products, so that was a top-down approach. So basically for medical products and for pharmaceuticals, we took the amount of euros spent and we multiplied with a specific emission factor. For the mobility, which if you take together transport of patients and of employees, you have also almost 11%. So there we have rather a bottom-up approach. So we actually had some sophisticated calculations of where the employees come from, how often they commute, and how they commute, if they commute with public transport or with the car. That was quite sophisticated calculations that are behind these numbers. And of course, food supply is also one important point. And also we have those gray emissions. If some of you don't know what that means, that are emissions from buildings. So of course, for example, we have newly built that wonderful clinic of surgery, and also this building has been built at some point, and these emissions are also taken into account in that calculation. And if you want to also have a look at the absolute numbers, so basically In the current version of the calculator, it's 240,000 tons of CO2 for the year of 2019. So if you have in mind that, for example, in Germany, an average person emits about 11 tons of CO2, then this is a small town of about a bit more than 20,000 people that the hospital could be compared to with the amount of emissions. So these are the first part of results, and actually starting off from this, we want to develop reduction measures. And if we want to develop such measures, I told you, we do need to involve stakeholders. So this is why we also did a stakeholder analysis. We did qualitative interviews with administrative staff, clinical staff, and also patients. And there's actually a lot of findings we had, but one important finding I want to share, and that is that there was actually a lot of priority on patient care, and the finding that people said that adverse environmental impacts are actually accepted. And that there was the perception, and a lot of times also maybe a misperception, that climate change mitigation actually comprises patient care. And I can illustrate that with a quote. So there was one administrative staff saying, patient welfare simply has priority over climate change mitigation. That's just how it is. This is how it should be. No one is supposed to leave the gloves on from patient to patient for environmental reasons. And that was a common perception that actually people thought, okay, if we want to reduce our emissions, we have to compromise patient care. But we actually believe that this is not the case. And also, there is actually an interesting study in the UK where they could reduce the use of gloves while keeping up high standards of hygiene. So there is not really this, this conflict that many people felt that is. So for communication, we believe that we need to communicate that mitigation measures at hospitals will always be with the same or even improved patient care. We need to emphasize health co-benefits if there are some, for example, in the area of food or active travel for employees. And we also heard that from Anna, and that's not only the principle of healthcare without harm, but actually it's a basic medical ethics principle of doing no harm. And that this is also something that needs to be communicated. And I want to show you one more quote, and that was actually one clinical staff who already integrated some of this thinking in what he was saying. And he said, as a doctor, you are not exempt from thinking that everything is centered on the patient and that this justifies everything. But actually, the opposite is the case. If you are responsible for people, you should actually ensure that you also act in the interest of people in other areas. For example, climate change. So I think that reflects the thinking we should have if we think about climate change mitigation in hospitals very well. So for the conclusions, I can say that measuring Scope 3 emissions is important. But we also have struggled with a lot of issues, so the methodology is not easy. And I also want to pick up the discourse about industry that we had this morning, because, for example, for medical product and pharmaceuticals, we try to go into the company reports to get also some more information about product life cycle assessment and these kind of things. But simply there is not enough data, no transparent data, and especially no comparable data between the different industry partners. So I think here politics and industry are called to actually policy, maybe make guidelines or also laws that make industry also make these kind of emissions transparent, so that then hospitals and other healthcare providers can act with that information. then I can definitely say that we need stakeholder involvement, bottom-up and top-down ideally. This is crucial also for implementing mitigation measures. As probably one important conclusion of our stakeholder analysis, it is important to communicate health co-benefits and the principle of doing no harm in the health care sector. And with that, I really want to thank everyone in the project, but also all the people on the ground in that network of sustainability. And I hope I did not take too much time. Thank you.
I'm delighted to be here back in Heidelberg, the chance to see some very old friends and I think make some new ones. The title on the slide that you see here is a bit misleading. First of all, I know very little about climate change. And I'm here basically because I was one of Rainer's thesis advisors many, many years ago. We discussed what I should be talking about at the meeting, and this is a title that Rainer came up with from a few that we'd been discussing. But given the occasion, I thought there should be some more room for personalizing the title. So I think what I'd like to talk about really is climate change and cancer with Rainer in the middle. Some of you may not know that apart from Rainer's reputation in climate change, he was actually a very acute cancer researcher many, many years ago. But then he deviated away from cancer and took on the career that you all now know about. So what we're going to try to do is to weave some connections between climate change and cancer with Rainer in the middle, and we'll see how we get on. So what are these connections? Well, first of all, climate change, I don't need to tell all of you that you've heard at this meeting many times the impact on infectious diseases, pandemics. This can lead to poverty, impede access to healthcare. This causes anxiety, changes in lifestyle. People start to drink more, smoke more. This can have a huge impact also on nutrition, malnutrition. Also, people start eating fast food all the time and it leads to obesity. And all of these factors independently have been shown to have major effects on cancer incidence. These are all very important. In addition to the famous carcinogens that we all know about, like smoking and ultraviolet light, these are all major factors that contribute to cancer. Also, of course, the major contributor to climate change is environmental pollution. I'm told that there are some 350,000 synthetic chemicals out there. And many of them can have a direct impact on cancer. So what we'll do is go through a few of these factors in the next 10 minutes or so and look at some global patterns. And then we'll come back to how cancer starts and what Rainer's critical role was in tackling the cancer problem. So this slide here shows the global cancer impact of infections. So as you know, there are quite a few viruses out there that can directly or indirectly cause cancer. Many of these viruses are prevalent in countries sort of in Africa, Asia, some parts of South America. Major efforts underway to use immunization protocols to try to mitigate the impact of these viral infections. Another major contributor to cancer globally, soon to overtake smoking as the major cancer-causing factor across the planet, is obesity. And this is the global cancer pattern in obesity, which is, of course, mainly focused in the so-called civilized regions of the world. We tend to eat more fast food, more hamburgers, and people get faster. But if you actually look at, if you toggle between infections and obesity, they're kind of mutually exclusive. So the infectious diseases are mainly in the less well-developed countries on the planet, whereas obesity is in the so-called civilized world, for want of a better expression. This is another global pattern which is becoming very topical in terms of cancer, because what this is this shows the development of particulate matter, the concentrations of particulate matter across the globe, and there's a huge concentration in northern Africa, across to East Asia, and these vastly exceed the WHO guidelines in how many particles should be floating around in our environment. And this is of interest for cancer for several reasons. This kind of particulate matter is second on the list here to smoking. And there's a lot of interest now in trying to find out, how does this particulate matter actually cause cancer? Does it induce mutations? Does it induce cancer by some other mechanism? So I just want to briefly step back in time a little for a very diverse audience and just give a couple of pointers on what we now think about the basic causes of cancer and how this relates to this kind of environmental pollution that you see here. Particulate matter is thought to cause almost 300,000 cancers a year. This was taken in 2017. So over a long period of time, you can imagine the impact of this type of pollution on cancer incidence. The first demonstration of cancer being caused by environmental factors was, in 1775 in London. A surgeon noted the chimney sweeps, who usually start becoming chimney sweeps when they're about 10 years old because they could climb up the chimneys. They tended to get scrotal cancer, and he noted the direct connection between the development of scrotal cancer and exposure to coal tar. This was then followed up in the 1940s by a group of scientists who looked at the effects of coal tar in animal models. And what they showed was that you could take coal tar and treat mice with coal tar, and with a small dose, nothing happens. You leave the mice for their whole lifespan, they don't get any tumors. But they then also found that if you treat the mice with an irritant, croton oil, then the croton oil on its own causes inflammation, but doesn't lead to cancer. But if you follow the coal tar by the croton oil, you get benign tumors, and these go on and become malignant and kill the mice. So this was the first demonstration that there are these two major processes that lead to cancer. One is directly mutational. The coal tar contains mutagens, very strong mutagens that cause mutations in our DNA. These are like a permanent scar on your DNA. Once they arrive, there's nothing you can do about them. We can't get rid of them. The croton oil was extracted from a plant that was used to make tea. And in regions of the world where they drank tea using this plant, there was a high incidence of esophageal cancer. So this is why croton oil came to be very fashionable in the cancer field. But the important thing to remember is that there are these two major features of cancer causation, and there's been a huge debate over decades about which really are the most important. A very important experiment done in the 1940s again was this one here, using the coal tar treatment and then waiting for almost the whole lifespan of the mouse, and then starting the promotion. And it was shown that the mutated cells in here, they sit there, they lurk in the normal tissues for the whole life of the mice. They don't do anything, but they respond very quickly to the croton oil, and you get the tumors very quickly. So this concept of there are all these latent mutated cells hanging around that are capable of being dormant and not doing anything until they get pushed by the croton oil. So the rate limiting step for cancer in this model is the croton oil. It's not the stuff that causes the mutations, right? It's the irritant. Now, the irritant croton oil was fractionated by this gentleman here. This is Erich Hecker. I'm including this because this was all done in Heidelberg. Heidelberg is the home of tumor promotion, the process that croton oil fosters. This is the plant, this is the molecule that Erich Hecker isolated from the plant. This is the molecule that Reiner worked with back in the mid-1970s. This is, of course, a very potent promoter, but still you can go on Amazon and get a bottle of this croton oil and you can put it in your tea, and this is still being used. There's some very, very nasty things are still thought to be good for you. And there are many others I can mention, but I don't really have time. Now, the discovery of TPA and croton oil isn't the only thing that happened in Heidelberg in the 80s. The whole group of scientists, including many on here, Friedrich Marx, Erich Hecker, Jürgen Schweitzer, and so on, many others, they really set the scene for what we know about this whole process of tumor promotion and how that works. And Rainer also came along as a student, and this is actually a picture, a screenshot from Rainer's thesis. This was never published. We probably should have published it, but maybe we still will. So what this is, I know many of you are not familiar with these techniques, excuse me to those who are familiar, but what this is this peak here is normal cells. This is the amount of DNA that you find in a normal cell. 2 cDNA, so each gene is present in 2 copies. When you treat skin with this TPA, then you see this peak here, which is the same as this one, but then you see some cells here which have double the DNA. These are the cells that are dividing, quite simple proliferation. When you look at benign tumors from this croton oil cancer mutation experiment, you find that the benign tumors look just like normal dividing cells. The normal content of DNA, but some of the cells are dividing, maybe a bit more faster than they should be. But this was the interesting thing over here. When Rainer looked at the malignant tumors, the really dangerous ones, their DNA is all over the place. This is 5C. You can find some cells out here that have huge numbers of DNA. They get all these extra chromosomes. So this is genomic instability, which is one of the hallmarks of cancer. So this is a major feature of tumor progression. And this was the comment from Rainer's thesis, which could turn out to be prophetic, which is, die typische Lage der Karzinom-Stammlinie könnte eine frühzeitige Diagnose der malignen Transformation in der Epidermis schon bei kleinen Tumorzellzellen ermöglichen. The English translation of that is down here. But basically, it means that if you could identify these cells that are just becoming screwed up in terms of their genomes, we find them early, then you can begin to, attack cancer at its very earliest stages. And this is these are the kind of stages that are stimulated by these promoters. So all of this was completely ignored by the scientific community for many years, but now it's become very fashionable through all of these new papers that have come up over the last 5 years or so. And the reason is that what we've now found out is that we are all riddled with mutations. We have thousands of mutations, sometimes thousands of mutations in a single cell in all of our tissues. We're kind of a ticking time bomb of mutated cells that are waiting for something to happen. And so, for example, this slide here shows you the human esophagus. You take the esophagus, you cut it into little tiny pieces, and you sequence them. And you can find all these different clones of cells within the completely normal esophagus. This is the esophagus of a 25-year-old, roughly, male. These small circles are clones of cells that carry mutations that are growing in this person's esophagus. So even though the younger section of the audience has already got these things. A 50-year-old, the circles are bigger, the clones are growing. And this is a 75-year-old. So Rainer's esophagus looks like this. And if he's been taking a lot more schnapps than he should have, it's going to have a lot more than this. So basically, the older you get, the more of these mutations you have. You've got lots of clones. And these are potentially very, very dangerous if they get exposure to a promoting stimulus, which makes them turn into cancer. These are all normal cells. If you look at them down the microscope, they look completely normal. We can't tell any difference. So this has now reawakened interest in what are the factors that stimulate these clones to suddenly start to become cancerous. And this is a new grant that we've just started. This is an international effort to look at this process of promotion. And this is a 25 million grant that's involves, is funded by Cancer Research UK and the National Cancer Institute. And it's 9 groups from 5 different countries. And what we're trying to do is to really get to the bottom of what this process of promotion actually does. We've collected about 6,000 tumors from 24 different countries, from 8 different cancer sites, plus normal tissue from all of these patients. And we're going to be using many different techniques to look at these tissues using animal models, using human organoids. You can take little pieces of tissue from humans, almost any tissue you like, and grow them in dishes. And we can recapitulate the process of cancer development in human tissues in dishes, which is very novel and has only recently become possible to use these approaches. We can do single molecule sequencing. You could detect 1 cell in 100 million in a normal tissue that carries a mutation. And we will be doing CRISPR screening. I'm sure you've all heard of the CRISPR revolution. It really is a revolution. It's totally changed how we can approach mechanistic studies and very extensive bioinformatics to try and put all of this information together. So, in conclusion, this is Rainer here. You may not recognize him. This was in 1975 or 6, I'm not quite sure. This was after a hike up the Scottish Highlands, and he was obviously worn out by all of his efforts in that. A number of years later, he came to San Francisco, got into some trouble, and ended up, in here for a short time. And then more recently, this is the Golden Gate Bridge in the background here. This is Rainer after a hike in the California hills. And so in conclusion, I'd like just to say happy birthday to Rainer. Oops. And a very long and happy and healthy retirement. It's been great knowing you, and I'm delighted to be here. Thank you.
Yeah, thank you so much, Alan, and a wonderful personal presentation. We do have plans for Rainer, so he's not allowed to go into the sunset of retirement just yet. So he'll have another 15 years or so with us. And I have the first question, and then maybe a question from the audience. Did I understand you correctly? If Rainer had managed to publish his thesis, science would be advanced by now by about 50 years or so.
Well, he did. His thesis is published. You can go online and I think and still see it.
But not formally
I have an old dog-eared copy. Some work from the thesis was actually published, but this particular part, which I think is prophetic, was not actually published. So I'll try and find a way to publish that, because I do think that this whole process of promotion, which was so well characterized in Heidelberg, has really been ignored for 40 years. But it turns out it's critical to the, it's a rate-limiting step for tumors to arise.
Excellent. Thank you.
My name is Renank, and I'm going to be talking about some of the lessons that we learned from sort of 2 years of COVID-19 modeling research. But the first thing I want to say is that it's really a pleasure to be here. Thanks for inviting me. But as you all know, research happens in teams, and I have many collaborators without which this work would not be possible. So thank you, collaborators. So as we all know, around the world, governments implemented loads of interventions to try and control the spread of COVID-19. We're talking like bans of large events, school closures, quarantines. And as we know all too well, these interventions have costs, socially, on well-being, and economically. And policymakers are constantly being faced with questions. Should we ease restrictions? How can we control a rising resurgence? Are we safe to ease the restrictions that we put in place? And critically, how can we balance the social costs of these interventions with controlling COVID-19 transmission? And to answer this question, what we really need to know is if I were to implement an intervention, what would this do to the spread of COVID? And that is sort of exactly the question that our work tries to answer. So what I'm going to do is give a very quick overview of the type of approach that could be used to tackle these types of questions. And we used like data-driven MPI effectiveness modeling. And this has several components. So let's just run through those step by step. So with data-driven modeling, the first thing that we're going to use is data. In the context of government interventions with COVID, what does that data look like? Well, we collected data of the timelines of different interventions in different regions. For example, when did the UK close schools? When did Nuremberg close nightclubs? This tells us what did a region do? How did a region respond to the COVID pandemic? The other data that we're going to need, or that we use, is the number of reported cases and deaths in those regions. By looking at the number of reported cases and deaths, that gives us information about COVID transmission. Is transmission high? Is it low? Is COVID present in the population? Is it not present in the population? So that is the data that we're going to use. And we're going to data-driven NPI effectiveness modeling. We need a model. And we're going to use like a Bayesian generative model. The purpose of the model is effectively to link the effectiveness of an intervention with the observed dynamics of the pandemic in a specific region. That's sort of the sort of question I would answer is like, okay, suppose this intervention, closing schools, was really effective. How would this show up in the observed cases and deaths? I think that's fine. Cool. Specifically, like a Bayesian model would define a probability, okay, if the intervention, closing schools, had this effectiveness, what would the probability of this set of observed cases and deaths be? And if I combine this Bayesian model with a set of prior distributions, i.e. before observing any data, what are our beliefs about the effects of different interventions, we can turn the crank of like Bayesian inference and produce like a nice set of estimates of the effectiveness of different interventions with credible intervals, which is really useful because we care about uncertainty. And this general recipe, like data, model, prior distributions, can be used in different situations, and we used it like many times throughout the COVID pandemic, looking at the effects in the first wave around March 2020, so what we call the second wave, the resurgence at the end of 2020, the effects of mask wearing and seasonality. But instead of focusing on the results here, and you can check out the papers for the results because they're interesting in their own right, I'm going to focus on like learnings that we got from doing this research over the past few years and what that might mean for us today. So the first learning is that we're doing data-driven modeling, and that means that the quality of our inferences, the quality of our results, is only as good as the quality of the data that we're putting in. There's this classic phrase like garbage in, garbage out. No matter how good, how fancy, how advanced your probabilistic model is, if you put in garbage data, you're going to get garbage results that aren't actually useful. But the thing is that data collection is really challenging. It requires judgment calls, proboscoping, effective teamwork. Not only is it challenging, but I think that contributions to high quality data can be like undervalued by academia, and often not really, these skills aren't really taught by academia. So one thing I'd like to leave you with is how can we incentivize high quality modeling ready data collection and equip teams of researchers and staff with the skills to collect such data. The second learning that I'd like to leave you with is that we're doing data-driven modeling, which means that all of the inferences that we make are made in the context of our data. In the context of COVID-19, one thing that this means is the effectiveness of interventions, the effectiveness of closing schools or closing restaurants, changes throughout time. One really easy example of this is that closing schools right at the start of the pandemic, or before the pandemic, actually means something quite different from closing schools in October or November 2020. Why is this? Well, as a society, we sort of came together and said, okay, how can we make schools safe? Also, throughout the pandemic, people changed their behavior. Before the pandemic, people would meet in large groups. Towards the end, or the middle of the pandemic, people were scared. They didn't go and meet in large gatherings. If people in the population no longer meet in large groups, then banning large gatherings isn't going to make a difference. It isn't going to affect COVID-19 transmission. The thing is that sort of at key, policymakers want to know the answer to the question, if I close schools now, if I do this intervention now, what's going to happen to COVID-19 transmission? But the question that data-driven modeling is really answering is, historically, at these points in time, in these countries, in this context, what was the historical effect of a specific intervention? And these are different questions. Communicating the limitations and nuance of these type of results is really, really important, but a set of best practices is not really clear. And I think that's something as a community we can think about and work on. And one more thing I'd like to leave you with is sort of how can we adapt to time sensitivity? In a pandemic, we have exponential growth, and you've heard this all time and time again for the last 3 years, but it is very hard for us sort of humans to sort of intuitively grasp what that means. But what that means is that a delay by a few days, a delay by a week in an exponentially growing pandemic doesn't just have a small effect on the public health outcomes, it has a really drastic effect on the number of infections, the number of cases, the number of deaths. The question is, how can we produce decision-relevant research in a timely fashion in emergencies? Another way of looking at this is that sort of as academia, as a community, what are we optimizing for typically? How are we training people? Well, typically we might care about being completely correct. We don't want to make mistakes. And that's all well and good. But in a pandemic, in an emergency, what we really care about is making good decisions. And so the thing is that I think that if you were to optimize academia, optimize our community for making good decisions, decision-relevant decisions, I think this could look quite different. I don't have the answer to these questions, but some ideas would be having our tools ready before the emergency and releasing high-quality, well-documented code and resources so others can very quickly and easily build upon them and iterate, which means we can do our research faster and make better decisions or more timely decisions. Other interventions here could be alternative peer review protocols with more dialogue and real-time discussion. Cool. So let me summarize what I've just said. Well, in the context of COVID-19, understanding the effectiveness of different interventions is really important for smart policy, for good policy. One broad approach to tackling this type of problem, this type of question is data-driven modeling, especially in Bayesian models. And the key thing I'd like to leave you with actually is that, well, perhaps academic structures, academic incentives are not well designed for performing time-sensitive research in a pandemic, and these structures and incentives are not really in place or there to equip researchers with the skills that they need to perform this research in a comprehensive but time-sensitive fashion and communicate the limitations and nuance behind that research effectively. And I think it'd be really great if, as a community, we can sort of sit together, work out what we think are best practices here, because emergencies will happen in the future. With climate change, there'll be other emergencies, and knowing and establishing a set of best practice guidelines in the scenarios, I think could be really impactful. Cool. These are some of the links to the work if you're interested in the actual results. And it was really great to have your attention. If you're interested in this type of stuff, please come and find me, grab me at some point, and I'm very happy to take questions. Thanks so much.
Yeah, really excellent, Minank, and I would love to discuss with you the advantages, disadvantages of Bayesian generative models versus causal inference of the types where we build counterfactuals, right, based on data structures that we discover. I think that's a big topic and wonderful to collaborate on such themes. As you know, Judea Pearl has come around from a Bayesian scientist to become a counterfactual observational scientist. So there's a lot to learn mutually and go back and forth. And I loved your idea of alternative peer reviews. We've seen in COVID-19 that peer review has massively accelerated, especially for COVID-19 papers.
Yep.
And at the same time, the quality of peer review has decreased. We've seen more retractions, we've seen more severe retractions, so there is scope, I think, for improvement to cut down on the delays while keeping quality high. And journals like eLife also are powerfully experimenting with alternative forms. So wonderful ideas. Any questions to Mrinak? Yeah, Peter. What do we do? Do we throw?
Where?
So thank you, very interesting presentation. You concluded by noting the question of whether structures and practices are suitable for effective communication of the science in this type of modeling. Can you share any examples of whether you found structures and practices that were more suitable in some places? And any thoughts you have on whether the issue is more structures or practices?
Give me a second to... You can still hear me, right? I think like you've made a distinction in this. I mean, okay, how I'm interpreting your question is that, one, are there any examples of ways of communicating the research and limitations of research which might be better? And, you know, there could be the structures in place and the actual practices that people use. And, you know, which one of these could be more important? That's what I'm hearing. Cool. Yeah. So I think I don't see such a big dichotomy between like structure and practice. I think, you know, if the practice or the habits that people have when they're researching is how can I really clearly communicate my research, really clearly communicate the nuance here, I think that would lend itself to structural change. And at the same time, if we have a structure in place that helps researchers ask these type of questions, it automatically changes best practice. So I think my view is much more holistic, and I think one thing is that usually it's just better to actually talk to a policymaker, to talk to someone in person than in a paper, because at the same time the truth is that people are also optimizing for can I get this paper published somewhere, and that means they might say different things in the paper that they would communicate in person. So I think that type of communication is best, but I don't have any more nuanced thoughts on that. Thanks so much for your question.
Yeah. Great, thank you so much.
Absolutely.
And we will have a panel in the end, I think.
There's a question here.
Oh, we have one more question.
Yes, one more question.
One more question.
Thank you very much for your presentation, and you made a lot of emphasis on data, and it reminds us of what Ali said in the morning about collecting data and quality data. I have the impression that we've become data consumers, but not much putting effort or say resources in data generation. Because Ali was talking about how to transform the HDSS to the next level, 2.0. And this is the first of its kind. So I just imagine all the fancy artificial intelligence, machine learning, eating data. So we invest so much in other resources to consume the data, but the collection of the data, the improvement in the quality of the data, primary data. So do you have the same impression? And if you do, how do you think we can push this agenda forward to make sure we get more quality primary data to feed our fancy analysis? Thank you.
Cool. So I'm hearing the question as that shifting from a view of consuming the data that we have out there with advanced machine learning statistical techniques towards an approach where we would think, okay, what is the question we're trying to ask here, and then how can we collect the data that would help, best help us ask that question, and then how can we make the shift in practice? I think it's quite difficult. You know, in my experience during the pandemic, the data that we have access to is not the optimal data that we would use to actually ask the question or answer the question. You know, what happens with the effects of different interventions? I think something that could be promising here is maybe like closer links towards like between academia and government institutions. It's like very predictable. It was predictable that we might want to know what is the effect of different interventions. And the governments probably like have this data, but getting that data to us, to like a modeling team, was very, very difficult. But I could imagine if we had sat down and spoken together right at the start of the pandemic, there could have been stuff that we've done there. So on that, I mean, maybe just like early thinking and preparation. And I also do really like this approach of, okay, specifically, what is the scientific question I'm asking? And what data would best help me answer that question? Yeah, I hope that's helpful. Thanks for the question.
Thank you for the introduction, ladies and gentlemen, dear colleagues. Now bringing the veterinary perspective on human and veterinary pandemics. We live in an interconnected world. Truly, climate change is an issue. Ecosystem health, ecosystem destruction, degradation, and everything is also then connected to human and animal health. That's not new to you, and it's also not new that over the last decades we experienced a number of new, previously unknown zoonotic events, starting with avian influenza, H5N1, and not at least ending with the coronaviruses, SARS-1, SARS-2, and MERS corona, and also those diseases that cause a lot of death in humans, like HIV, that have a zoonotic origin but are no longer considered zoonoses. It's fair to say that not all diseases, not all pathogens and pandemics originate in wildlife and then jump into humans. We also have a number of diseases over the last 100 years that come from domestic livestock. So pandemics do not only originate in Asia and not only in wildlife. What is so central to One Health, to the thinking of One Health, is livestock. And why is it so? Because if you look at this slide, you can see that there are wild animals, and whenever there's a high prevalence of a disease in wildlife, there may be a higher risk of spillover into livestock and or humans. Now, if a disease jumps into livestock, we have a severe amplification mechanism because we keep a lot of animals in a dense space and pathogens easily spread within these populations. At the same time, it functions as an incubator, as we saw it in SARS-CoV-2 in mink farms, where we had a spillover from humans into minks and a spill back from minks into humans. The density of the interface is much greater than what we experience from wild animals and humans. If we think about public veterinary services, they have the task to prevent and control diseases, also the transboundary animal diseases, protecting humans from zoonotic diseases, food safety, quality assurance, animal welfare, and the protection of the environment from any harm that originates from animals and their products. And that should be, ideally, in close collaboration with the human health part and the agriculture administration. That is in line with our goal to reach with the Sustainable Development Goals. Fighting poverty, fighting or zero hunger, food health and well-being, good health and well-being, etc. The issue is that if we compare the settings, for example, between the tropics and us here in Europe, the work environment is much different. In Africa, it's much more diverse compared to the standardized settings of food and animal food, food production in a European stable, for example, in pig industry. And that tends to lead us to the assumption that we create fancy new institutes, like my one, the Institute of International Animal Health, One Health, and we go out into the world and explain our partners how One Health works. But the reality is much different. If you look at this map, the green countries are the ones that have a national One Health strategic action plan. Germany is green, but it's wrongly green because we only have a brochure from the BMZ, and that was wrongly integrated here. So you can see that we can actually learn from Africa a lot. One example is Nigeria as one of the best One Health strategic action plans, and they already write joint field investigations of outbreaks of zoonotic diseases and have included veterinarians. They do these outbreak investigations together. Veterinarians, human health scientists, and environmental researchers go and do outbreak investigations. And 2.5 years after COVID, Germany still has no national One Health strategic plan. Disease outbreak investigations are traditionally siloed. We have the different disciplines, they hardly communicate, there is limited cross-sectoral data sharing, no exchange, no standardized interface, and there are huge legal and organizational restrictions. That's the reality where we are at the moment in Germany and many countries in Europe and the northern world. There are good and bad practice examples, for example, the tripartite guide to addressing zoonotic diseases in countries, and they already write that joint risk assessment makes a difference and is the recommended thing, but still we are lacking behind. This is an example, and for time reasons, just focus on graph number C. You can see the human exposures to rabies and dog rabies cases, and you can see they are clearly correlated. In other words, if the human doctors would be informed by the veterinarians in those areas that there is a higher number of rabies cases in dogs, they can quicker go for the post-exposure prophylaxis in dog bite cases and save lives. If the veterinarians would be informed that there are more rabies cases in humans, they could go and do vaccination campaigns in dogs. We need to share those data. Another thing, where the ecology component comes in, if you know about the flight routes of wild birds transmitting avian influenza, highly pathogenic avian influenza, we can already say to the farmers in Europe, scale up your biodiversity. Avian influenza is detected on the way of these migrating birds and it will arrive in Europe. And that's actually what the Friedrich-Loeffler Institute is doing constantly, risk assessment. But these data hardly find their way into human health. And that's a zoonotic disease, so it would be really interesting to share those data and to have a common platform and exchange. Another thing is we should go away from only looking into zoonotic events. This is the current situation for African swine fever. It's killing wild animals, wild pigs, and also house pigs in food production systems in Asia. And people are losing income, food. They go and have to compensate their nutrition in going and getting bushmeat, and they have no money to access healthcare. So even non-zoonotic diseases clearly impact human health. And you can see that's an example from Vietnam in 2019, and they have lost 1/3 of their pigs just to African swine fever. And that's continuing, as you can see here. We have 2 major hotspots, one in Asia and one in Europe. We should also not forget that not everything comes from the tropics and needs to be new. If you think about mobiliviruses, you probably know that measles originates from cattle, from a mobilivirus that affected cattle. Now, another relative to this is canine distemper virus. And canine distemper virus is actively on a search for new hosts. We see an increase of host species, the host species range over the last years and decades, and it now includes already non-human primates. And that's a disease with the R0 of 15, a deadly virus in primates. And if, for example, we would be eradicating measles, there's a naive population of humans, and if that makes a jump into humans, we have another problem. So not always those things are relevant from the tropics. How can we overcome this shortage of communication? We are developing tools together with WHO, for example, for rabies here, national bridging workshops. We bring the human health sector and the animal health sector together and run a workshop so that we create networks and we really foster these collaboration across the sectors. Again, this is a map showing you where these workshops have been done so far. We can learn a lot from our colleagues in Africa. We are inviting them now to talk to our politicians and to demonstrate how it works. All the northern countries are lacking here. We are very lucky as FLI to have a president, Thomas Mettenleiter, who's also the co-chair of the newly founded One Health High-Level Expert Panel. founded in May 2020, together with Wanda Makota, and it's about policy relevant scientific assessment and the guidance and development of long-term strategies and approaches. They have redefined the One Health term. It now says One Health is an integrated, unifying approach that aims to sustainable balance and optimize the health of people, animals, and ecosystems. So we have all three compartments in there. It's about different disciplines. It's about society at different levels, from the rural, urban areas to mobile communities, local, national, regional, and global. And through communication, collaboration, and coordination and capacity building, we get the One Health outcome. I think Buckminster Fuller said something that really applies to One Health right now. You never change things by fighting the existing reality. We have talked a lot about we are using the wrong system. We have to make a change. What we now have to do is to change things by having a new model, the One Health model, that makes the existing model obsolete. And that really means we have to bring One Health lighthouse projects where we can demonstrate that One Health works on the local, regional, and global level. Having showcases that demonstrate to the opinion leaders and the decision makers that One Health is a difference. And not only in the academic world, everywhere, through innovative thinking and the motivation to change something across the borders. We have started things like that on a small scale. For example, we work with SORMAS, the Surveillance Outbreak Response Management and Analysis System created by Helmholtz. And what we're currently doing is we try to establish a layer of environmental signals and animal health signals that are included into the system, and for example in Ghana, so that we can use water sources, drinking water, not sewage water, where we can see that if there are some pathogens in it or increased AMR levels, that people are warned to not go there and take the water for drinking or using it for their cattle, and that hopefully prevents diseases from emerging because we can warn them ahead of infections. So what you see here is the root causes and the long-term effects. And in the middle, you have the unwanted central event, the spillover, for example. We really work a lot on the emergency preparedness level, but where we have to go is we have to move into prevention. That's hard, because how do you measure prevention? How do you get funding for something that, if you do it right, will never happen? And that's a real issue and something that we all have to work with. But there are already good data out there. Andy Dobson, a really brilliant modeler, showed that this red box here are the costs compared to the costs calculated for coronavirus damage in 2020, and this is even greater now. The red little box here indicates the costs that are necessary to prevent a disease. So it's minor to what we experience at the moment, and these are the figures that are convincing to the politicians and decision makers. And it's fair to say, pandemics have happened throughout throughout human history. It's just indicated with the color that they rapidly affect now all the continents because we travel a lot, and they happen regularly. So we can already predict that the next pandemic is on its way, even though we don't know what it is. Maybe another coronavirus, maybe mobiliviruses, and it's better to prevent it from happening rather than just running after those things. So in summary, the agenda for cooperation, research, and policy. There is no magic in One Health. It means just to work together, lead by example, everyone, from the local to the governmental level, everywhere. Don't allow One Health to become a new silo. Be committed to good scientific practice, and One Health is politically supported. The momentum is now. You can see that on all levels, and also that's the reason why we're here right now. The tripartite is now quadripartite, so WHO, FAO, OIE, and UNEP have joined forces, and so should we. And with this, I would like to thank you for your attention.
thank you so much, Sasha. Very interesting, and the potential for reverse policy innovation from Africa to Europe and, as you said, Northern world is powerful, and we should really learn and engage heavily and learn from people who have good processes and good policy mechanisms. Any questions for Sasha? Alina.
Yeah, thank you so much for the presentation. I was actually wondering, how do you see the relation to the concept of planetary health? So is it complementary, or is it the one or the other? Yeah.
My personal view on it is that we don't need these differentiations. It will end up planetary, galaxy health, whatever. I think it's one health, and it's just the borders, how you see it. It can be an ecosystem, or it can be the planet, which is actually the same. So I think it's causing a dilution effect, and it would better, it doesn't matter how you name it, if it's one health or planetary health, as long as we do the right thing and work together. So I think we should overcome this fighting against, what is it? Is one health now planetary health or vice versa? And I think it's just, sucking energy without really doing a difference. That's my personal view on it. And I think with the new definition of One Health, we clearly see that climate change and all these things are also part of One Health.
Yeah, let's have maybe 2 more questions. And in the meantime, Rinang and Ellen, if you could come back for a panel discussion. If you could already come back to the panel down here. Ellen, thank you. And Rinang, hi. Yes.
Okay, thank you so much. So my name is Agrin, I come from Indonesia. I'm a veterinarian by background and a master student in Heidelberg of International Health. So my question is that you said that the One Health itself, One Health concept or initiative in this world actually is like a political commitment in a way. So my question is like, what do you think? Like, what is the critical aspect in the government system that you think would be really help to be like interdisciplinary collaboration to really works somehow? Yeah, thank you.
Well, I just recently joined FLI, which is a governmental institution, in 2020, and formerly worked in a research institute that was not connected to politics. And I experienced politics to be very conservative. And I think we as scientists often make the mistake to stand in front of an audience and say, your system is not working and you need to change it. One Health is the way forward. But what we don't do often, it's slowly changing, is presenting our data and showing that it really matters and saves money and lives and all these things. I think we need to be more convincing. And we have to fill the term One Health with real examples that showcase that it will work. And it's, at the end of the day, I'm pretty sure no one will refuse to do a One Health approach if it clearly outlines that it is more cost-saving, that it saves lives, etc. I think the effect matters. So that's the convincing part of it. I don't think there's a shift. It's the same thing. It's all connected, human, animal, and environmental health, and that includes, in my view, also climate change, etc., the environment. And I don't think there's a shift from one thing to another. I think it's actually 2 communities that should be the same. I personally don't see there is the need to distinguish. You're welcome.
Thank you. Yeah, so my question was similar to what you discussed right now. It seems like in terms of the IPCC, if you look at the big assessments and so on, there's not much actually on zoonosis and prevention and the climate-induced risks in relation to One Health. And at the same time, if you look at the sort of pandemic preparedness, the Intergovernmental Panel and the report, there's very little on prevention and climate. So it really seems like these are siloed communities. And that's really much, it's such a shame that even in the scientific community, we can't really work and tackle these issues together. My background is with the climate community, although I'm working a lot in the One Health community as well nowadays. So hopefully in the future, these communities would merge and work together. And I think that's actually the last thing you said.
Definitely, yeah, that's true. I think I haven't shown it, but I have another slide showing you. I mean, we all know that livestock is one of the core sources for emission, driving climate change. If you have healthy livestock, it helps to reduce emission because you make production more effective, and that's, I mean, this is the clear veterinary task. So I think there are a lot of loose ends that we just need to tie up and demonstrate that if you do a proper health service in veterinary health service in countries, you can also help to reduce greenhouse gas emissions, things like that. So I fully agree. There are deep roots that bring us together, and I really hope that we can overcome this. We are part of planetary health. We are part of One Health. We all have to think as One Health and come together as a group.
Yeah.
Instead of, fighting over definitions.
So we have to work on that.
Yeah.
That's
I welcome this.
And the prevention.
Great, yeah. Thank you so much. Sasha, if you would join us. I want to start us off with a question, so really powerful and diverse, yet somehow it hangs together in a very integrating way. And I wonder if I could challenge you, the one intervention or the one action that we could do in your respective fields, cancer, COVID-19, non-pharmaceutical interventions, broadly science policy, and One Health. What would it be? And the constraint I would like to put on your thinking is in a resource-poor situation, something that doesn't need massive resources, maybe the one behavior that we would need to tackle to most substantially affect cancer burdens or reduce the spread, the risk of zoonotic spillover in contexts where that is common and matters. Who wants to start? The one intervention, the one future-looking action that we should take? Or research?
I can give it a start. Hand this over to you.
Thank you very much.
In my view, the key is to bring the different sectors together and start discussing things and then ending up in national action plans that will help us to guide the way into international action. So really getting this standardized and more organized in a way that we can build up on these different strategies and then hopefully create a joint international strategy for One Health.
Yeah, maybe I can just follow up on that. I mean, in the cancer area, there's a huge amount of money goes into cancer research globally. Can you hear me? No? Is this? It's on. Okay, I need to sort of hold on. Okay, so I think that there is actually a major field change taking place right now in how cancer is funded. And that is the major charitable organizations as well as government-funded agencies like the National Cancer Institute in the US, I think are moving towards a more global approach, definitely. So these, I mentioned this one grant system that has just really started about 5 years ago. And this involves putting out a worldwide call. So for the first time, the US and the CRUK, Cancer Research in the UK, they put out worldwide calls. Anybody on the planet can apply for these huge amounts of money. And there are sets of what are called grand challenge questions. You get the best people together and you ask them to come up with what are the 10 top questions that we need to answer if we're going to solve the cancer problem. And then there's a worldwide call for proposals. They dangle a lot of money out there, but it has to be international. It has to be multidisciplinary. It has to use all of the expertise available from many different fields to focus on this one question. And that takes place over a 5-year time period. It's constantly evaluated, much more scrutiny than your average National Cancer Institute grant. There are committees that are set up to monitor each step of the way. And I think it's really changing. This approach has been running now for just over 5 years. I've been involved in one of the first ones, and this is the new round that's just starting now. And I really do think it's changing the way cancer science is done. And I suspect that it's going to extend to other branches of science, not just cancer. But it forces global cooperation by making the money available only for groups that are involved in that. So it's highly competitive. A lot of people don't like it because it's taking a major pool of money away from the smaller grants, which are the bread and butter of research. But I think it has to be done.
So in the context of COVID, where it's sort of coming to like a different phase where we're sort of getting more used to living with it. And I'd just be pretty excited to look back over the sort of the policy decisions and the communication that happened in the last 2 years and think what went well here, what didn't go well here. So one thing I think is that like we saw the importance of like early action. You know, everyone's talking about exponential growth, we need to act early, but like typically across Europe in the second wave, even though we'd had quite an intense first wave, you know, there's a lot of death, a lot of cases. We did not act early, and we allowed the cases to go high again. And it's a bit disappointing to see that, because the first time, you know, we don't know what we're doing. It's an emergency, it's a pandemic. We don't know what to do. But sort of societally, sort of the incentive structures that we had led to us making these same decisions. And I have this context, you know, as a researcher. I know there, but I don't know exactly what's happening that leads to these decisions being made. So I think, like looking over this time period, what went well, what didn't go well, how could this go better in the future? And not just in the context of COVID, but in the context of responding to real-time emergencies in like effective ways to save lives, I think would be very, very important. You know, I don't think we were well prepared for the COVID pandemic or the emergency, and I think it's wise to expect future emergencies to happen.
Any questions from the audience? Alan can throw. I'll allow you to. Yeah, this will be challenging. I'll try my best. It's the old handball.
Thank you very much for the nice presentations. My name is Michael Lopata from Heidelberg University. My question goes to Shama. I mean, one of the highlights of your slides was garbage in, garbage out. So what this means is that if you got crappy data, you get crappy results. But as researchers, sometimes we struggle to really understand how you pre-process your data and how you organize your data in a manner that you can really reproduce what you as a Bayesian scientist really did with your data, especially when it comes to COVID data. So do you think it should be more open, or scientists should be more open with the way they handle their data from analysis to publication? Because most of the times we go to the publication, cool title, cool equations, no data to reproduce your results? Thanks.
Thanks so much for your question. So I'm hearing this question as so we've got garbage in, garbage out, and there's data, and there's also like pre-processing data that happens, and often for papers the data is only available on request. I think like all data should be made publicly available. Even once you've got high quality data there are many different assumptions that can be made, many ways of processing the data, pre-processing the data that can affect the results in ways that like aren't transparent or like unpredictable. So I think it's important that we assess the sensitivity of policy relevant results to different ways of processing the data and assess the sensitivity of the results using the same data but a slightly different model and asking, do you get the same, not necessarily the same results, but you take away the same conclusions for policy. So I would be really excited to see data, code, and not just data and code, but where the documentation around the data and the code is quite high quality online. But you know, of course, when you're doing research in a pandemic, there's a lot of time pressure. So finding ways to have both reproducible, high quality documentation at the same time as responding in real time is really difficult. And I don't really know how to best do that. I hope that answers the question.
Thank you. My question is to Dr. Shasha that Bangladesh is one of the, I'm from Bangladesh, so Bangladesh is one of the very few countries has one health policy. But like, you know, my experience is dominated by all, like, you know, physicians, the medical doctors, and there's very little inclusion of the veterinary, those who are working veterinary, and the doctors are not very keen, and even I think don't have that understanding. So my question is to you that, I don't know whether it exists at the global level, but if we can't make the doctors, the human doctors, to make them understand the importance of being inclusive and bring veterinary to make One Health successful, how can we proceed?
That's a common problem. We often see that the veterinary part is more or less neglected in terms of resources and infrastructure. That's what we want to change in some of our projects. For example, FLI is building now under the mandate of the ministry field presences and as a demonstration project. One will be in Zanzibar, the other one in Vietnam. And in Zanzibar we have the same thing. Through COVID there was a lot of funding for the human health sector and the veterinary part is largely neglected. During BSE, so that was different. So there the veterinary part was more and better equipped. And so there will be a constant change throughout the pandemics, whether it affects the veterinary part or the human part. But in general, I think it's important to lift the veterinary part in terms of expertise and also resources and infrastructure so that they can meet on eye level. And I think both parts, and actually also the third one, the environmental people, they need to understand that there is no way around collaborating. So it's about bringing them into one room and doing workshops and discussions to really generate the idea that this needs to be done as a team. So.
Yes.
Yeah, I think with these sorts of, you know, there's different factors. Each of them have their own objectives, and there can be these senses that everyone's playing on their own team and not working together. And I just wanted to highlight that. Sort of, I hope, at least aspirationally, that it's. You said this. They're playing on the same team. We're playing on the same team. We care about the same things. How can we work together and find a solution that best balances everything here, rather than sort of fighting over the little differences? And I think that sort of environment or atmosphere is much more conducive to coming up with creative solutions.
Yeah,
hello, thank you.
Yes.
Thank you so much for the presentation. My question is also to Dr. Knauf. You showed the value of data sharing between the sectors of One Health, And my question is, how do you estimate the problem or the magnitude of the problem of data or knowledge standardization between the sectors? So to say that, I know that there is an initiative like Tricycle Protocol for AMR from WHO, but otherwise it looks like it's different protocols for data collections among the sectors. And do you see the ways how one can approach, whether it's should be from the scientific community or from the public health community or veterinary? Thank you.
Yeah, that's a good question, because we do see that in many countries the sectors are somehow collecting the data in a very good way. In Germany, for example, the animal health data are, you can trace the animal from birth to death, and you can see all the infections that it had, etc. But still, there is no interface to the human health part. And I think Germany and Europe is a good example for the problems that we have, because sharing data means to overcome data protection and all these privacy issues. And that's where the big problem starts. You cannot just simply share data. For example, the poultry farms that were affected by avian influenza with GPS data and the name of the owner and all these kind of things. So it's a huge task. I have no solution for this, and I guess this needs to be handled by the big data people that better know how to handle those things. But we need to talk about it, and we need to talk a bit about it on the local and on the global level. I fully agree, but it's not easy to do that. SORMAS, for example, is a human health management system where it's now integrated the environmental layer and maybe later on then the animal health layer, but we do have our own animal health system and databases, and probably it's easier to just link them and having an interface that can speak with each other rather than just copying everything into one database. I have no idea, but it's a big challenge, definitely.
Yeah, excellent questions. Let's finish with one question, a last one. You're all scientists, you're all masterful communicators, and Rinang, you raised the question as a starting point for discussion. How can we better communicate the nuance in science, the uncertainty in science? Any takeaways from your own communication practices and experiences? How can we be better communicators of scientific results and insights? Who wants to start?
Yeah.
Yeah, well, in our field, there is a major requirement for better communication, because there's so much confusion out there about what really is important in how we as individuals conduct our lives to avoid disease, in particular cancer. We know already so much, but the vast majority of it is ignored. And for much of it, there are lots of tales and recommendations that we kind of grow up with about how we should conduct our lives to avoid disease and avoid cancer, but we really don't know how many of these factors are working. What are the mechanisms? And so it tends to get sort of swept under the table. And a major part of what we're now trying to do is engage the community in trying to disseminate in simple terms that everybody can understand what the science is telling us about mechanisms. Because I really believe that if people understand why something is working on your body in a certain way, if you have any sense at all, you will take more account of that and change your behavior accordingly. And try to get the message across that the cancer is a disease that is eminently preventable. 80% of it is probably due to environmental influence. Genetics is another major component, but there's so many things that we can do, and we haven't succeeded in this very important issue of prevention by explaining this adequately. So that's going to be a major point of these new grand challenge questions, is to try and improve communication to the public.
One thing is that I think we can get a lot of leverage just by very carefully asking ourselves, what do I actually believe? Like as like the expert or as the person doing this research, if I sit down and not just think I want to get this result out as soon as possible, and I said before the time criticality is important, but at the same time we need to balance like what do I actually believe, and that means testing our assumptions, thinking about okay, I've written down this equation in maths, I've written this down in the model. What statements is this implying about the real world? And sort of sitting with like a piece of paper and doing this for like a few hours, and then internally you can get a better sense. What do my results actually mean? And then ideally you can like frame those results in the context of like what decision is this person I'm speaking to trying to make. Cool.
I have one. I'm a little bit biased in yes, we need to communicate better our research results, and we need to translate our research into policy and help to translate it. At the same time, I believe that researchers should stay independent and should not interfere with politics, because that's not our job. Our job is to deliver high quality research data that provide evidence that can be used by the decision makers to make their decision. So I think we need to find a balance between going out and communicating our research to the public as well, and at the same time doing our job as researchers in doing research. So I think there needs to be also maybe a part that functions as a translator that is between decision makers and the researchers.
Yeah, thank you so much, Sasha, Rinang, Alan, and it's a starting point of a discussion and hopefully collaboration.
Welcome. I'm not the official welcome speaker. This is the rector and the dean of the medical faculty. But I do want to announce our concert pianist who starts, as always, with a piece. She's from Turkey, but she plays something that you all know. Gülsin Onay from Turkey, please. And if you... round of applause. So I hope all the stress of the day has now gone, is gone, and you can now focus on our rector, Bernhard Eitel. See? And all the speakers have to go to the podium, unfortunately.
So once again, in the morning, I welcomed you already, and I am proud that it's my privilege to do it again here in the Great Hall of Heidelberg University, or in the, as we say, Alte Aula. The morning we had an introduction with South African music, and now we have the end of the day and this festive event in the evening here in the Great Hall with Central European music. So we see internationality as a central part of the symposium, as well of the Institute of Public Health of Heidelberg University, and of course of you, of the auditory. Spectabiles, dear keynote lecturers, dear colleagues from all over the world, you came here to Heidelberg, and I welcome you in the Great Hall. The Great Hall of Heidelberg University is filled with history. And I would like to give you a short introduction about our spirit, and I hope that this spirit, this vivid spirit of science and of research, inspires you as well, has already inspired you today, and will inspire you in your future work. Heidelberg University was founded in 1386 by Prince Ruprecht of the Palatinate, and in the 19th century, 1886, with the 500th birthday or anniversary of the university, the Grand Duke of Baden made a big gift to the university, and this gift was this Great Hall. And the spirit of the founding certificate of the permit of the Pope in 1386 was reconfirmed in 1803 in Napoleon times, and in 1945 by the American troops reopening the university after the Second World War. And they reconfirmed the spirit of Heidelberg University's tradition and how we define ourselves. Heidelberg University was founded as a comprehensive research university, and you see it in the medallions here on the ceiling, starting with theology, with law, with medicine, and last but not least, with the artes liberales, the predecessors of philosophy and natural sciences. Along the role model of older universities in Western Europe like Paris, Oxford, or Cambridge. The both balconies, they stand for the medieval disputation, or because Hegel, the famous philosopher, taught in 1816 in Heidelberg, and developed here a little bit. He worked near his dialectic philosophy of forming an hypothesis. Here the second balcony stands for the antithesis, and you, the auditory, you have the task to find a synthesis. And that's the symbol of research orientation. So comprehensiveness, I mentioned already in the morning, both balconies, research orientation, and you see here in the fresco behind me the incoming professors in 1386 to Heidelberg from all over Europe, not the world, but the medieval world, from all over Europe, because they were oriented to the Pope in Rome and they had to leave their countries, in particular France, and the Prince opened the university and took them over as science refugees, as medieval science refugees. So we are an internationally oriented, comprehensive research university. And you see behind this philosopher with a white collar, you see a black man. And this black one is Marsilius von Ingen, the first rector of Heidelberg University, and he has been the rector of Paris University. The prince recruited him, and perhaps, I always say that, perhaps it was the first successful headhunting recruitment process in science history. So he brought him to Heidelberg to found the university. But you see Heidelberg University and the spirit of this Alte Aula, of this great hall, comprehensiveness, internationality, research orientation. And we are proud that our institutes today, at present, in Heidelberg University, at all campuses, including Mannheim and Santiago de Chile, including all partners of our scientists of Heidelberg University, share our spirit, share research orientation, share meritocratic systems in science and research and higher education. And we share the same task to produce results, findings, to translate these results and findings to society or by transfer to industry. So we are part of societies. We are dedicated to help societies, humankind, and individuals for a better life, and we create future for our societies, and we create it presently again. We are facing big challenges, and your symposium about climate change, pandemics, diseases, but also individual welfare, societal success, all these topics we are facing, you treat them again also by your research in your institutions, by your own individual efforts. So we are proud that you are with us. We are proud that you meet in Heidelberg University. And in this hall, I think, you are at the right place. We always feel at home here. It's a place where research is vivid, where we can come together, we can exchange our experiences, we hear news out of research, we hear about inspiring new ideas, we can share our opinions and our convictions. And we can create, as I mentioned before, we can create future. I wish you all the best here in Heidelberg. I wish you all the best for your meeting, not only for your individual careers, for your individual benefit, but for the benefit of our societies. And we all form, and if I look to the auditory, I see and I feel it. We all form a global society. All challenges we are facing are not restricted to limits, to borders, to frontiers, to nations, to states, or something else. We all form a global community, and we have also the task to come together to train, coach, and educate the next generation in the cosmopolitan spirit. Because they have to take over the stick from us in order to do the same what we are doing, what we did, what we are doing today and in the future. Thanks for coming. All the best here in Heidelberg, and good luck and a lot great success for your future, for our future on our small globe. And as an Earth scientist, I always say, we are in spaceship Earth. We have to steer it. Thank you very much.
And now the Dean of our faculty, Hans-Georg Kreuslich, with whom I've worked a lot, and many have worked a lot, so the floor is yours.
Not to give an introduction because time would be over. Thanks very much. It's a pleasure to be here. Besides being Dean of the Medical Faculty Heidelberg, I have the pleasure of being a virologist, which is interesting in these days, obviously. And I was asked to say a few words about the Heidelberg response on the pandemics, which I'm happy to do. But I would like to spend the first few minutes on giving a few personal words on the Institute that has sort of invited us all to the symposium. You may have read a little bit about it. You know, obviously, the main players, Rainer Sauerborn, Till Berninghausen. But if we look back, it's a 60-year celebration now. It was founded in 1962. It's a pretty long time ago. I was 4 years old then, and so it spans my lifetimes, basically. But I didn't know about it when I was 4 years old. At that time, it was not known to me. And the history of the university, you just heard about it from the rector, is over 600 years. So in that sort of period, it's actually a short time. In the history of public health as a field, I think it's a very long time, especially in Germany, because Germany has been late and rather weak in public health. Over a long time and still is today. In general, Heidelberg clearly is at the forefront in this country. Fortunately, none of us has contributed to this. It was our predecessors in these positions. Public health obviously is old in principle from the days of containing plague, containing smallpox, containing syphilis and other diseases. It was an infectious disease. Topic. It was then a topic of vaccination with Jenner Pasteur in the 17th, 19th century, and the topic of vaccination arguably being the most successful medical intervention we had in all times. And it was the topic of hygiene with Max von Pettenkofer and others in the late 19th century, arguably the most successful non-medical intervention we had in all times, saving lives. 62. In the early days, I don't really know much about what happened then. Interestingly, however, it was not part of the medical faculty. It was part of the so-called South Asia Institute, an institute that was part of Heidelberg University to focus on South Asia. It was not a disciplinary institute. It was a regional studies-oriented institute, and it had a health branch. And this health branch was the Institut für Tropenhygiene und öffentliches Gesundheitswesen, Tropical Hygiene and Public Health, as I said, 62. And it's a pleasure to actually see two and hopefully have online the third of the directors of this institute, currently Till Berninghausen, his predecessor Rainer Sauerborn, and his predecessor Jochen Diesfeld, who wanted to be here today, but I learned broke his leg and unfortunately has to stay home sick. So all the best. We should all wish him well. He turned 90 earlier this year on Easter. He had his 90th birthday. Rainer turned 70 on March 1st, if I remember correctly. And the Institute turned 60. Till you should have had your 50th birthday this year. You really did not do well here in this regard. But that's okay. Jochen Diesfeld took over in 76. He got into public health also in an interesting path. He was a young assistant physician in a small town in northern Bavaria, in Ansbach, in his training, and there was a smallpox case. A person traveling from India to Ansbach. This was a vaccinated person, recovered fine, and Jochen Diesfeld also got infected, had a very high antibody titer, and then worked with the Bavarian State Vaccination Institute and started his career through that early interaction. He was chair from 76 till 97. And in the sort of, it seems like a heritage type of thing in this institute. His long-term co-worker, Rainer, succeeded him. Rainer also had an interesting career because in his civil service, he went to Africa. I don't know how you do this. When you defer from military service, you go to Africa as a community physician, where he worked for 3 years, and that installed our partnership with Nuna in Burkina Faso, which is now a very strong and long-standing partnership. And Till again studied in Heidelberg and worked with this institute in his early days as well. Then went on through the world, had a position at Harvard School of Public Health, at the Wellcome Center, Africa Center, and at other places, and joined us with one of the very prestigious Humboldt professorships, Alexander von Humboldt professorships. That's one of the most highly endowed positions we have in Germany. And he was the first Humboldt professor at Heidelberg University. We now have 2 more. Interestingly enough, and fortunately, 1 more in the same institute, Joachim Röckloff, in artificial intelligence related topics, again, related to global health. So it's great to have 2 of you here and the 3rd one online, and we congratulate you and the institute very much. That leaves me about 4 minutes or so to say something about Heidelberg in the pandemic, and I mean, other people here can say much more. We had a committee in the medical faculty already since 2006 or so to deal with epidemics, outbreaks, pandemic responses. And it was never meeting because we said we only need it when things come up. It was obviously then in place in the swine flu situation 2011. But when we heard about Wuhan and the situation in January, mid-January, and especially when the first cases came to the Munich area, this was a traveler from Wuhan working in a company close to Munich, then we immediately had initially weekly, then bi-weekly, then daily meetings of this commission. And actually, for another event, I looked up the protocols of this pandemic committee from February and March 2020. And the right questions were asked: what do we do with equipment? Do we have enough face masks? Do we have enough gloves? How about ventilation tubes and all of these things? We had no idea what would come up. We had absolutely no idea, but the questions were right and the setup was correct. Our first case was on February 27th in 2020. It was a young person, 40 years old, in his 40s, from northern Italy, skiing vacation. This was the time where all the skiing vacation travelers came back and created the initial phase of the German epidemic. He was completely fine. He obviously had to be put up in the hospital at this time. Even asymptomatic patients went to the hospital. He was sitting in his room working on a home trainer, cycling in his sick room. And then after 8 days deteriorated and was close to being put on ventilation in a very short time. And this happened with a few cases initially, and that was this biphasic course that has been seen all over the world in many, many patients afterwards. It was already our first patient. And so what we learned from this was, and we created something from this with our clinical physicians, and I was involved in this as well, obviously, as virologists. We created something which we call the corona taxi. And that was that we had the patients with mild symptoms at home, but around day 7, we had a nurse, an experienced nurse with a medical student, visit them at their home. Later, we also had pulse oximetry so that we could measure oxygen levels on them. And they were asked, they had a sort of little questionnaire, they were asked things, and then those that were seen as probably being deteriorating were brought to the hospital right away, even before they deteriorated. And we believe that that was actually quite successful. It was very highly covered. All the German newspapers wrote about it, and it made me popular in the US because New York Times wrote an article about this, and all my friends from the US called me, "Oh, I read your name in the New York Times." So you see how you can get famous. You don't do research, you just tell about things that other people do. But that worked reasonably well, and then obviously the course went as everywhere else. We had the filling up intensive care units and had really difficult times with deferral of tumor operations and everything. But generally speaking, and that would be my last statement, Heidelberg went around relatively well because we have a very close and very good relationship and interaction and communication with the local and regional health offices, and especially with the public health authorities. In Germany, this is traditionally bad because they are understaffed, and hospitals and research units do not work with the state and regional public health authorities. They don't know each other even, and that's really bad and needs to be changed. I think that's one of the major things we have to learn from this pandemic. In our case, this was, from both sides, already well established with the state officials, with the public health officials of the local Gesundheitsamt, the health office. And when we had our first meetings in January, February 2020, they were part of these meetings in our lecture hall. So we didn't have university hospital meetings. We had meetings with the university hospital, the regional hospital, private practice physician, the public health official, and the state and regional officials. And I think that was the major thing that has helped us to get through better than some of the other regions. And I say it here, not because we were the only ones, many other people had this established before, but because I think it's poor in Germany. So we need to do something, and I think, if anything, this pandemic will help us in is that the acceptance of public health and the need for public health will be rising also in a rather late and rather slow country like Germany, and I really hope this will be the case. With this, my time is over. I hope this was reasonably entertaining and interesting for all of you. It's a pleasure to be here, and I look forward to all the future presentations. Good luck. Enjoy the remaining time of the meeting, and I hope you can deal with this rather hot situation in Alte Aula. The rector sometimes calls it old sauna rather than old aula. Thank you very much. Enjoy the meeting.
Okay, and now I have the pleasure, I just checked that we have our Minister of Health online. Could you show us? He's from, we met, now I have to show off a little bit, at Harvard, but since you're here, I have to pull the Harvard card. Oh, hallo. Grüß dich. Grüß dich, Karl. Alles gut. Also toll. Thanks that you have found the time in your busy schedule to talk to us. You have the Dean of the Harvard School of Public Health here, and our Dean, and there are 6 Deans of Schools of Public Health here, and many international students and researchers, and now we are all listening to you. You have the floor, Karl.
Thank you, Rainer. Dear colleagues, dear friends, ladies and gentlemen, first of all, it's a great pleasure for me to have this opportunity, and I've also enjoyed listening to what was just presented. I would very much like to be in Heidelberg in that moment, but I can see you and I will follow the discussion. It's a real great honor and a pleasure. And I think the Global Health Institute addresses exactly the key interrelationships between health protection, climate change, food, the most important questions in many ways of our time. The topics can be seen as inseparable, and each topic alone is already complex enough. So we have 3 topics, very complex, and they are interrelated, and therefore it needs a highly specialized institute, an institute like yours, with that history and also with that interdisciplinary research in order to tackle the issues. And I follow your work as a matter of fact, and I think it is fair to say that in Germany, at least to my knowledge, there isn't a second institute that is specialized in this triangle of important questions, challenges, and ideas. For the last 2 years, health protection has been the most dominant topic. I was involved heavily myself, and I, as a matter of fact, remember in the very early days of the pandemic, I talked to colleague Kreuslich, who was just talking to us, and we at that point were already discussing about vaccines which came to the market more than a year later, and also obviously followed the Heidelberg taxi and have very often referred to it. And I can only congratulate you to the eminent work that you have done. Heidelberg has managed the pandemic very well and has provided leadership, and Professor Kreuslich's work was among the work that was often underestimated. There were virologists on TV and in public hearings that I consider were less well prepared than Professor Kreuslich, whom I would have liked to see more often, but this is only a personal remark for which I may be excused. In the last 2 years, health protection was the most dominant topic, and now we are dealing with the incredible and unpredicted human rights defeating barbaric war of Putin against the people of Ukraine, which is a public health threat in itself, and it also threatens the achievements that we have made in other fields. So this war, indeed, with the migration that follows it, with, let's say, the diminishment of assessed fundings of international agencies, with taken away attention of major research into research engagements and investments, this is a fallback that I would not have expected. And let me use this opportunity to condemn this barbaric war on behalf of our government. It is clearly a war that does not fit into a humane society. It does not fit into our time, and it is a backdrop in a time which I expected was behind us. Germany's new coalition government is determined to give the topic of sustainability a more prominent role in policymaking. And sustainability here is not only sustainability in production, sustainability in food production, it's not only sustainability with respect to climate and biodiversity, but it's a holistic approach which we want to follow. And we want to invest mostly in people, because the most important resource for efficient lifestyles in the future is the education of people. And in my opinion, if there is one tipping point which we can look at as a positive tipping point among all the tipping points which we are already approaching, or which we have already approached in climate change or in biodiversity, the single most important and only positive tipping point that I'm aware of is the Fridays for Future movement. So that is why we as a government, but also me personally, we invest in young people, we invest in minds, and this is exactly what your institute does. So this is one more reason why I'm so pleased to share this evening with you. None of these topics has protection, climate change, food, provides a coherent picture of the complete challenge we have to face. If you only look at zoonotic diseases, we currently estimate that there is about 4,000 to 10,000 viruses that potentially could become origins of zoonotic diseases in humans. And therefore, we see at the same time re-emerging pathogens and new pathogens to arrive. And what is most important, the new research in this field shows that while climate change is moving forward relentlessly in more or less a linear fashion, along with this linear increase in climate change, there is an exponential increase in the risk of zoonotic diseases. So I personally believe that pandemics will become a way more important threat to us than we currently estimate. And it is already clear that the pandemics that we have seen, the intervals are becoming shorter, and the extent of the pandemics is increasing. So that having said, I think the research between, let's say, climate change and health, and a holistic approach with the assessment in what ways the risk increases, in using also measures of intelligence, including artificial intelligence, that is research that is vastly underestimated, underinvested. And I do think that the institutions that we are discussing today, the Heidelberg Institution, the Global Health Institute, but also the Harvard School of Public Health, these are institutions that are lighthouse institutions that invest in this type of work. And without their work, we will have a very difficult time to address the challenges ahead of us. Germany currently provides the leadership in the G7 group, and we in the healthcare system G7 group have made climate change one of the three topics we focus on as a G7 group. As a matter of fact, there is three major topics on which we look. Better preparedness for future pandemics. So we invested in a pact for pandemic preparedness. I come to this in a moment. Then we focus on antimicrobial resistance, related to the first issue, but partially independent. And number three, on climate change and health. And these are the three topics on which we are working. I have already briefly mentioned zoonotic diseases, but I would like to spend a couple of minutes about pandemics. If it is true what I estimate and what researchers around me and people in, advising us, we have a big international advisory board. If it is true what they basically announce, and if we understand the current research correctly, then pandemics will become way more common and potentially more lethal than what we currently see with the COVID pandemic. If that is the case, then pandemic preparedness is of utmost importance. And our Pact for Pandemic Readiness is a pact which basically tries to improve surveillance measures, mathematical modeling of outbreaks, identification of outbreaks, early intervention resources. For example, the 100-day CP mission includes the better preparedness in terms of readiness, where information is shared more quickly, and in particular an educational effort where we would like to invest in 5 centers of excellence in the north and 5 centers of excellence in the south, where young people, including members of the Fridays for Future generation, invest their academic careers in preparing for pandemics. We do have institutions that focus on pandemic preparedness, but if you look at the list of institutions that are already responsible for pandemic preparedness, and many of these institutions have been around for a long time, you wonder how the pandemic could ever happen. If you look more closely, you immediately recognize that there is 2 shortages in these institutions. Shortage number 1, most of these institutions are vastly underfunded. And number 2, there's a shortage of highly specialized, well-educated people. So this is where the Pact of Pandemic Readiness that we are developing will enter the field, and we will try to come up with a reliable resource provision as the Financial Intermediate Fund held by the World Bank, which is supposed to support the Pact for Pandemic Readiness, including the educational institutions in the north and in the south that I have already mentioned. So we will come up with a concerted action, and I'm working together with a group of international researchers that try to organize this network of research, but also education, and I could easily see your institution in Heidelberg to be one of the institutions that could be part of such a training effort, of such a training investment, given your history and given the excellent work, the excellency that you have shown in the past. We know that there are solutions around that we could currently practice, and we do not have to wait for solutions. For example, very often when it comes to, let's say, renewable energy, have to deal with politicians and sometimes journalists and even sometimes economists or researchers in other fields that believe that we need a new science to be able to provide the extent of renewable energy that we would need in order to sustain the lives that we currently enjoy, that we, for example, sustain the standard of living, and also, let's say, the production that we currently have, that the renewable energies that we would need for that is currently not possible with the science we do have. But if you look at it, all you need is basically the science of 120 years ago. Everything that is needed in order to produce, for example, electricity from wind energy was already known in the Maxwell equations in the late 19th century, and everything that was what you, in essence, as a science rather than technology, need to know about solar energy was already known to Einstein when he developed the photon effect, for which he was given the Nobel Prize. So we have an old science, and we know how to use this science, and we could do it. We have the technology, we have the science, but we have basically postponed the investment, and I think we can no longer accept this. We have to push forward, and if we don't do this, we will lose the time spent, the next 10 years, where we could, let's say, with an overseeable investment, get gains that in a later time are way more expensive to gain. We will ultimately produce energy only by renewable resources. That is for sure. What is not for sure is when this will be the time. And the earlier we start, the less investment is necessary. We could also, for example, eat less meat or eat no meat, and we would solve many problems at the same time. We would reduce greenhouse gases, methane and CO2 rapidly and extensively. We would also reduce the problem of antibiotic resistance, which I mentioned before already. We would be healthier. We would, for example, reduce countless cases of colon cancer and heart disease. We could basically provide much better for animal rights, and we could reduce hunger and deforestation because of the energy investment which is wasted in order to produce energy in the form of meat. And this was already known in the 80s, when I, for example, in 1987 turned non-meat eater for exactly these reasons. All of this was known 35 years ago, and we are still not doing it. We should basically be way more honest about these issues, because if we are not honest about it, then nothing will happen. And in that sense, I think politics has to change in two ways, which is perhaps my most important input for today's short remarks, because I think I have referred to many issues that you know at least as much about as I do. But let me offer two insights which I, for example, which I most likely can share with you, where I may have an advantage because I've been in politics by now for so long a period of time, also internationally. So let me share two central insights from this experience and work with you, which I believe are central. First of all, I strongly believe that we will only make progress if we manage to make politics and policy way more evidence-based. Science has to become a much more integral part of the way how we do politics. This is also something that I personally practice. I, for example, despite the fact that I'm a scientist and I do a lot of reading, time permits, I have a large group of researchers that advise me internationally. Also in Germany, we have an expert council which advises me every 2 weeks. And I have a similar group for hospital reform. I have a large group for this pandemic preparedness. So I'm in touch with scientists all the time, because as a scientist, I know enough about scientists that I also know what I do not know, and we underestimate how much we do not know and how much is needed in firm knowledge from scientific sources in order to come up with better policy solutions. This is number one. And number two, I think we have to be more honest about where we currently stand. In climate change research, it was often the case that, let's say, the news were provided in a nudging way, where we were pretending the situation was, as a matter of fact, better as it indeed is, because there was a general belief that if you, let's say, put too much negative news into the message, motivation will go away. I don't think that this is a strategy that will work, and it clearly does not work with policymakers. If you want to convince policymakers, you have to be blunt about the message. The message cannot be exaggerated, because for every message which is not really true or exaggerated, you lose many policymakers that will never trust you again. But on the other hand, the blunt news is what is needed, because otherwise things will not move forward. So these are the two, let's say, impressions I'm left with, let's say, 20 years in politics as a scientist. we need more science in politics, and we need to be blunt about the future. And these are two things that I would like to share with you. Coming back to the Institute and coming back to Rainer, I should say that Rainer Sauerborn is one of the people who, and we have known each other for 33 years by now. I think that Rainer Sauerborn was one of the people who, at a time when all of these topics were not really at the horizon, he was already providing such a comprehensive vision to everyone who was, let's say, in touch with him. So in that sense, I could not think of anyone who was better prepared to lead that institutions. And I think it was a privilege for me. I think we have been working together at Harvard for a couple of years, 2 or 3 years, but it was a wonderful time, and I've enjoyed our talks very often with a glass of wine in the late evening. But even at that time, and clearly at that time you were ahead of me, I was focusing on other issues in those days, more technical issues, but you were at that time already aware of what was to come 20 years later. So this is something I would like to share with the audience. Most likely this is also known to everyone who is around and has been privileged to be as a collaborator with you, a member of your institute. Let me end in wishing you all the best for the next 60 years of the institute. I would really hope for collaboration in the future. If the Pact for Pandemic Readiness materializes, institutes like yours are clearly asked to be, let's say, part of the initiative. I think that the Institute was ahead of its time. If you think about it, 60 years ago, these topics were outsider topics. Nowadays, they are in the minds of most people or many people, but it is professed in your institution at a level of excellency that is clearly academic leadership, and therefore congratulations to the celebration. Again, I would like to be in Heidelberg. It's not possible, but I will continue to follow your work, and I'm looking forward to our next personal meeting, Rainer. All the best wishes to the pioneers in the field that are currently in this historic room, and I'm looking forward to what you will produce in the future and to your work. Thank you for the attention.
Ja, du hörst am Applaus, du hast viele Knöpfe gedrückt. You have pushed many buttons that are very close to our heart. And yeah, let's intensify this collaboration. You see, this is the United Nations here at your service, if you like. And I'm looking forward to further exchanges. Thank you for finding the time. And now we leave you for your busy schedule. Thank you so much, Karl.
Thank you so much. All the best to you.
Bitte? Well, we are privileged to have our minister come to us, even if he doesn't come in person, but certainly he has us on his radar, and he is very like-minded. Fridays for Future. He's a social democrat, by the way, and very green in his heart. Not in his mind, not in his mind, in his heart. And he's a scientist. He's a real scientist. He knows his stuff. He is aware that there is something here to be cooperated with, and we should do this a little bit more forcefully. I say that to Till and to Joachim, who are following this agenda. And now we have the pleasure, und ich kann jetzt auch auf Deutsch übergehen, denn Gülçin hat einen deutschen Vater und eine türkische Mutter. Und deshalb bitte ich dich, Gülçin, jetzt dein türkisches Stück zu spielen. Nämlich, wir machen ja, we do global music and global health. And this is now by a German, Turkish, if you like, lady. Not lady, I mean, she's a lady, but she's the concert pianist of Turkey. And he plays preludes from Adnan Saygun. Gülsün, buyurun. Now, how do we manage the slides, the slide mouse, the telemouse? From there, there's something sitting there. Yeah, okay. So you please come to the lectern, and I have the pleasure to introduce Srinath Reddy from Delhi. He is a long-standing friend of mine. We have collaborated on several ways and conferences and projects and so forth. He heads the Public Health Foundation of India. Then, like Germany, India was late, sorry, I think you will agree, was late in developing an academic public health field. It was flourishing, by the way, in Germany in the 20s and before. Then Hitler took it away out of the universities into his epidemic preparedness in the worst case, into the internal ministry, Gestapo and all the rest of it. So to prevent epidemics during the wartime. So this is why Germany, after the war, was a latecomer to re-establish public health. And I was one of the, and Karl was one of the beneficiaries of 29 stipends for PhDs to go to Britain, to the States, to learn about epidemiology and about public health. And we were kind of seeds in many universities, and now we are back as a university. Public health is a field. And the similar history was also in India, and you chose another way. You created a foundation which is coordinating, and probably you're talking a little bit about this, coordinating 6 schools of public health in India, 6 campuses of one university, if you like. So it's my great pleasure to give you the floor, Srinath. Over to you. You managed the...
Yeah,
okay.
I found it. Whether I can manage it, I'll find out. Thank you, Rainer. Good evening, ladies and gentlemen. It's indeed a privilege to be part of this celebration. While listening to that enchanting music in this venerated hall of wisdom, it is difficult to think of threats to health security. However, that is where the world is now currently. Somebody should put the slides on. If they're not, I can manage without the slides. Is there somebody managing the IT? Otherwise, I'll speak without the slides, not a problem. Oh, great. Great. Thank you. Well, thanks, Rainer, for getting the slides on. Yes, it does. So I have no excuse now. Right. So in a world that seems beset with multiple challenges, the threats to health security are uppermost in most minds. Since early 1990s, the term health security has been frequently used in very many senses, but now it has even been further amplified in the context of multiple simultaneous challenges. At the population level, we recognize that there are pandemic threats, antimicrobial resistance, climate change, pollution, and conflict. At the individual level, these manifest in or aggravate non-communicable diseases, endangered maternal and child health, lack of nutrition security, mental health disorders and addictions, gender violence, lack of road safety, high-risk behaviors among individuals, and lack of financial security for health care. But the fact that many of these, which are seen either at the population level as the determinants and the drivers, or the manifestations in terms of individual maladies, are quite closely interlinked. And this is something that Rudolf Virchow had already pointed out several years ago in his report on the outbreak of typhus in Upper Silesia. Quote, "Do we not always find the diseases of the populace traceable to defects in society? If disease is an expression of individual life under unfavorable circumstances, then epidemics must be indicative of mass disturbances." Indeed, he said, mass disturbances of artificial culture. And we see now, in the example of pandemic infections, of which there have been many erudite presentations today, that these factors which are occurring at the population level are causing death and disease of a great magnitude at the individual level. And the virus that came in 2019 is still around as Omicron, traveling around the world. And there have been several other pandemic infections, as has been pointed out in the talks in this afternoon. And this is not because microbes have suddenly become malevolent towards human beings. It is because we have built conveyor belts for their transmission through our own actions. Indeed, David Quammen in Spillover says, quote, "Ecological circumstance provides the opportunity for spillover. Evolution seizes the opportunity, explores the possibilities, and helps to convert spillovers into pandemics." And that is exactly what we are seeing now. And these conveyor belts are essentially created by us through deforestation, which provides proximity between wildlife and human populations, often through captive bred animals, with deforestation being also accelerated by urban growth, expansion of agriculture, logging, extractive industries, a high consumption of animal foods, which the Honorable Minister just spoke about, wet markets with animal mixing, captive breeding of animals in factory farms, grain-fed animals which require agricultural expansion and in turn cause deforestation, travel of human beings which is now farther and faster than ever before for trade, tourism, education, or employment. But we also have displayed the arrogance several times that we can completely eliminate the viruses, vanquish them, and completely have a full victory over them, little recognizing that it is only smallpox in humans and rinderpest in animals that have been truly eradicated. And Joshua Lederberg, who won the Nobel Prize in Medicine and Physiology for his discovery of microbial genetics, has written in Science in 2003, quote, "Ecological instabilities arise from the ways we alter the physical and biological environment, the microbial and animal tenants, humans included, of these environments, and of our interactions, including hygienic and therapeutic interventions with the parasites. The future of humanity and microbes will likely unfold as episodes of a suspense thriller that could be titled Our Wits versus Their Genes." And that is the battle that's going on with multiple sequels now. But what COVID-19 has also taught us, that there is a huge amount of complexity in health, complexity in environment, complexity in many other systems, and these complexities interact to create further complexities, which we must discern, dissect, and then act upon. And therefore, we see, for example, the virus and its variants competing with the vaccines, transmission dynamics of droplets and aerosols, of drugs and non-pharmacological interventions, and issues like individual behaviors or group behaviors versus international cooperation, which again also has behavioral elements of vaccine nationalism. And of course, there are several unknowns. But the point is very clear that complexity does not permit dependence on linear models alone, that we need complexity science to unravel this and to respond to this. And again, we find a similar situation exists in terms of climate change. We see horrendous heat effects, both physical and mental. Incidentally, the tendency for interpersonal and intergroup conflicts increase with rising temperature. And we see waterborne diseases and water insecurity, vector-borne diseases, extreme weather events, exacerbated air pollution as the carbon dioxide dome descends, that also traps the polluted air closer to the ground. We are seeing climate refugees, increased risk of chronic diseases, impact on agriculture and nutrition security. And all this is encased in inequities which are exacerbated over time because the poor are the worst victims. In India, there were additional 40 million heat wave exposure events in 2016 as compared to 2012, a dangerous surge in the impact of heat waves on health. But the story does not end there. There are predictions for further increases, averaging 2.2 to 5.5 degrees centigrade in northern, central, and western India by the end of the 21st century. In terms of infectious diseases, as human beings lie listless and wilt in the heat, mosquitoes will become athletic, will climb to greater heights, and race to farther distances. They'll spread to new areas in India. Changing spatial patterns of diseases are seen, and malaria is now spreading into areas hitherto not frequented. There is a longer transmission window in terms of the annual calendar, and there is a shorter extrinsic incubation period. There was a talk on dengue today. In Kerala, the extrinsic incubation period is now as short as 9 to 14 days, and we are seeing a huge rise in dengue cases now. And when it comes to food and nutrition, we live in a world where the food systems are threatening the environment, and environmental degradation from a variety of sources is threatening the food systems. This will get worse if we do not change this dynamic. If you look at climate change through the nutrition lens, 40% of the world's land surface will likely experience altered climates by 2100. Up to 2050, agricultural output is projected to fall by 2% per decade due to the impact of climate change on crop and livestock production, while food demand is projected to rise by 14% per decade due to population growth and increasing longevity, urbanization, and poverty reduction. So the mismatch will be huge. But as has been pointed out today, again, higher production of staple crops will not suffice even if we do manage it, because there is also a huge deterioration in the nutrient quality of the crops. And the nutrient-rich crops are more susceptible to droughts, pests, diseases, and temperature fluctuations. Higher carbon dioxide in the atmosphere reduces the nutrient content of staple crops, and soil degradation also reduces the nutrient quality. Sub-Saharan Africa and South Asia are particularly prone to productivity losses because these areas have been shown to be already producing staples at almost the highest tolerable level of temperature, and as the Dean of Harvard School of Public Health said this morning, a 10% yield loss will occur for a 1 degree centigrade rise in temperature. But the quality of the nutrients also decreases. Protein, iron, and zinc when grown under elevated carbon dioxide levels. And this is not merely of scientific interest. This hits human beings in terms of poor nutrition. India already has challenges of malnutrition in many forms. But because of the zinc deficiency produced by climate change, by 2050, India would have 49.6 million new zinc-deficient persons. It will have 38.2 million new protein-deficient persons, and 106.1 million children and 396 million women would become iron deficient. And this is in a relatively young population where the demographic dividend of a population growth is anticipated to be an accelerator of global economic growth. And if this is going to be the fate, then the world will suffer, not just India. And if you want to see examples of the double jeopardy of climate change and COVID-19, in Sundarbans Delta of India and Bangladesh, in 2020, just as COVID-19 was beginning its rampage, Cyclone Amphan struck with disaster. The pandemic affected livelihoods as well as access to even available resources. And similarly, the cyclone blocked the access to available resources while destroying natural resources. And the UN report on disaster response basically said in their assessment of 2022 that the climate emergency and the systemic impacts of COVID-19 pandemic point to a new reality of dangerous convergence. So ecological sustainability has to lead to ecological security, and only there can we find human health security. Therefore, the health system must recognize and prevent and manage syndemics, because we are not dealing things in isolation. We're dealing with multiple events and illnesses occurring together. Provide comprehensive, continuous, connected primary care as the pivot of health services. Must combine public health functions with clinical care. Both are not separate, they're part of a continuum. Influence the social, environmental, and commercial determinants of health to align with the public health priorities, to develop capacity for health impact assessment of policies and programs in other sectors, and to promote appropriate use of technologies and ensure their affordability, to stimulate, advance, utilize science to serve health goals, because science is sterile if it lacks a social purpose, and policy will crumble on clay feet if it does not stand on the strong foundations of robust science. And again, this is not something that is original. We go back to Rudolf Virchow. He said again, quote, "Should medicine ever fulfill its greatest ends, it must enter into the larger political and social life of our time. It must indicate the barriers which obstruct the normal completion of the life cycle and remove them. Should this ever come to pass, medicine, whatever it may then be, will become the common good of all." Medicine has now become public health in its broadest dimension. And that's the role the schools of public health must play. To conclude, the spectrum of science is reductionist in content, but holistic in context. You may have beautiful colors of the rainbow, but unless they blend together, you will not get the dazzling brilliance of white light to show you the truth. Therefore, the role of universities is to create T-shaped individuals who have domain expertise of great depth in some areas, but also have transdisciplinary thinking and real-world awareness to build coalitions, partnerships, and to bridge complexity. Training of public health professionals, we need to craft competencies of change makers, because complexity matters, big data from multiple sources. Context matters, Bayesian analytics and models. Comprehension matters, mixed methods research, quantitative and qualitative. Caution matters, estimating uncertainty is important. Communication matters, clear, coherent, and consensus-building communication is the order of the day. Ladies and gentlemen, never before have we been so forewarned about the dire future that awaits us if we follow the present path to perdition. All the models about non-communicable diseases, climate change, pandemics, all of them have shown what the future might bring in terms of disaster. But also never before in human history have we been so forearmed with the knowledge and tools to alter that future for planetary health and human well-being. So it is a challenge to human intellect and enterprise as to how we shape our destiny. Public health must be the world's GPS to guide that journey through the complexity of change. As Simone Weil says, attention is the rarest and purest form of generosity. Thank you for your gracious invitation and your generous attention.
What a broad scope of mind and scope of presentation from Virchow to Kerala and back. Thank you so much, Srinath. And we try to create these T-shaped individuals. I see some already in the audience, T-shaped, very deep in one discipline, but very broad, like a tree. Very broad to understand multiple disciplines and so forth. It's now my pleasure again to welcome you to take the floor. And she wanted, of course, everybody knows, I introduced her this morning, Michelle Williams, the Dean of the Harvard Chan School of Public Health. And she wanted explicitly to address our students, master and our doctoral students. So that I'm very grateful that you take this focus, and the floor is yours.
Thank you, Rainer. You know, we were friends until you put me to speak after these luminaries. This has been just a tremendous day, but the last hour or so that we have heard the presentations have just been outstanding. And remind me to never accept an invitation to speak after my friend Srinath Reddy. That was a tour de force. Thank you. So I really wanted to take this opportunity to address specifically the students and the young scientists who have encountered in real time in your pivotal parts of your careers challenges and opportunities. And I'd like you to continue to look at the last 2 years of your training and experience and journey in public health and global health just as an opportunity for challenges and opportunities, and the role that you can play in preparing for a better, brighter future with greater global collaboration, cooperation, and that comprehensiveness that you've heard Dr. Reddy and also your rector speak to. So it's a pleasure again to be here and to have this opportunity. I know when you all decided to start your studies in public health, I'm sure you never imagined doing it in the midst of the worst public health crisis in a century. That the topics that you set out to learn about, be it virology, epidemiology, immunology, AI and machine learning, or the study of the social determinants of health, never did you imagine that would come so glaringly in focus during your times off campus and out of the classrooms. And so much of your interactions with your classmates and your faculty members would happen over video in a distance that you had not anticipated. As challenging as the times were, however, and as disruptive as the times were in your learning, I hope that on some level it has reinforced your reasons for choosing this path of public health and global health in the first place. Because this crisis has been the education of a lifetime for all of us. It's shone a light on so many of the global public health challenges that we face. And while it has kept us physically distant at times, it has also reminded us just how connected, interconnected, and interdependent we really are. That a pathogen in one country, just one flight away from infecting another. We learned that local supply chain issues have ripple effects on the other side of the world, and that financial, social, and physical vulnerabilities compound one another, and as a result, a threat to health anywhere is a threat to all of us everywhere. You know, today it's also clear, more clear than ever, that we need a more global approach to problem solving. We absolutely must confront the complexities that you just heard about in Dr. Reddy's talk with as comprehensive a set of solutions to the problems that we face. Our fate collectively has never been more intertwined, and so our solutions must be as well. In thinking about the last few months and thinking specifically about this conversation that we're having this evening, I thought a lot about someone who embodied the mantra of our working together. I'm sure many of you know that this year we lost a true icon in global health, Dr. Paul Farmer. Paul was a renowned physician and anthropologist who dedicated his remarkable and all too short life to improving healthcare for the most vulnerable people in the world. He dedicated his life to work in places like Haiti, Sierra Leone, and the Navajo Nation in the United States. And he did it with an enormous sense of empathy that came from embedding himself in the communities he served, so that he could better understand his patients' lives and their unique needs. Paul was extraordinarily skilled in driving change, even within some of the world's most deeply entrenched systems. In 2012, he talked about the secret to his success in a graduation address, and I quote, "With rare exceptions, all of your most important achievements on this planet will come from working with others, or in a word, will come from partnerships." Indeed, our greatest triumph in global health has always been collaborations, from the explosion of the vaccine development to the creation of institutions like the Centers for Disease Control and the World Health Organization. Paul Farmer knew this. He understood that no country or no entity has a monopoly on knowledge, that innovation must be shared, critiqued, and built upon, and that the best time to build alliances is before the crisis begins. His legacy resonates deeply with us today, and it's reflected in so many of the talks you've heard. So many of his life's work was reflected in the questions that you asked and the presentations from speakers today. In many ways, the global response to this pandemic has been marred, and we've heard this before, has been marred by underinvestment, siloed and conflicting approaches, and vast inequities, both within and between countries. But it also has been a shining example of the power of partnership. Across the world, unlike partners, all across the world, unlikely partners have come together to save lives, from producing and distributing supplies to bringing diagnostic tests to market in record time. You might remember that in the early months of the COVID-19 pandemic, we saw a flurry of research papers with authors from 2 or more countries. The greatest numbers came from 2 unlikely allies, China and the United States. Meanwhile, scientists from around the globe developed multiple vaccines in incredible speed. And international databases have allowed us to track outbreaks in every corner of the world. I'm going to tell you one story among many about the power of partnerships. And I'm sure that you know, that everyone knows by now, are well versed in the signs and symptoms of Omicron variant, SARS-CoV-2. Statistically speaking, many of you have probably had it yourselves. Unfortunately, being a public health expert doesn't make you immune to the highly contagious virus. And as you may have heard, even our own Dr. Anthony Fauci, who outran the virus for 27 months, it caught up with him a few weeks ago. But the story I want to share with you is about how the Omicron variant was discovered. It was discovered by a researcher in Gaborone, Botswana. Shikaleli Moyo is a director of the Botswana Harvard AIDS Institute Partnership Lab. The lab is a long-standing collaboration between Botswana's government and the Harvard School of Public Health. By the way, I should pause here and just say I loved when the minister referred to our institutions as lighthouse institutions. I will quote him forever for saying those, because for me in my own career, and I know it's true for many of you, your entry into public health and your devotion for public health is through these lighthouse institutions. And I just have to pause and say this, because the example that I will share with you about Sikaleli Moyo, his training and his commitment to the lessons learned at the lighthouse of the Harvard Chan School of Public Health became so critically important for all of us. You see, The partnership, the Botswana-Harvard partnership, has spent years investing in training and mentoring. And today, the partnership has now developed to a point where we have 350 employees working in Gaborone, all led by local researchers and staff. So when the pandemic began, the lab had the infrastructure and the technical know-how and knowledge to quickly pivot to test for and sequence the COVID-19. And in mid-November, just a short while ago, Dr. Moyo noticed an unusual pattern developing while sequencing the COVID samples, a number of the mutations that looked very different from the Delta variant that had been circulating for months. He quickly shared his findings with colleagues across the border in South Africa, and they too found the new sequence in their local samples. And together, they quickly alerted the rest of the world to this new highly contagious variant that had been found. That kind of transnational partnership must be the rule going forward. It cannot be the exception. We must make that story so normative that we don't have to talk about such stories again. That collaboration, partnership, sharing, and a commitment to global health be so normative that stories like this are not necessary. So at the Harvard Chan School of Public Health, we've had the opportunity to launch a number of new cross-disciplinary collaborations to spread and multiply this kind of speed. Early in the pandemic, we helped develop a partnership between researchers, technology companies, and global policymakers to collect and interpret COVID-19 transmission data. That data has expanded into a platform now called Crisis Ready. And this platform is designed to incorporate such data into local disaster planning around the world. We've also realized that we must build the bottom up. And so we established the Harvard Global Nursing Leadership Program with the goal of supporting, educating, and strengthening nursing and midwifery leaders around the world. And we've recently launched a partnership with the Vanke School of Public Health at Tsinghua University in Beijing. Our schools will share findings in infectious diseases and other international issues like antimicrobial resistance and climate change. And students from both schools will be involved in fields of research in the field in the US and in China. Imagine what would be possible if we could scale that kind of knowledge sharing, innovating, and local capacity building across the globe. Imagine if our two lighthouse institutions could really be brought to scale and work, as you all do, so transparently and collaboratively with global partners. That's exactly what we have to do. It requires us to seek out not only well-established international partners, but also emerging ones. It requires us to invest in places that have traditionally been ignored, or worse, places that are thought of too often as being the source of the problem rather than part of the solution. Because in this globalized world, a handful of rich countries cannot be the only ones with the equipment, the resources, the agency to sequence viruses or manufacture vaccines, or the creative talent that exists across the globe to bring about the discoveries that we need to solve the problems. The global scientific community must be exactly that, global. That kind of sea change in how we approach public health, that is going to be up to you all, up to you, the next generation of leaders in public health. I want to say that it's up to you to make sure that the lessons learned during this pandemic aren't quickly forgotten. I want you to be sure that your work isn't confined to a single discipline or to a single sector or to borders. Be that T-shaped individual that is generous, that is collaborative, that is creative, and most importantly, work across all of the sectors. Be that leader where you seek out and invest in ideas from all over the world, even in places where the conventional wisdom suggests that you're least likely to find them. What we do, and whether we do it together, will set the course for human health for the next century and beyond. I firmly believe that more than any other generation in public health, your generation of leaders, you're the generation that's ready to meet the challenges that you've been hearing about and talking about all day and living through. By choosing this field of public health at this time, all of you has chosen to run towards some of the greatest threats that we face in today's world. Instead of letting this pandemic deter you, you've let it motivate you, and that makes you truly remarkable. And it means that you are surrounded by your classmates who are also truly remarkable collaborators. My hope is that you'll continue to work together long after you leave this institution. And you've heard so many connections over decades of speakers working with each other. So even if you disband as classmates, you'll consider each other lifelong partners in a global health effort to improve health. The world has never needed you more urgently, and because of that, you've never had a greater opportunity to make a positive and lasting contribution to human history. With that, I'm grateful for your attention, and I thank you, and I'm here to work alongside of all of you.
Well, thank you so much, Michelle. And I want to pick on one of your remarks. You said big successes are only coming from collaborations, and I guess most of you would agree. But I would add something, and that's something controversial, because people say you should never get friends with business partners, or scientists should be dry, as somebody in Africa told me to be, with colleagues. And my life experience is different. I have had the privilege of having friendships, lasting friendships, decade-long friendships with people who I work with. And I wondered, I hope I don't forget some of them. Many are in the room, but I start with my doctoral supervisors. I don't know where you are, but you heard Alan Balmain from Scotland this morning. Where are you, Alan? Alan, are you here? Well, I will tell him. And then Peter Berman, but Peter is here, I hope, who supervised me in Harvard. There's Peter. Then from Africa, Bokar and Ali, lifelong friends for decades. From Sweden, Göran, and from India, you, Srinath, and I could go on and on. So I think that this friendship is also another ingredient, another booster rocket that propels science into the orbit. That's at least my little flavor to your remarks, or Paul Farmer's remarks. And now, since the BioNTech founders have cancelled or couldn't come, I take the liberty of two little program items. Only takes 3 minutes, don't worry. One is, I think that Jochen, the German form, of course, Jochen Diesfeld is watching us via live stream from his rehabilitation bed. He is 90 years, for those of you who don't know this, and he has been so sad not to be with us to celebrate here. So he comes tomorrow to the dinner by Zoom on his tablet from his bed. And I guess he's watching us now from his bed, also via his little tablet. So I think we should give him a roaring applause, and in the hope that he listens and sees us all. So to Joachim, to Jochen and his 19th birthday. And then I want to mention another person who passed away last year, and he was part of the DNA, or better, the soul of the Institute, Andreas Ruppel. And yeah. And from my children, he was known the Geigenmann, because he came to our house with his violin, and he taught me to play with him a certain piece, which I will now, trying to entertain you a little bit, also play with Naz, who we have seen yesterday. Naz and we unearthed it again yesterday, and we played a little bit. So it is daunting to be in your footsteps after you played here, but it's just a little amateur thing to entertain you. Of course, Naz is a professional, but I'm not. So 3 minutes. Schubert, Sonatine in D-Dur. Okay, thank you so much. My little contribution. Now it's the students' time, and they have prepared one for the master students, that's Afra, and one for the doctoral students, that's Lisa. A little, show who we are and what topics we work on, and they have prepared it in a PowerPoint presentation. Afra, I think you should go first. You want to do this with the micro or from there? From there,
okay. Good evening, ladies and gentlemen. It is a pleasure for me to standing here to this marvelous and sophisticated hall. And I believe that during the symposium before, we had already reflect, and some of the discussion maybe motivate us to maybe to translate systematic research evidence into something applicable. And for that, I also believe that some of our output is to bridge the planetarium and One Health concept and to achieve an equal approach for all of the population in the world. And to quote Dr. Bernard's statement before, looking at these marvelous terraces on our both sides is just like speaking about the diversity and the comprehensiveness of the research. So for that, please let me moderate on our session on this mini research showcase as a diverse and comprehensive thoughts on our fellow MSc student. Okay, so the first rule is if I present your slide, you are pleased to be stand up and explain about your research interests, about your expertise, and also about your thesis topic. Because I am standing here and I would like to start by myself. So I'm Afra from Indonesia. I am a public health by background, but my minor and major was in public health, in health economics and insurance. So there are my interests: health insurance, economic and financing, health policy and government, health system strengthening, non-communicable disease, and health technology assessment. And I am now currently gonna write my thesis with my supervisor is here, Manuela, and it's about healthcare utilization and insurance. Okay, so because not all of us were lucky enough to be to attend here in this room, so I would like to present some of my friends on behalf of some of my friends. So we have also in our student Pramila. She's from Nepal. She have a public health background, and she did some research experience with the Nepal public health. And then her thesis title is The Challenge Caused by the COVID-19 Pandemic Towards Controlling the HIV, AIDS, and Hepatitis in Prisons. And here, I believe in our room, we have Adarsh from India. Yeah, he is a biomedical engineer by profession. So Adarsh, please.
Hi everyone, it's such an honor to be amongst all of you. I'm Adarsh, I'm a biomedical engineer. I work for the National Research Mission and the Department of Health in my state of Kerala. My key interest areas are clean technologies, climate change mitigation and adaptation, disease surveillance, medical equipment management. Thank you. Medical equipment management, e-health, and telemedicine. I'm currently doing my research on the impact of technical solutions on the energy efficiency of hospitals in high-income countries. And yes, I'm looking forward to collaborating and building better together. Thanks.
Okay. Thank you. And next we have Shaila, also here, and she's a dentist and also a healthcare professional by background. So Shaila, please.
Dedicating me.
Yes, I am Shaila Akhtar. I am from Bangladesh. I am a dentist by background. For the last 1.5 years, I am working as a public health researcher, mainly for systematic and scoping review. And my main research interest is communicable and non-communicable diseases. And my thesis topic is effect of having a severely disabled child in the family structure and other normal children or parents in the family. It is also a mixed method systematic review. Thank you.
Okay, thank you, Shaila. Alice wasn't able to attend here, but I'm gonna give a brief introduction. She's an obstetrics from Brazil, and she's currently doing a research regarding the obstetric violence, a systematic review. She's currently, okay. And then in this room, we also have Ezgi from Turkey, who is gonna present herself.
Hello, everyone. I'm a pediatric dentist from Turkey. I'm into qualitative research methods and integration of oral health into primary healthcare. Thank you.
Thank you. And next we have Leslie.
Hello, good evening to everyone. My name is Maria Leslie Olmido. I am from the Philippines. My training is nutrition, and my thesis topic right now is on notions of responsibility affecting the vaccine uptake in the Philippines. And my previous work experience is with the Department of Health, and I'm doing health financing before, but now qualitative research. Thank you.
Okay. Yeah. Now we have Yodit. Is Yodit in this room? Okay, so I will speak. So she's from Eritrea, and she's a public health officer. Currently, she's working a thesis on the effect of the COVID-19 pandemic on routine child vaccination across sub-Saharan Africa, a scoping review. And then after that, we also have Lames El Hassan, who's also not in this room. She's from Sudan, and she has a bachelor in dentistry, and her area of interest are e-learning, blended learning for medical education in sub-Saharan Africa, TB, and disease related to immigration. And next we have Agrin from Indonesia. Agrin, please.
Okay, thank you. So my name is Agrin Zauyuni Putri. I came from Indonesia, and my background is a veterinarian, and fortunately, I'm only veterinarian in my batch. So my area of interest is One Health. Currently, I'm doing a thesis topic on strategic intervention for neglected zoonotic disease using One Health approach in Southeast Asia. And my past experiences was at the quality management in Harbin, China for 6 months, focusing on end-to-end vaccine viruses in avian influenza, and then also as a clinical practitioner. Thank you.
Okay. We also have Yan Fei, who is not in the room. She's from China, and she has a medical data analyst internship and also a psychiatric editor in the field of mental health. And she's currently writing a thesis in mental health and well-being impacts of the SARS-CoV pandemic, a cross-sectional analysis among adults in Zambia during the 3rd and 4th wave. Okay, we also have Precious. He got his bachelor in public health, and currently he's doing a research in mental health impacts of COVID-19 among adults in Zambia. And Lina, is Lina? Yeah, please.
Hello, my name is Dina Al-Marhali. I came from Yemen, from Aden City. I am a clinical pediatric, and I'm a student here also, and I prepare a topic about all governmental approach and all of society approach against COVID-19 in European countries. Thank you.
Okay. Next, we also have Mio in this room.
Good evening, everyone. My name is Miu Chi. I come from Myanmar. I am a public health professional. Before I came to Heidelberg, I studied Master of Public Administration because I thought health is more related to the broader context. So currently, my thesis project is related to the geospatial analysis because I am interested in interdisciplinary health research, and my future career goal is also related to interdisciplinary. Thank you.
Okay. We also have, sorry, we also have Janet from Kenya, which have a key area of data analysis and standardization, research, health system strengthening, violence against children, and consultancy. And her current research is on understanding the management and support practice of violence against children in Kenya. And we have Agustin Alejandro Alcantara, who have a professional experience in WHO, WB, and EIB. His thesis is what can be learned from the COVID-19 pandemic. We overlook the room fires and watching the building burn, a Western Hemisphere perspective. Okay, and then we also have Asma in this room. Asma, please.
Yeah. Hi everyone, my name is Asma Ahmed. I am from Egypt. I'm a pharmacist by background, and my research interest is the sexual and reproductive health, immunization, and also health informatics. And my research is about research about the impact of misleading information around COVID-19 vaccination and how this affect the people's willingness to take the COVID-19 vaccination in Yemen by using social listening approach. Thank you, Afra.
Yeah. Okay. Next, we have Mohammed, was not in this room. He's from Yemen, and his area of interest are health system, health information system, and mental health promotion. He's currently writing a thesis in the magnitude of the health and health service problems linked to COVID-19 in Yemen. Next, we have Ariana, who's also in this room. Ariana, please.
Hello, everyone. I'm Ariana Amaya. I'm from Venezuela and Colombia. I'm dentist from background. My biggest interest is promoting inclusion of dentists and oral health into global health. And actually, currently, I'm researching about oral health in patients population in Colombia and a perspective from the social determinants of health. Thank you.
Thank you. And then next we have Samasti, who's not in this room, but she's have experience as an international consulting in companies, and her areas of expertise is in health and development research, monitoring and evaluation, accountability and learning, and gender equality and social inclusion. And currently she's working a thesis also regarding exploring experience and attitudes on the collaboration between research and practice in global health, a qualitative study among German stakeholders. And then next we have Ayman, who's also in this room. Ayman, please.
Yes, thank you very much, Afra. Hi everyone, my name is Ayman Hadi. I am from Yemen, and I work with WHO in immunization program, and my interest is system strengthening, health system strengthening, immunization, and quality improvement. That's why my research topic is evaluation of sustainability aspects of quality improvement projects in Yemen. Thank you very much.
Okay, thank you, Ayman. Next, we have Dalanda. She's from the Gambia, and she has a nursing background. Her current research interest is One Health, neglected tropical disease, health system strengthening, communication disease, surveillance and response strategy. And currently, she's writing a thesis on the assessment of One Health in ECOWAS region as a measure through global health security framework. Okay, last but not least from our slide, it's Annie. She's also not here. She's a nurse by background. Her field of interest are health economics, quality improvement, management and communicable disease, bridging research to policy making, and global health governance. So that's all from the MSc side. To expand our current and create more spaces on these research terraces, I believe that I will hand this to Lisa or Jessica on continuing and lighting all of the lighthouses. So please let thank you very much for your attention.
Afra. What a power woman. What a power woman. My God, this is the future. Now, we have people waiting outside to give us the last musical, so we cut the PhD presentation a bit short. We have more than 100 PhD students. We want just to give you some flavors, and it's only 3 minutes. You promise. Jessica, thank you.
Hi, so I'm Jessica, not Lisa, but that's fine. So in the interest of time, and because I think nobody wants to be listening to everybody, even though everybody's doing amazing research, so I think we have about 100 or more doctoral students at the Heidelberg Institute of Global Health, covering loads of different topics, not only climate change, but also HIV, nutrition, malaria, dengue, I think probably also, you name it, we do it. We do every combination of the above, and research, using research methods, quantitative, qualitative, mixed. So I think we have an amazing group of very international and diverse students who are building on the collaborations and the connections that our predecessors have built for us, and we're really grateful that we can use the space to build on our research and follow our dreams. And as you said before, Michelle, it's a great time to be doing research in global health. So yeah, I'm going to keep it short and enjoy the rest of the evening. I think over to the choir now.
Thank you. Good. Well, with women like this, the future is, I'm not worried. Okay, and now we have a little musical surprise.
Where do you get the power at the end of the day? My God, thank you so much. Really great, thank you. Woo! Vielen Dank. Ja, mit 5 Männern habt ihr... So. For those of you who haven't heard the story this morning, they came also to perform in the morning. There are 2 choirs, one from Heidelberg, Germany, and one from Heidelberg in South Africa. And the one choir leader was Tabang, obviously the very dynamic director, and the lady who was here was the German part, and they go on tours and they visit each other, and he's now a conductor in training, and not in training, in how do you say that, to teach our folks to sing, and with a purity. I hope you have appreciated the purity of a cappella songs. It's really an achievement. So Heidelberg to Heidelberg partnership.